खोल आवाज की बोला मैं हेलो हेलो 1 2 3 माइक चेक हेलो चेक हेलो 1 2 3 हेलो हेलो 1 2 3 माइक चेक हेलो हेलो माइक टेस्ट 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 हेलो 1 2 3 माइक चेक हेलो हेलो 1 2 3 माइक चेक हेलो टेस्ट माइक टेस्ट हेलो 1 2 3 हेले 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 1 2 3 माइक चेक हेले टेस्ट 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 माइक चेक 1 2 3 हेलो माइक चेक माइक चेक माइक चेक 1 2 3 माइक चेक माइक चेक माइक चेक माइक चेक माइक चेक माइक चेक 1 2 3 माइक चेक माइक चेक 1 2 3 बालू चेक
Hello, testing 1, 2, 3, mic check. Hello, hello, testing 1, 2, 3, mic check. Hello, testing 1, 2, 3, mic check. Hello. Hello, testing 1, 2, 3, mic check. Hello, जी, hello. 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 Hello.
Bismillahirrahmanirrahim. Assalamu alaikum. I think we'll start our session. Today's session is about panel discussion and case discussion. So in this session, we have this time combined the two things together. So before calling on the first speaker, I would like to invite our panelists. So our first panelist is Professor P.S. Meher. He's the outgoing president of Pakistan Glaucoma Association, and he's the current president of Ophthalmic Society of Pakistan. So thank you very much, sir. Sir, audience aa jayega. Our second panelist is Professor Syed Imtiaz Ali. He is the founding president of Pakistan Glaucoma Association. Thank you very much, sir, for joining us. So the first presentation is by Professor Sadia Farooq. She is going to present her first case, and then we'll have a discussion with our panelists.
Thank you very much, Aisha. Right. So, sometimes small mistakes lead to big disasters, and the idea is to look back and learn from those mistakes. So my case presentation is on angle closure disease. After the case discussion and some discussion, I have some guidelines as well that have been updated recently regarding management of angle closure glaucoma. So my case presentation is on angle closure glaucoma, right? So after the case discussion, there will be some discussion, and then I have some guidelines to show up. A 49-year-old male with hypertension episodes was admitted because of hypertension and also complained of decrease in vision in left eye for last 2 days. He was a known case of left amblyopia, known diabetes, and morbid obesity. Very difficult examination as he was squeezing his eyes. Visual acuity in the right eye was 6/9, corrected to 6/6, and the left eye was 6/36, corrected to 6/12. He had bilateral shallow anterior chamber, sluggish pupils, full extraocular movement, intraocular pressure were 21 on the right side, 22 on the left side with GAT, no diplopia, right normal disc margins, normal vessels, because his disc was absolutely normal and the pressures were fine, so he was reassured, and he was asked to come for B scan to rule out drusen's. This is a picture of the disc on the right side and the left side with full disc, no cupping, and normal RNFL, showing green in all quadrants and in line graph. He was followed up at 2 weeks. Yeah, he had poor hygiene, blurred vision in left eye for 2 to 3 weeks, and visual acuity in the right eye dropped to 6/18, and the left eye dropped to light perception. He still had shallow anterior chamber and unable to do gonioscopy, and this time the pressure in the right eye was 22, on the left side it has risen to 40 millimeter of mercury. Sir, he was seen in IPD, so no refraction was done. But he was not wearing any glasses. Yeah, he was not wearing any glasses, sir. Yeah. Ji, sir. He was diagnosed with a case of acute angle closure glaucoma in left eye, and he was started on oral and topical treatment to control the pressures. He was reviewed in 1 hour, and the pressure has dropped down in the right eye to 18, on the left side to 22. He was advised Maxidex eye drops 4 times, pilocarpine 4 times, and dorzolamide and iopidine that was available there. So this is an alternate, here is alphagan. He was booked for laser peripheral iridotomy. Patient didn't come up for follow-up for the laser appointment. He missed that at the 3 weeks he was given, and he was reviewed at 12 weeks as a follow-up case of acute angle closure glaucoma. Vision at that time on the right side was 6/9, left eye was barely counting finger, pressure was 32 on both sides. This time gonioscopy was done by the consultant, and it shows angle closure grade 0 to 1 in all quadrants in both eyes. At that time, he made sure that the YAG laser was done in the same setting. Pilocarpine was instilled, bilateral YAG laser PI done, and he was continued on Lumican and iopidine, and then reviewed at 1 week post-op. Post-laser PI, as he was in these anti-glaucoma, the visual acuity came down to 6/6 on the right eye, still counting finger in left eye. He was feeling comfortable. Pressures were 16 on the right side, 18 on the left side. On conioscopy, they could view the trabecular meshwork in all quadrants with no peripheral anterior synecdoche, and he was continued on the anti-glaucoma drops. Steroids were tapered.
सादिया आपकी आवाज़ फिर कम हो गई है भाई आवाज़ बढ़ा दें
Peripheral anterior chamber OCT is, it shows peripheral anterior synecdoche. This is the OCT anterior segment of the left eye of the patient. At 16 weeks follow-up, the patient was seen in glaucoma clinic, and the vision was right eye 6/6, left eye perception of light, intraocular pressure over right eye 18, left eye 32. The cup disclosure was 0.4 to 0.5. Conioscopy shows still iridotrabecular contact in all quadrants. That was not opening on indentation. So impression was taken as he has right synechial angle closure glaucoma, left absolute glaucoma, and he was given trial of pilocarpine before any definitive treatment for the right eye. Patient was counseled that there is an irreversible loss of vision on the left side, and all we are now concerned is for the right eye. And for the left eye, we were doing pain management only. Then patient was followed up at 21 weeks. The vision was same. The pressures were controlled on the right side, and angle was found open this time on conioscopy, and he was comfortable, so he was advised to continue on medical treatment. This is the OCT at 21 weeks. OCT of anterior segment that the arrow is showing that there is some angle recess was visible even on OCT anterior segment and on conioscopy. The RNFL is showing a defect in the ganglion cell and superior and inferior RNFL thinning. And at the same time, the patient's right visual field is showing inferior arcuate scotoma. On the left side, it was total loss of visual field. So the points to ponder is, this is a case from a developed country where we have a setup of NHS and still things were missed. This is just to take an example how we can easily miss things even when we have everything available there. So the points to ponder is what was missed in first examination, what was missed initial advice, what change in strategies would have helped prevent vision loss in left eye, and what's the definitive safe evidence-based treatment for the right eye now.
Thank you very much. Can I just ask you one thing? What was the presenting vision of the left eye, presenting vision on the first day of presentation?
Yeah, it was good.
It was good.
It was good. He blurred vision in the left eye. He had complaint of left eye vision only, so it was 618.
618.
618 almost. He was
So
not.
over the period of 21 weeks, this went down to PL only.
Even in the first follow-up at 3 weeks, it dropped immediately to perception of light when the pressure rose, and it never came back.
Okay, so now the case is open to discussion for the panelists. Can I ask Professor Meher to give his comments?
एक्चुअली आपकी ट्रीटमेंट तो बिल्कुल सही थी और उसको आपने LPI के लिए एडवाइस किया which was a good one. Only problem was the patient did not attend. So this is an issue, these patients, as soon as if the pressure is very high, you control it medically, and then best thing is to do LPI in these cases. Once they settle down, doing the cataract surgery is very difficult phenomena in our case. We understand what Eagle trial and all those trials are saying, but in real life scenario, when we advise patients, पहला सवाल ये पूछते हैं कि cataract तो नहीं है, तो हम कहते हैं cataract नहीं है, लेकिन उसको 9 out of 10 people will not agree to my advice कि हम उसकी lens निकाल रहे हैं, ठीक है जी? And then other option is that you look at the patient, if he's not coming regularly, maybe safely you can do the glaucoma surgery. ठीक है, ग्लूकोमा सर्जरी कर दें अगर कुछ नहीं है उसको तो आपको चॉइस ये है कि लेज़र एंड देन यू ऑप्ट फॉर द सर्जरी. थोड़ी सी भी अगर लेंस कैपेसिटीज है लेंस निकाल दें उसका. That's the advice.
Dr. Sadia, one was the pachymetry and the left eye amblyopia 612. Is the 612 is amblyopia?
It was less vision than the other eye, so the cause of this decreased vision initially was labeled as left amblyopia.
Then you said you were unable to do the gonioscopy. In such cases, come give the mannitol and the patient, the corneal edema subsides, and then do S the gonioscopy. Then keeping the age in mind is 49. Yes?
Yeah.
He's pressed by, what is the need of laser PII in of the tablet? Why don't you say give just a phacotreb or remove the lens? Because the PI, there's a complication, and then you put on cold drugs, the pilocarpine. Is it available, pilocarpine?
Available, yeah, it was available in UK, yeah.
Achha, it's
So
for
this is from
it's not
NHS
available
case,
here.
Yeah,
ठीक है?
definitely.
So-
So this is what we'll be going to discuss later on. What are the different options to treat if we do not have pilocarpine and if the patient is not taking medicine? So what is the definitive treatment for this patient?
But
So
this
you are
pa-
suggesting we should do phaco, trab in this patient?
There is presbyopic, the 6 region go per lens extraction. Do the lens thickness what it is. At the end, it will be the lens extraction. And then have the anterior synechiae and give the deepening technique with hyaluronic acid. He will be safe. Otherwise, visits and the PI blocking and these
So
these things.
which eye you talking about, left eye or the right eye?
Right eye. Left eye is the absolute. For absolute glaucoma, still I would prefer, you will be laughing, but I would prefer go to remove the lens and if possible a trabeculectomy. Because there are the pain. Because there is no neovascular, the angle is, there are no vessels, so it will be safe. Okay. So 49 age is important. If it was before 40, presbyopic, then you have very good IOLs and all are very good surgeons. And the anterior segment OCT was important there. And gonioscopy, at that time you should, acute है ना, तो उसकी corneal edema etc. इसको कर लिया करें. So summary is right eye, cataract extraction, peripheral anterior deepening techniques, and for left also go for surgical intervention to avoid the drugs. क्योंकि उसकी अपनी वो complications वो है ना. Thank you.
I fully agree
Okay, sir,
with you.
thank you
So
very much.
Ben's first
I
in
would
angle
like
disease.
Professor Imtiaz to add in anything in this.
वो जब आपने आयोडीपिन का जिक्र किया तो मैं समझ गया था कि ये पाकिस्तान वाला केस नहीं है. So what I was wondering is कि if we had this case presenting in an outdoor in Pakistan, what would we do? I think यहाँ पर ये लेज़र वाला और ये का टाइम नहीं था, उसको मैनिटोल लगाते 2 दिन पूरी प्रेशर नीचे ला के और उसकी ट्रैप कर देते या कंबाइंड एक्सट्रैक्शन जैसे कह रहे कर देते.
So this is why we are discussing it here. So I'm just giving as an example here that we can lose vision in one eye easily if we do not take it seriously and we do not follow the guideline.
Same
So this is what we'll be later on seeing. So I fully agree. So we should have a definitive treatment for angle closure disease. So if not taken, decisions are not taken in time, we can lose vision in one eye.
तो पेशेंट का भी गलती थी ना, वो गायब हो गया था.
Hanji. Although it was a free treatment, but still they take it lightly. It's not up to them. So can we move on to the guidelines?
Yes, please.
Yes, thank you.
And sorry to interrupt, can I invite Professor Nadeem Hafiz Bhatt on the stage as a third panelist?
So management of PSCG depends area-wise, depends where we are living, zone-wise, and at the same time depends on the stage of the disease as well. Whether we are seeing an acute or chronic patient, medically controlled, uncontrolled, we have patent PI, lens changes are there, or peripheral synechiae are present or not. A number of options are available starting from observation and then up to lensectomies, MEGs, trabeculectomy. So let's see what the evidence says about it. EGS guidelines published in 2020 says that we must manage acute angle closure glaucoma initially by lowering of intraocular pressure and then, whenever possible, consider laser peripheral iridotomy as a first-line option. It should be done in the affected eye, and remember to do prophylactic laser peripheral iridotomy in the other eye. So what we have seen in this case is that patient was booked for LPI. In fact, it should have been done in the same sitting rather than taken it lightly because pressure had dropped down, and probably this would have saved the angle permanent closure in the left eye. EGS guidelines further stress that after the laser peripheral iridotomy, treatment doesn't stop here, and then we must move on to the definitive treatment of angle closure depending upon the mechanism of it. OCT anterior segment and the examination can help us to know what is the type of the mechanism. If it's pupil block, LPI followed by lens extraction, that we'll see later on why it's needed. If it's a plateau iris and the crowding is in the angle, LPI can just overcome pupil block only. So the LPI for peripheral or the plateau iris or the crowding of the angle, laser peripheral iridoplasty or lens extraction can help. And if it is lens induced with a large lens in the eye, then the lens extraction is the definitive treatment. If we do not follow this and if we do not do the secondary management, sometimes patient may go into the attack of angle closure glaucoma again. Some of the RCTs have compared the efficacy of different mechanisms of treatment, phaco versus peripheral iridotomy. So this RCT has shown that laser iridotomy was not the sole treatment that was effective. So 1 year after laser PI, 80% of the PACs still had gonioscopic residual angle closure. Mechanism could be peripheral anterior synechiae, plateau iris, or high lens rise. And cataract surgery was effective to resolve completely the residual angle closure after iridotomy and lower intraocular pressure. What's the role of iridoplasty if we have crowding of the angle? So iridoplasty is basically firing argon laser burns 500 micron spot, 200 milliwatt in the peripheral to reduce the hump of the iris, and it opens up. This is one of the RCT comparing iridoplasty versus medical treatment. Has shown that iridoplasty does help to open up angle, but it doesn't lower intraocular pressure because the trabecular meshwork, it has no effect on it. And this Cochrane review states that it may not be better than other treatments for chronic primary angle closure, and sometimes unwanted effects may be seen because we are directly firing laser on the iris with side effects of inflammation as well. EAGLE trial has confirmed the efficacy of lens extraction in primary angle closure and primary angle closure glaucoma. And to have an idea what type of, in which patients lens extraction would be effective is OCT anterior segment helps us in it. So a line joining the scleral spur, if the center of this point is then, it meets with the corneal endothelium, and one third of it, or more than one third of it, is occupied by the bulge of the lens. It means it's a large lens pushing into the anterior segment that is crowding or bulging the angle as well, and removing the lens will be effective in reducing the crowding of the angle. What about trabeculectomy, the conventional surgery? What is the role of it in angle closure disease? So this is one of the RCT comparing phaco versus trabeculectomy in medically uncontrolled chronic angle closure glaucoma without cataract. So TRAB is more effective in reducing dependence, but it is associated with more complication. 1/3 of the TRAB group needed cataract surgery, 1/5 of the phaco group needed TRAB. So if possible, we should avoid plebin, PAC, and PSCG because the phaco alone is almost as good. If done initially, we have a high risk of complication in acute angle closure glaucoma, especially if it's a small eye, and it should ideally be reserved as a second-line treatment. So this is a reference from IKML. But the problem is sometimes phaco doesn't lower intraocular pressure in all cases of PSC and PSCG, and probably this is due to residual peripheral anterior synegy. So what's the role of GSL, goniosynechiolisis? A lot of discussion has been done on it. So sometimes phaco alone is enough, and but sometimes if we have peripheral anterior synegy and we haven't any idea on the chronicity of the case, then sometimes phaco is not enough. Doing phaco with GSL is not a difficult thing. It's almost as safe as phacoemulsification alone. If you look at the guidelines of Royal College, these were published in 2020 in the management of angle closure glaucoma. It states that GSL has been shown to have no benefit and therefore should not be carried out, but the evidence is moderate to weak. And then later on, we have a meta-analysis that is published on GSL in 2024, and it has shown that it was effective in the hand of many surgeons who have combined it with phacoemulsification. So why we have a difference of opinion? GSL, someone is saying it is effective, someone is saying it is not effective. If we look at the changes that occur when we have peripheral anterior synegy, the idea is probably iris stuck to the trabecular meshwork damages it as well. Histopathologically, the TM and Schlemm's canal in primary angle closure glaucoma was found to be damaged. So even if the synegy were opened, the TM is not working or it's not functioning. So is it possible if we just remove the diseased trabecular meshwork as well, that can help? And this leads to this recent RCT, that's phacogoniotomy. So phacogoniotomy is doing phacoemulsification, doing goniosynechiolisis, and then removing the portion of diseased trabecular meshwork. So now the aqueous has direct entry into the canal of Schlemm and bypassing the diseased trabecular meshwork. It was compared with phacotrabeculectomy in advanced angle closure disease. And they have found on this multi-center RCT that phacogoniotomy was non-inferior to phacotrab. So if we just compare how long procedure phacotrab is, and if we are seeing non-inferiority of phacogoniotomy, which is a simple procedure, and it is like shorter surgical time, lower post-op complication, fewer interventions, and better quality of life compared to those treated with phacotrab, we should always consider it as an option in those patients in whom we think it should be done first before we consider a pleb disease. So gonioscopy is critical to diagnose angle closure in time. Irrespective of the mechanism, there is always role of laser peripheral iridotomy. Pylographene does help reverse angle closure. Post-laser, there is always need of more definitive procedure, and evidence supports phacoemulsification, phaco-GSL, combined with removal of diseased TM by incisional or bypass mix, if chronic and not sure of time, as a definitive procedure. So thank you very much for your time.
Thank you very much, Professor Sadia. It was a very interesting case and highlights the importance of early diagnosis in angle closure glaucoma. Our next presenter is Professor P.S. Meher. He's going to present our second case.
my presentation. There's no easy answer to these kind of cases, you know. आपके पास choice है, आपके पास PI तो करें उसकी laser से, and then you can have a trabeculectomy, you can have combined, you can have goniosynostomy. तो आपने phacogoniotomy, तो you go around the thing, you know, because सिर्फ lens remove करने से अगर angle बंद है, it doesn't solve the problem. So you have to do something with the. The only thing is कि trap will bypass all these things because you are making other channel, you know, but angle तो उसमें बंद रहेगी. So you have to find out what is good for the patient and go for it. So that was very good.
I remember, since I think you were also there a decade ago. In this sad case is 5I, GHI, capital I. Is there is inflammation 1I, second there is intraocular, the 2I. With the 3I go with IV line for IOP, and the 4I go for radiectomy, and the 5th I you go the intraocular lines. This I remember a decade ago in Lahore somewhere. There's 5 eyes in eye angle closure glaucoma eye. So you should follow this pass 5 eyes.
Thank you, sir.
So after Sadia's an interesting case, मैं आपको ये case दिखा रहा हूँ. Now this is a lady, 46 years of age. She came to our glaucoma clinic for second opinion, and her problem was less decrease in vision in the left eye. She has no significant medical surgical history, but she has got family history of glaucoma. Her corrected vision was 6.6, so you can see -4 diopters in the right eye, and almost the same in the left eye. Anterior segments are normal. IOP, 14 millimeters of mercury in her both eyes, and this was measured at 9 o'clock in the morning. Angles were open, Schaeffer's classification, grade 3, and you can see the central corneal thickness, which is 486 microns in the right eye, 490 microns in the left eye. This is her fundus pictures, and I'll give you a little bit of magnified view. So, what can you see? Apart from के ये कप है इनका ये है rim, I thought was healthy, but the problem is that she has got a atrophic area here, so that was a little bit confusing. But यहाँ पे ये है. She has got 2 splinter hemorrhage present on the disc margin there. So we did the RNF analysis. This is the OCT in the right eye, and that's the OCT in the left eye. So she had a, you can see, to compare that with the other eye, decrease in the RNFL thickness. That's the fields, normal in both eyes. So, is this a normal tension glaucoma? And by the way, because she was referred from somebody else, they already did a MRI brain, and also she had a carotid Dopplers. They both are normal. मैं अब क्या करूँ इसका?
इलाज.
So what shall we do next to make appropriate diagnosis?
Sir, I would like to ask Professor Nadeem Hafiz Bhatt to
Okay,
comment on
panelist.
this.
वो जैसे कह रहे हैं ना कि मैं क्या करूं, तो बस इसका यही है कि सोच विचार ही हो सकती है. Anyway, such kind of cases are seen sometimes, and मेरे पास ऐसे भी कुछ पेशेंट्स हैं जिनकी इससे भी ज़्यादा कप डिस्क नज़र आती है, और पिछले कई सालों से उनकी OCTs भी नॉर्मल हैं और विजुअल फील्ड भी नॉर्मल है. एक एंड तो ये है, और दूसरा एंड ये है कि चेंजेस आनी शुरू हो जाती हैं. यू हैव टू फॉलो देम अप. और बाकी इसका वर्कअप तो कंप्लीट है, और उसके बाद भी यू नो द चेंजेस आर देयर, सो यू हैव टू ब्रिंग द प्रेशर फर्दर डाउन. आप और क्या कर सकते हैं?
Professor Imtiaz.
So we did this.
I
We looked at patients' IOP throughout the day, and very interesting. You can see here, and it went up to 26 millimeters of mercury in both eyes, and then stayed there. Okay, so this patient does not have a normal tension glaucoma. So yesterday somebody was presenting a normal tension glaucoma. महमूद कर रहे थे, तो मुझे रात को खाने पे गए ना, तो किसी ने पूछा कि कितना नॉर्मल टेंशन ग्लूकोमा है, लो टेंशन ग्लूकोमा यहाँ पे कॉमन है. तो मैंने उनको जवाब दिया कि पिछले 15 साल में इन माय प्रैक्टिस आई हैव सीन ओनली 2 पेशेंट्स, thoroughly investigated, and otherwise I don't see them. Maybe there's a difference in the locality. कराची के पेशेंट हैं और पंजाब के पेशेंट हैं, यहाँ पे नॉर्मल टेंशन ग्लूकोमा ज़्यादा है, but that wasn't it because we don't do this. So ये इसका प्रेशर है. So patient has got early primary open angle glaucoma. This is what we call as a pre-perimetric. So what are the risk factors? Do you treat this patient? So we look at the risk factors. What are the risk factors? Raised intraocular pressure, age more than 40 years of family history of glaucoma, patient is myopic, and she has got thin corneas. So treatment, so we offered her a treatment. But what is the significance of splinter hemorrhage that I showed you in the early photograph? Now, these are mostly associated with NTG, normal tension glaucoma, but they also been described in primary open angle as well as primary angle cruciate glaucoma. They indicate the glaucoma progression and enhancement of glaucoma treatment, usually precede neuroretinal rim changes and visual field defects. But apart from the glaucomatous changes, there are other causes of splinter hemorrhage. I have given you the entire list. You can see papilledema, neuritis, all of these can also give rise to this thing. So it's not only the glaucoma that we are looking at, but there are non-glaucomatous causes, mostly vascular causes, where you see this. So we put this patient. I did not have a SLT at that time, otherwise I would have offered SLT in this patient. So we advised her that to use letonopras, 1 drop, both eyes, at night time, 9 to 10 p.m., and we brought her back at 1 month, and you can see pressure came down to 11 millimeters of mercury. Now this is throughout the day. So we looked at pressure at 9 o'clock, and then we bring her back after 5, 6 o'clock in the evening, and it was the same. And then this is the subsequent follow-up, and the pressure has never gone beyond this thing. So now I got SLT, so I was asking this lady, can I do the SLT, get rid of your thing? She said, no, I like letonopras. I said, why do you like it? He said, because my lashes has gone, and but she doesn't have. I can give you the pigmentation around the eyes. She says, so far I have no pigmentation, only the long lashes. So I'm very happy. And she was asking, what is the effectivity of SLT? And we discussed with her, and she said, no, I want to stay with letonopras. So she stayed with letonopras. So what I want to emphasize is the role of phasing. Now, phasing of intraocular pressure in glaucoma is important because IOP is not a static value. It fluctuates throughout the day and night, and these fluctuations, known as diurnal variation or nocturnal variation, can significantly affect glaucoma diagnosis and management. So why phasing of IOP is important in glaucoma? You detect IOP spikes, understand true IOP burden, identify progression despite normal IOP, and then you want to evaluate the treatment efficacy. So you think patient has got only 20, 21 pressure, and you maybe opt for beta blockers, but when you see, is going almost late 20s and 80s, then you are thinking in those terms as a medical treatment where pressures can be significantly reduced. See, and some medication are more effective at certain times of the day, because if it's beta blockers, you know that the beta blockers has almost no effect on the IOP and aqueous production at night time, so you want to either use them in combo or you want to use prostaglandin analog. So the phasing helps assess how well treatment controls IOP over 24 hours, not just during the office hours. And that's the way you can tailor the patient's management. So it helps you guide the timing of medication, dosing, and whether to escalate treatment, laser or surgery, and it determines if patient may benefit from medication targeting nocturnal IOP and like a prostaglandin analog. So what happens if you don't? So I got morning and evening clinic, so I take the liberty of shifting patient from morning to evening. But say sometimes you see that I only see patient in the evening, what you do? You do that. So this is the water drinking test. It's a provocative test as used in glaucoma management to evaluate the outflow facility of aqueous humor, and it detects the fluctuation in IOP that may not be apparent during the routine office measurement. And the purpose of water drinking test in glaucoma is it assesses the IOP spikes, evaluate outflow facility, predicts the IOP fluctuations, and test the treatment efficacy. And how do you do the water drinking test? You have to have baseline IOP measurement, and the patient drinks about 800 to 1,000 mils of water within 5 minutes, and then IOP is measured at intervals, that is 15, 30, 45, and 60 minutes after the water ingestion. A rise in intraocular pressure of more than 5 millimeters from baseline is generally considered significant. The patient with poorly controlled glaucoma or reduced outflow facility will show higher and more prolonged IOP peaks. What is its clinical relevance? It helps tailor the treatment plan based on peak pressure and may predict risk of disease progressing over office hours where the IOP seems to be controlled. So this is the clinical correlation between phasing and water drinking test. and its use in the practice. So studies have shown that water drinking test can predict IOP peaks seen in phasing, especially in untreated or poorly controlled glaucoma. And use in practice, water drinking test may serve as a surrogate for full day phasing when the latter is not practical for you. The patients with high IOP will respond to this test, showing similar peaks during the phasing. Both are useful for detecting IOP variability, a known distractor for glaucoma progression. So clinical implication, identify patient with large IOP fluctuation can guide you treatment, monitoring progression and cost and efficacy. And the take-home message, understanding that IOP fluctuation is critical in glaucoma management as pressure spikes can contribute to optic nerve damage and disease progression. Phasing provides a comprehensive view of IOP variation throughout the day or night, but can be resource intensive. And WDT, water drinking test, offers a practical and efficient alternative, mimicking physiological straits to assess outflow facility and predicts the IOP peaks. So both methods are valuable in detecting IOP variability, which is a key risk factor for glaucoma progression. So in clinical practice, water drinking test can serve as a useful surrogate when phasing is not feasible, helping tailor treatment decision and monitor patients more effectively. And thank you very much for listening to me.
Thank you, Meher, for bringing this topic. You would remember that when we were both house officers and registrar in UK, we used to have evening duties, and every day there was a phasing patient lying in the ward that we used to do the intraocular pressure every 2 hours or every 4 hours, whatever the protocol. And in water drinking test, I would add one thing, that there was a person, I cannot remember his name, from Liverpool. He invented this test. And what he would do is he would ask them to drink water and then lie in the prone position.
Prone position.
That would enhance the closure of the angle and give you more information. I still do water drinking test maybe once or twice a month in my outpatient if the patient is willing to do it. And it's a very, very useful thing and non-invasive.
Meher, is there any evidence or data that would confirm that the timing of the water drinking test is significant? Like your case, in the morning hours he had a pressure of 10 or 11, and in the evening he had 26 and 28. What will be the difference if the water drinking is done in the morning versus in the evening?
There's no time thing. You can do in the morning, you can do any time. This is the beauty of the procedure, because you are sitting in your clinic at certain times and it's not feasible for you to bring the patient on the either times. So this test can be performed in the morning because it's a provocative test. You are pushing about 1 liter of water in their body.
Right.
So you can do it any time. It has been found it doesn't make difference what time of the day you are doing it.
But the difference is in the baseline intraocular pressure. If the baseline at that time is 10, naturally the rise will not be that much because the patient's own system is not letting it go high. And in the evening, the patient's own system is failing and the pressure is going to 26 or 28. So if you perform water drinking at that time, I think that will be more, probably that will be more significant or what, I don't know.
So actually one of my residents has the fellowship, dissertation on water drinking test, and we correlated with the phasing and we found out that is very, very, almost 90% accurate. So when we were residents, the water, as Dr. Imtiaz said, we were doing it. And the guy who has done this test, he's an old, you can look at the literature, his name was Mapstone, and he used to work in Liverpool. And that you can do this test also in the angle closure that he used to do, put the patient upside down, to see if pressure rises. So, and we found out that you can do in the morning or the evening. We did not find it, And nowadays there's a renewed interest. There are few articles. In fact, I think I shared a couple of articles with Aisha, which I put on the PGO group, that for busy practitioner, when you cannot see the patient at mornings or evenings and you're not sure what's happening, this might help you in majority of the cases.
And once you have done your phasing and you found something significant, as in your case, then there will be no need of doing water drinking.
No, I don't.
Still want to carry on.
So water drinking test, I just should describe it for
You
the
don't want to do the
patients.
phasing.
I personally, I very rarely do it because I look at them from 9 o'clock till 9 o'clock in the evening. I face them. And I check the pressure, by the way, myself. That's also important because I see my residents, my optometrists, their readings totally differ from me. So what I do is I make sure that I am there in the clinic and I check the pressure myself, and on the same machine.
Yeah.
Yeah.
Thank you very much, Professor Meher. Our next presenter is Dr. Yusuf Jamal Mehsood.
सदर है आपको कुर्सी नहीं खींचेंगे आपकी तो
Thank you, Dr. Aisha. Bismillahirrahmanirrahim. So, I have given the title to my case presentation is that eye is window to the brain. I will be talking mainly the relation between the eye and the brain, how you can see the brain through your eyes. So, this was a case presentation. An 18-year-old female, she was referred to our clinic, glaucoma clinic. She was already labeled as a case of glaucoma and was on anti-glaucoma medications. But what were her complaints? She had decreased vision, headache, and watering of eyes. On asking 2 years ago, she was labeled as a case of glaucoma and was started on anti-glaucoma medication that were prostaglandin analogs, carbonic anhydrase inhibitors, and beta blockers. This is what, when I checked her, on slit examination, the best corrected visual acuity was 636, both eyes, pupils were reactive. The anterior segment was normal. With medication, the pressures were 8 in the right and 6 in the left. On gonioscopy, all quadrants were wide and open. Coming to the cup disc ratio, the right eye was 0.7 and the left eye was 0.5 or maximum 0.6. But what I found was that there was temporal rim pallor on the both sides. You can see this picture. This is the right eye and the left eye. The cup is enlarged. It is about 0.7, but you can see the temporal disc pallor here. Here the cup is a little bit small, 0.5 or maximum 0.6 with cup, the disc pallor on the temporal side. So what we requested, we did the OCT of the disc and nerve fiber layer and visual fields. So what were found on the OCT? If you look on the OCT, there were thinning of the nerve fiber layer. What was important here that you can see the bitemporal involvement of the thinning of the rims. You can see the bitemporal side on both sides. So this is usually suspicious when you find the bitemporal, as you find the bitemporal involvement in visual field. In OCTs, it is also very suspicious. This was the visual fields, and I think everyone will agree with me that it is not suggestive of any specific glaucoma defect. So, as the maximum IOP that we found on her previous records were maximum were 20 in both eyes, there was bilateral disc pallor, and the OCT, it showed the bitemporal involvement, and the visual fields, they were atypical. They are not typical of glaucoma. So what we did, we advised MRI brain and visual pathway. So MRI lesions, there were some lesions that were suggestive of multiple sclerosis. What we did, we stopped the anti-glaucoma medications and we sent the MRI for the report. When the report came, it showed that there are hyperintense signals in corpus callosum and periventricular area that are suggestive of demyelination, maybe mostly multiple sclerosis, and bilateral optic nerve atrophy. So since she was 18 years old girl, we sent her to neurologist for opinion and his input. What were his findings, the neurologist, that there were balance problems with this patient, there were speech problems, the dimness of vision that was already, she was getting treatment for fatigability and limbs weakness. That was the finding. That were the findings with neurologist. There were some cerebellar signs as well: scanning speech, horizontal nystagmus, and ataxia. So, when they asked for the family history, the younger brother had the same ataxic episode and decreased vision. And the final diagnosis made by the neurologist was that it is a leukodystrophy. It means the white matter in the brain, it is dystrophic. So MRI is the single most diagnostic investigation, and its findings are positive in almost 80% of the patient for these type of problems, especially the demyelination. And in such cases, the follow-up MRI should be considered in 6 to 12 months later to assess for the presence of any new lesion, because what damage has been done, if it is older one, that cannot be reversed, but it should be followed so that new lesions are detected on time. As the patient was currently not in any flare-up stage of the disease, so only asymptomatic treatment was given, and we stopped all anti-glaucoma medications. So take-home message from this case presentation is that if there is typical visual field loss and corresponding disc changes with elevated IOP, then it is the diagnosis of glaucoma is very likely. But if any of these are not in line with glaucoma, if there are atypical disc changes or the visual fields and OCT, they are not correlating with each other, then there should be some, the threshold for neurological investigation, it should be lower than the normal. And if there is sectoral or diffuse pallor of the rim, it is a strong indicator of neurological disease. What happens in neurological cupping, that the pallor extends into the neurological rim, while in glaucoma it is restricted to the cup, but neuroretinal rim remains same, like pinkish or orange, until it is fully cupped. And I will end my presentation with this quote from my supervisor when I was training, that most of the intracranial lesions that are detected by glaucoma specialists. That is what he used to say. Thank you.
Thank you very much, Yusuf. Any comments from the panelists, please?
About your first slide, you said the eye is the window of the brain. I will just make a slight modification. The first slide that I show to the fourth year MBBS on the start of ophthalmology lecture is that the eye is the window of the soul.
Actually, you know, that's a very interesting case, Yusuf. I've got several cases over the years, you know, that are referred to me as glaucoma, and I'm not convinced this patient have glaucoma, and the first thing we want to do is to get an MRI done, and MRI will tell you the story. A neurological opinion, MRI will tell you the story. You know, we have seen, and even I've seen patients with carotid insufficiency, and they have pallor, all those things, you know. So if you have got any suspicion about glaucoma, I think it's good to investigate them systemically and get a neuro opinion on this patient, because you're not sure what you are looking at, you know. ग्लूकोमा तो आप ठीक कर देंगे ना, पता चले 2 महीने के बाद जो है वो उसको कुछ और निकल आया. और इंटरेस्टिंग जो चीज़ है वो ये है कि अबाउट 6 months ago I have seen this lady and she the same thing. तो मैंने कहा कि मुझे आपका MRI कराना है. उन्होंने कहा जी ये ले, ये MRI हम करा के आए हैं. कहाँ से कराए? रिपोर्ट ने कहा कि MRI में कुछ नहीं है. ठीक है. Now I am not a MRI specialist, you know, so I looked around, मुझे समझ नहीं आ रही थी. और उन्होंने कहा था कि इसके maxillary antrum में there's a cyst there. मैंने कहा how can that go into the back of the eye and cause a problem with both eyes? So I took it to the ENT guy, और ENT guy ने कहा कि भाई ये तो इसको तो मुझे लग रहा है कि कोई पिट्यूटरी में ट्यूमर है, इसको दोबारा भेज दो. तो we sent the reports to our radiology, और उन्होंने कह दिया कि पेशेंट को पिट्यूटरी ट्यूमर है. So it totally missed, the diagnosis was missed by the initial radiologist who did it and who reported it. So आपको ये भी इसमें भी बहुत ख्याल करना चाहिए. So we have learned a lesson कि जो बाहर से हमारे पास, क्योंकि because our khan will cost you a lot of money, so unfortunately patient get these things from outside. तो हम उनको कहते हैं यार आप थोड़े से पैसे खर्च करके ना उसकी कम से कम रिपोर्टिंग तो यहाँ से करा लो.
Thank you, sir. Sir, just one question. How often do you see such patients in your practice जिनको ग्लाकोमा डायग्नोज होता है, लेकिन एक्चुअली वो इंट्राक्रेनियल लीजन है। आम ऑडियंस से भी यही क्वेश्चन है। एनी कमेंट्स?
यूसुफ, मैं केस प्रेजेंट कर रहा हूँ पिछले 2 साल से। इन लास्ट 3 years आई हैड 2 cases which I have already presented in different meetings. Who was shown as sent as glaucoma but turned out to be pituitary tube.
It's not very uncommon. It's not
Yes,
very uncommon.
क्योंकि-
Every few months you get some case like this.
और मेरा तो तकरीबन हर मंथ में यही होता है। अभी 3 दिन पहले भी यही डायग्नोज करके भेजा है। तो ग्लोकोमा क्लिनिक में मेनली ये हो सकता है, मुझे नहीं पता और विट्रेटना वाले या वो क्या कहते हैं, क्योंकि ग्लोकोमा में यूजुअली वो डिस्क के लिए आए होते हैं और डिस्क से ही पता लगता है।
तो
थैंक यू।
यूसुफ, मैं 6 महीने में कम से कम ऐसे केस देखूंगा, लेकिन अगर आपको मैं बताऊं कि मैं हर हफ्ते 2 केसेस देखता हूं जिनको ग्लूकोमा नहीं होता।
हाँ, ये तो ठीक है सर,
ठीक है ना,
ये
ग्लूकोमा
मान
नहीं
लेते
होता
हैं।
उनकी। हाँ,
And they are convinced कि उन्हें है.
3 साल से दवाएं। अब वो मुझे कहते हैं कि हाउ दिस इज पॉसिबल कि हम 3 साल से दवा डाल रहे हैं, आप कह रहे हैं दवा बंद कर दें। मैंने कहा जी यू कम टू मी फॉर ओपिनियन, दिस माय ओपिनियन, अगर आप माने तो ये करें। एंड देन दे स्टॉप द ट्रीटमेंट। और प्रेशर 10 से ज़्यादा जाता ही नहीं है, और वो कहते हैं हम जेलाटिन डाल रहे हैं पिछले 5 साल से।
Thank you very much, Yusuf.
इसमें ये कि किसी को कहना कि आपको ग्लूकोमा है, ये एक बड़ी जिम्मेदारी का डायग्नोसिस है और एक सोशल स्टिग्मा भी है। एंड द पेशेंट्स कैरी द बर्डन ऑफ दिस डिजीज़ फॉर रेस्ट ऑफ देयर लाइफ, जस्ट लाइक हाइपरटेंशन, डायबिटीज़ और हार्ट डिजीज़। सो लेकिन किसी को ग्लूकोमा से उतारना उससे ज़्यादा बड़ी जिम्मेदारी है, क्योंकि एक दफ़ा वो ट्रीटमेंट पे लग गया है और वो सारी ज़िंदगी के लिए उसने ज़हनी तौर पे वो तैयार है। 5 साल से वो लेटानोप्रोस डाल रहा है, तो वो समझ रहा है कि मेरी बीमारी है और मैंने इलाज करना है। अब आप उसको इलाज से हटा रहे हैं, तो इसका भी एक प्रोटोकॉल है ऑलरेडी, और वही मैं थोड़ा सा आपसे शेयर करना चाहता हूँ कि एकदम से आप सारी मेडिसिन बंद करके, ठीक है कि आपके पास एविडेंस है कि इसमें चेंजेस नहीं है, ये नहीं है, वो नहीं है, लेकिन वो भी तो पेशेंट्स हैं ना जो मुख्तलिफ स्टडीज़ में, जिस तरह ऑकुलर हाइपरटेंशन स्टडी में हम कहते हैं कि पहले 5 सालों में कुछ नहीं होता, अगले 5 सालों में बहुत कुछ होता है। तो आप कहते हैं कि जी उसकी कोई एविडेंस उसके अंदर नहीं आई विजुअल फील्ड्स में, OCT में, तो फिर आप उसको क्यों ट्रीट करें। लेकिन तकरीबन 10% पेशेंट्स हैं जिनको ट्रीटमेंट बाद में देना पड़ जाता है। अब ये कैसे पता चले कि कौन से 10% हैं वो, तो एक ये फॉलोअप ज़रूरी है। दूसरा ये कि उनको आप फेजेस में उतारें और उनकी मॉनिटरिंग जारी रखें। उनका पहले बंद करें सारी दवाइयाँ, फिर उनके प्रेशर चेक करें, जैसे बताया कि 10 ही हर दफ़ा आता रहा बाद में भी। तो एक तो ये चीज़ है। अभी रिसेंटली भी मैंने एक खातून को दवाइयों से उतारा है, लेकिन उनको मैंने फॉलोअप पे रखा हुआ है। साल में एक दफ़ा उनका OCT भी होना ज़रूरी है, ताकि कोई चीज़ ऐसी मिस ना हो जाए, क्योंकि उसके बाद फिर जिम्मेदारी आपकी आ जाएगी कि वो इलाज पे थी, आपने हटा दिया और वो ब्लाइंड होना शुरू हो गई, और वो इस गलतफहमी में रही कि मुझे कुछ नहीं है। तो इसलिए दोनों तरफ इम्पॉर्टेंट है किसी को डायग्नोसिस देना, जब तक कि आप खुद कन्विंस्ड ना हो। अगर आपको मुश्किल हो रही है तो हमेशा सेकंड ओपिनियन ले लें अपने किसी कुलीग से, और इसमें कोई रिजर्वेशन नहीं होनी चाहिए कि आप कोई छोटे नहीं हो जाएंगे किसी से कुछ पूछने से। और दूसरी बात ये कि सारी चीज़ें पूरी करें, और कभी पहले फेरे में उसको दवाई ना शुरू कराएं कि आज पेशेंट आया तो आज ही 3 दवाइयाँ आपने जड़ दी हैं उसको, लेटेनोप्रोस भी, अल्फागैन भी, दूसरी भी। ये कोई दिनों में कुछ नहीं चेंज होने लगा। इट्स अ डिजीज़ ऑफ मंथ्स एंड ईयर्स, इट्स नॉट अ डिजीज़ ऑफ आवर्स एंड डेज। सो यू ऑलवेज टेक योर टाइम। थोड़ा सा पेशेंट भी 1-2 चक्कर लगाता है, आपके पास कुछ कॉन्फिडेंस बिल्डिंग होती है, कोई लेजॉन डेवलप होती है आपस में, आपकी बात उसको समझ आती है, उसकी आपको समझ आती है, उसकी फैमिली इन्वॉल्व होती है। सेकंड टाइम आता है और वो परेशानी के आलम में कि जी क्या है। मैं तो हमेशा ये कहता हूँ कि आपकी पीछे की जो नस है उसकी खून की गर्दिश मुतासर है, अभी हम उसको देख रहे हैं कि किस वजह से मुतासर है। जब उसके सारे टेस्ट हो जाते हैं, फील्ड्स भी, OCT भी, सब कुछ, फिर उसके सामने रखते हैं आप। एंड ऑलवेज हैव अ नॉर्मल एट योर हैंडी विद यू। जैसे OCT का एक नॉर्मल, विजुअल फील्ड्स का एक नॉर्मल, तो उसके साथ अगर आप रख देते हैं तो पेशेंट के लिए अंडरस्टैंडिंग बहुत ईजी हो जाती है कि ये नॉर्मल है और ये मेरा है, इतने चेंजेस इसके अंदर आई नहीं है जिसकी वजह से मुझे ये इलाज की ज़रूरत है। वरना उसको सिम्टम्स तो कोई हो नहीं रही होती, माइल्ड सी हेडेक है, कुछ और है, तो उसको तो वो समझते नहीं कि ग्लूकोमा है। तो किसी सिम्टम के बगैर पेशेंट ट्रीटमेंट ले और सारी उम्र लेता रहे, ये बड़ी मुश्किल बात है। तो उसको कन्विंस करना ज़रूरी है कि आपको है ये डिजीज़ और ये एविडेंस है उसकी बेसिस के ऊपर उसको आपको लेकर चलना पड़ेगा।
Thank you very much, sir. Our next presenter is Dr. Afshan Ali. She is going to present our last case.
Assalamu alaikum everyone. I am Dr. Afshan Ali, working as glaucoma consultant in LRBT Karachi. So today my case is of a female patient, 40 years of age, a housewife, resident of Karachi, presented to our glaucoma outdoor with blurring of vision and pain in her right eye for last 6 months. Her blurring of vision was gradual in onset, progressive in nature, and painless in the beginning. Soon she started experiencing pain, which was severe, would come and go and radiate to her right temple and forehead. It was not associated with nausea, vomiting, or red eye. She did have temporary relief with painkillers though. She was diagnosed as case of glaucoma about 6 months ago and was put on anti-glaucoma drops for her right eye. When she presented to me, she was using topical combination of beta blocker and carbonic anhydrase inhibitors and topical prostaglandins. She was also taking oral tablets of acetazolamide twice a day. There was no significant surgical or medical history. Family history of glaucoma was negative. She had a low income profile, she's unemployed, her husband is a stall keeper, and she has 4 kids. So on examination of the right eye, which is a problematic eye, her best corrective vision was 6/9, intraocular pressure was 42 millimeters of mercury, cornea had a very typical hammered silvered appearance, interior chamber had irregular depth due to peripheral anterior synecdoche, iris had nodules, pupil showed correctopia, polychoria, and ectropion UV. Lens showed nuclear sclerosis of grade 1. Optic nerve showed vertical cupping of 0.6 with mild thinning of superior, inferior, and temporal limbs. On examination of the left eye, intraocular pressure was completely normal, interior chamber depth was normal, and optic disc was of 0.4 cupping with no thinning of neuroretinal rim. This is the short video of interior segment of the right eye. You can see the correctopia, polychoria. Now you can see the ectropion UV and also the iris pedunculations. This is the video of interior segment of left eye. You can appreciate that it's completely normal. This is the video of right eye optic nerve, 0.6 cupping, vertical cupping, and mild thinning of superior, inferior, and temporal limbs. This is the fundus photograph of the left eye, completely normal. This is the gonioscopy of both the eyes. First is the gonioscopy of the right eye. You can see peripheral anterior synecdoche. That was superior quadrant. This is inferior quadrant. Again, you can see here PAS, nasal quadrant. This is the temporal quadrant, again showing PAS. This is a gonioscopy of the left eye, was completely normal, grade 3 angle. So we did carry out the investigations on visual fields. Right eye ka jo MD, that was -5, and there were few non-specific central defects. So we decided to carry out 10-2. Left eye was completely normal, right eye mein there were central defects seen. So we carried out OCT, and there was no red or yellow zone seen on the OCT, so it was kind of green disease. So we carried out progression analysis of the right eye, especially for the right eye. There was mild thinning seen in the inferior quadrant and also in the temporal quadrant, but it was not thin enough. Red or yellow was not shown, still not shown. GCC was normal, no positive findings. So this is the interior segment OCT of both eyes. Upper figure shows the OCT of the right eye. Left eye, which was completely normal, you can see the open angles, and lower figure shows the angle of right eye. You can see the peripheral anterior synecdoche here. Iris is stuck to the angle. Center cornea thickness was normal, 533 and 540 microns. So we made a clinical diagnosis of eye syndrome because of the typical corneal abnormalities, typical iris features, and characteristic angle features. Panel ke saath.
I think you can finish first and then we can have a discussion.
So I'll skip the management part right now.
You carry on.
Okay. So she was already on maximum medical therapy for last 6 months, both topical and oral, and her disease is uncontrolled. She was still having the pressure of 42 millimeters of mercury. So we decided to do the lens extraction with IOL implantation and glaucoma drainage device. Syndrome is a group of disorders characterized by abnormal physiology of corneal endothelium, unilateral, common in females in 4th to 5th decade of life. It is non-hereditary. So variants are Chandler syndrome, Cogan-Reed syndrome, progressive iris atrophy, but these clinical features often overlap. Sometimes it's not easy to differentiate between these three. So etiology, herpes simplex virus was seen in PCR of corneal specimens of iris syndrome patients. The problem is corneal endothelial cells. They undergo anatomical changes and they start acting like epithelial cells. So they proliferate and migrate over iris and angle. These abnormal cells make a membrane contracture which leads to PAS, iris holes, and pupillary abnormalities. So glaucoma is the main cause of visual loss in iris syndrome patients. Prevalence is 46 to 82% and is more common in Cogan-Rees and progressive iris atrophy. Word, मैडम अब डिस्कस कर लेते हैं पहले, फिर उसके बाद कंसेंसस और ये गाइडलाइंस होंगे.
Okay, sir. Any comments so far?
Yeah, so iridocorneal endothelial syndrome is, not that uncommon. We will see every second month these cases, Most of these cases are referred. The only problem I've seen is that majority of the patients who come to me, they already have a trabeculectomy done, and it never works. Although literature says it might, but I've never seen trabeculectomy being successful in these cases. And if the patient comes initially with me, I'm not going to do trap. And sometimes there's a lot of finances involved if I'm putting the M glaucoma valve. But मरीज मुझे फोर्स भी करते हैं, दोस्त मुझे फ़ोन करके ट्रैप करें. मैंने कहा मैंने नहीं करनी, कि मुझे पता है कि नहीं काम करेगी. एंड स्टिल आई कैन टेल यू देयर आर 2-3 केसेस हैंगिंग ऑन माई क्लिनिक जिनको मैंने बताया कि जी ये आपने जो कराई सर्जरी ये काम नहीं करेगी. और सो दिस इज़ अ डिफ़िकल्ट proposition, and one has to be extremely careful. And दूसरी बात है कि पेशेंट जितने आते हैं, they are all young patient, And females, I have not a male I can see it, but majority of the patients that I see, they are ladies, So yeah, difficult to. And you need always do bilateral, because अगर ये bilateral है तो then your diagnosis is not ice, then you think about rigors and things like that, The iridocorneal endothelium syndrome is a unilateral problem. Yeah.
So my question is to you that would you have taken the lens out in this patient if she had presented to you?
So I don't remove their lens. I just put a valve and just stay there, because I have seen that if I remove the lens, I'm not going to, although I understand they have got those things, but these are not a typical angle closure that you are. They have got a problem, these genetic problems, they have anatomical problems. So मैंने जिनको भी सर्जरी की है, मैं normally lens नहीं निकालता, I just put a valve, and it works very well.
So where would you place the tube? Where would you place the tube? In anterior chamber or in sulcus? Because you are not taking the lens out, so you're going to put it in the anterior chamber.
So what I do is, I want to go around the anterior chamber to see where is the in a good space that I can put my tube, and the trouble sometimes superiorly, especially those cases जिनको trap हो चुकी होती है, तो superiorly उनको पास space नहीं होता, तो I have put AGV also inferiorly. So if superior-temporal is the choice, or otherwise अगर नहीं होता, मैं उनको inferior-temporal डाल देता हूँ, because you always find there is a decent space there, because ये भी है ना कि आपने ट्यूब डाला, ये नहीं हो कल उसको कॉर्नर टच हो जाए, there's another issue. So inferiorly.
So
मेरा कोई एक्सपीरियंस नहीं है, आई डोंट हैव पुट एनीथिंग इन. मैं उनको पार्स प्लाना जो है वो हमारे पास फैसिलिटी नहीं है, सो आई डोंट. देन यू नीड अ विट्रेक्टमीज एंड थिंग्स लाइक दैट, योर VR गाय. सो सिंपल ये है कि आप उसको इंफीरियरली डाल दें. एंड आई पुटिंग इंफीरियर ट्यूब इज, पहली दफ़ा जब मैं डाल रहा था तो मुझे डर लग रहा था कि कैसे होगा. देन आई रियलाइज इज वेरी सिंपल एंड वेरी ईजी एक्चुअली टू पुट द valve inferiorly rather than even superiorly.
So she had a nuclear sclerosis of grade 1, so we decided that we will take the lens out, and because we wanted to put the tube in the sulcus.
Yeah.
So that was another reason why we took the lens out.
बट अफशान आपकी पॉइंट बहुत वैलिड है कि अगर आप समझती हैं कि 360 डिग्री स्पेस नहीं है और आपने ट्यूब डालना है, दिस गोइंग टू हिट द कॉर्निया, बिकॉज कॉर्निया इज ऑलरेडी कंप्रोमाइज इन दिस पेशेंट. तो आप यू कैन मेक अ स्ट्रॉन्ग पॉइंट ऑफ गेटिंग देयर लेंसेज आउट, और आप फिर क्या करें कि मैं उनको सूडोफेकिक होते हैं ना, आई पुट दी बिहाइंड द IOL. So I don't put them in an anterior chamber, I put the tube under the IOL. And make sure कि जब आप IOL के नीचे डालें तो ट्यूब को लंबा छोड़ना है, क्योंकि वो pupil से नज़र आना चाहिए. And it works very well.
So World Glaucoma Association consensus statement on eye syndrome management is that both TRAB and MMC and GDT have only good initial results, but other surgeries may be needed. Insertion of tube in the sulcus or vitreous cavity whenever possible is recommended to decrease the risk of corneal decompensation. If they are PAS, considered glaucoma drainage device due to high chances of trap failure. Studies have shown higher success rate of GDT over trap in ICE patients. How to minimize tube occlusion in these patients? So choose the optimal tube insertion site without or with the least ICE membrane and PAS. Insert the tube approximately 2 to 3 millimeters from the limbus through a 23 gauge needle track under the scleral flap and fix the limbal portion of the tube with 10 or 9 on suture to the deep scleral bed. A small size needle entry, a proper length scleral tunnel, and a good fixation suture will be beneficial for avoiding dislocation of the tube. Cut the distal end of the tube slightly longer than usual before anterior chamber insertion and keep the tube tip away from potential sources of eye cells, such as the iris and cornea, and away from the iris anterior synecdoche. Use viscoelastic to separate the iris synecdoche and deepen the anterior chamber before tube insertion to avoid tube ostium blocking by the iris. So this is the video, post-op video. We implanted Ahmed Clear path in this patient after IOL implantation. So we cut the central iris band, did lens meta aspiration, IOL implantation, and then we put the ACP. You can see the tube in the pupillary area. We also put scleral patch. It has been 3 months since the surgery, and now patient is completely off anti-glaucoma therapy. Thank you.
Thank you very much, Dr. Afshan. I think there's no session after this session till 12 o'clock, so I'll present one more case, and then we'll finish this panel discussion. Okay, so my case is about a 25-year-old male who's a design engineer in NUST, and he has no comorbids, and he presented with gradual reduction of vision in both eyes since the last 1 year. He was diagnosed as having glaucoma in both eyes in February 2024, and he was put on anti-glaucoma medications. He was diagnosed as having a retinal condition in March 2024, and since the last few months, his IOP was not controlled adequately, and he was advised to have a glaucoma surgery in his right eye. The surgery was deferred due to a retinal condition which was diagnosed in March 2024. One of his anti-glaucoma drop, that is latanoprost, was also stopped because of that retinal condition. The patient came to us for a second opinion to discuss whether he can have a surgery in that eye to control the pressure or not. His family history was not significant. He was on anti-glaucoma medications, combination of dorzolamide and timolol and brimonidine. He was on nepafenic eye drops and some oral acetazolamide tablets as well. So on examination, in his right eye, his vision was 612, and in his left eye, his vision was 615. The lids and conjunctiva were normal. His cornea was clear, and there were no Krukenberg spindle or anything of that sort. His central corneal thickness was below normal. It was 495 microns in the right eye and 491 in the left eye. By Goldman applanation tonometer, his intraocular pressure was 27 in the right eye and 20 in the left eye. His anterior chamber was quiet in both eyes. He had right relative afferent pupillary defect, and his lens was normal in both the eyes. On gonioscopy, he had closed angle and no structure was visible in both eyes. On fundus examination, he had a very advanced glaucomatous cupping in the right eye with deep excavation. The foveal area showed abnormal sheen-like cellophane maculopathy, and there was a question mark whether it was a epiretinal membrane or not. And in the left eye, his CDR was normal, 0.3, the left disc also looked healthy. And on foveal reflex, again, there was this abnormal sheen on the fovea. And there was, again, this query of epiretinal membrane in the left eye. So this was the OCT RNFL of the patient. So in the right eye, you can see that he has superior-inferior thinning, whereas the left disc is normal. This is the field of his, both eyes. So in the right eye, you can see he has only tunnel vision left, whereas in the left eye, the field is still full. Then this is the OCT of the macula of the patient. So if you look at the fovea of the both eyes, there you can see there are multiple, tiny loculated, multi-layered areas in the foveal region in both eyes. So this is another one. This is the fundus fluorescein angiograph of the patient. So there was some peripheral leaking you can see in certain areas. Here. In late phases. And these are, further pictures. So a retinal consult was sought, and the diagnosis of a macular schisis was made. No intervention was advised from the retina side, and in fact, they gave us a go-ahead that the glaucoma department can perform any kind of a surgery to lower the intraocular pressure. So my question is with the panelists. So what will you do in such a patient? Would you go with lowering of the intraocular pressure? Would you think that lowering the intraocular pressure will further increase the macular edema that we saw?
Well, it depends on the etiology of the macular edema. If because of the macular schisis, then reduction of the intraocular pressure will have no influence, But you want to reduce the intraocular pressure because you think that it's hurting the RNFL, then you only do it. But otherwise, I don't think that's going to make effect, By the way, sometimes macular edema, even with retinoschisis, we deal with carbonic anhydrase inhibitor drops, We put them on Azopt or Trusoft drop 3 times a day, and the edema component decreases in these cases, The traction stays. So, but otherwise, so you can decide about it. If the retina guys don't want to do it, you just deal it as a glaucoma patient. Okay.
Do you have any experience of doing, a filtration surgery in such patients?
No, I have no experience of doing filtration surgery where there's a retinal schisis present there.
I would be very cautious. You see, if this patient goes into hypotony, which many patients can go transiently in the post-operative period, then the macula would be definitely affected. So you have to be very, very careful.
So does anybody in the audience have got experience of treating such patients with macular edema, which is basically diagnosed as foveal retinoschisis, which is generally a congenital condition? Anything to add, Professor Sadia? Have you ever, operated on such patients with macular edema? No? You have? So Yusuf, what do you say? One should go for a filtration surgery in this case?
Yeah, the macular edema is because of several reasons, diabetic macular edema is the most common thing that we see, और उसमें तो कोई issue नहीं होता, हम उनको anti-VEGF लगा के stabilize कर देते हैं, and then we go and do the surgery. But here the phenomena is totally different, here is a schisis, so there is a traction there. Yeah.
So if you're sure it is retinoschisis, then you can go ahead with any kind of glaucoma filtrations.
I think जो Dr. इम्तियाज ने कहा ना वो ये है कि you make sure that you're not dropping the intraocular pressure too low, that patient runs in hypotony, and that will exaggerate the macular edema. So आप माशाल्लाह you are a competent surgeon, flap को tight करके बंद कर दें, and then maybe you can titrate. You don't want to bring it down to 7-8 नहीं चाहिए. अगर early teen में भी छोड़ देती है ना तो a lot of sutures, the way we do on the myope patient, which are always troublesome to do the drainage surgery.
Okay. Can anybody give a mic? So he was already on AZM tablets.
So there was an option of GSL in these patients. So
Okay, Professor Sadia has something to add?
yeah, so there is no role of goniosynculitis if we have angle dysgenesis. Because goniosynculitis just work in those cases in which angle was normal initially, and then there was a mechanism that has resulted in recent closure of the angle. Because if it is just limited to trabecular meshwork only, then we expect it to work once we remove the diseased TM. But like in eyes or in cases in which we have maybe retinal degeneration, there's some angle dysgenesis, then we expect some distal outflow pathway problem is also there. And then GSL ideally would be to do a bypass surgery like tubes in these patients.
तो इसमें आयशा जो दूसरा आपका सवाल है ना, that's very interesting. What is the cause of reduced vision? Is the schisis or glaucoma? I think you have to counsel the patient. आपने पेशेंट की बात करनी है, क्योंकि आप उसका प्रेशर कम करके बैठ जाएं. अगर वो पेशेंट समझता है या समझती है कि आप उसकी विजन इंप्रूव करेंगे, सो यू नीड टू रियली अ गुड टाइम टू टॉक टू हर कि आप ये प्रोसीजर जो है कर क्यों रही हैं, बिकॉज विद मैकुलर स्काइसिस पेशेंट्स विजन माइट नॉट इंप्रूव.
Okay, thank you very much, sir. Any other comments from the audience? So this was our last case. If there are no comments, sir.
One of the good presentation was praising IOP. What do you think? We have the 60 plus patient and they have the hypotension or hypertension. They are taking the antihypertensive drug, sometimes hypotension and this. We are dealing with the intraocular pressure is the filtration pressure minus is equal to the blood pressure, mean arterial pressure in the optic circulation minus IOP. If the IOP is increased or the mean IOP in the vessel is decreased, both leads to glaucoma. For example, if you have IOP 22, but your mean arterial pressure is more than 30, more than 40, it is safe. But if it has a IOP of 12, but your mean arterial pressure of 30, you develop glaucoma. So filtration pressure is also important. I am always in question with the cardiologists. They keep the intraocular pressure, they keep the blood pressure 100 by 60, 110 by 70. And we just calculate the mean arterial pressure in the retina as you add systolic and diastolic is the mean arterial pressure. 1/3 of is 90 is normal. 1/3 and 60 is in your ophthalmic artery. Then 1/3 of it is 30 is there. So if your mean arterial pressure, the cardiologist keep it in low blood pressure. So there the pressure is. So once the sir said, I have seen 2 cases of low tension glaucoma. I see many low tension glaucoma in patients 60 plus 70 years. And this prostaglandin allow, they are good to control it. So along with pacing IOP, the pacing of the blood pressure is also should be done 60 plus patient, and particularly those who are taking antihypertensive tablets.
Yes, thank you very much, sir. You are talking about the ocular perfusion pressure, which doesn't have to go very low because of the low blood pressure of the patient, especially the patients who get nocturnal hypotension. Thank you very much. So any other comments from the audience? If no, then we would like to close this session. I would like to request the panelists to present the shields to the presenters, please.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Professor Sadia Humayun, and today we are going to have a panel discussion on refractive surgery for general ophthalmologist. May I request the panelists to please come on stage? Major General Mazhar Ishaq, Dr. Ishbala Tariq, Dr. Ishbala Khatak. No? Dr. Amir Israr, Dr. Sophia Iqbal, and probably Dr. Sharif Hashmani, Dr. Zafrul Islam, and Professor Saeed Iqbal. They couldn't join us because of their commitments. इसको screen change कर दें. We have a very limited audience, but I think we should start. I'll start with a very basic question. So, what is the right age for refractive surgery? वो पीछे डोर बंद करवा देंगे, वो बहुत शोर आ रहा है उधर से.
So the right age for refractives, this is a very important question. There are certain general guidelines, but the most important thing is the stability of refraction. The patient has to be above 18 years of age at least, but the refraction has to be stable. So you can wait till you get a stable refraction, you can wait till the age of 20 even. So it varies from case to case. And very rarely if you are doing an isometropic amblyopia cases, then you can go earlier before 18. And the upper limit can be 40, but then it depends if presbyopic element comes from 45 to 50, you can opt for other things like refractive lens exchange. But the start age should be above 18, and the stability of refraction is the most important factor. Plus the other factors like the ocular surface should be normal, the cornea should be okay, and topography, everything should be stable.
So what if a patient comes to you and he is interested in joining army, he is 17, he has a refractive error of -6, and he is very adamant that he wants to get refractive surgery done?
Got two kind of answers, but I think so, as Dr. Saab has very clearly said, I think so one has to be very blunt about this thing. Because there are some gray areas and in which I think so, I will never try to do anybody less than 18 years of age. When you go into look into literature, people doing it, there will be a lot of answers about that, but this is one thing which is, I will, because we have, this is a program for a general ophthalmologist, so we normally should tell them exactly that below 18 years we normally don't do it these cases. But it's a kind of a contraindication all over the world. I do not know of any paper which has been written in which it is below 18 years of age, maybe like that.
So why I ask this question is because there are many patients we come across who have been advised refractive surgery at younger age just because they want to join forces or they want to get it done. So my question for Dr. Amir Israr, so if a patient has a refractive error of -6 and he comes to you at 18 years of age, so what will you do? Will you still do his refractive surgery?
I think Dr. Sabha has already answered it very nicely. Like, we have to look into different aspects to it. 18 is good enough an age, but most of the people try to delay till the age of 21. If we have got stable cornea, stable refraction, and patient understands that we might need to retouch, there is no problem with that.
Right, sir. So, the right answer, as everybody described, that patient has to be above 18 years of age, stable refraction during the last 1 year with no more change of 0.5 diopters, not more than 0.5 diopters in change in refraction during the last 1 year. And normally what the latest literature and the refractive surgeons all over the world, they emphasize that we should wait if the patient has high myopia till the time the patient is 20 years or 21 or when the refraction stabilizes. So chronic contact lens wearer, a patient comes to you and he's a chronic contact lens wearer, wearing contact lenses daily from 8 in the morning till 6 in the evening or 8 in the evening, and for the last 20 years. So he or she has only 1 week before she returns back to UK. What will you
Chronic
do?
contact lens user, as we all know that contact lens has an effect on the corneal surface and curvature. So definitely that will affect the topography readings and that can compromise our surgical outcome. So the patient has to stop wearing contact lens, and it depends on the type of contact lenses. And you said 20 years, this is a very, very long time. So, but you have to, in cases of soft contact lenses, you have to stop generally 4 to 7 days, but some surgeons can wait for some time. And rigid lenses, you have to wait for a few weeks even, because that affects the curvature more. And then you have to repeat the topography. Till the topography, sometimes you have to repeat it again till it is stable, and then you can go ahead with it. And contact lens wearers have other problems of dry eyes issues as well, so you have to address that. So a full ocular examinations, the tear breakup time and everything, that has to be addressed. Not only the corneal surface, but the dry eyes related issue has to be addressed. So it depends on the contact lens type, and once when the topography is stable, then you can go ahead. You should not rush that. And now the other senior colleagues will add up to it.
100% agreed with it. The other things is like looking at the limbus to find out blood vessels. The important question is like, in general, how much time to be spared before we plan for refractive surgery. In general, for hard contact lenses, 2 weeks, soft lenses, 1 week. But I think that is not fair, as Dr. Sabha said. It is like to look into the scans, to look into the general appearance, and then decide. A time comes when your clinical judgment is far more important as compared to this standardized time given frame. So for the exams, if you ask, Jansa would be able to let you know better, but for practical purposes, as Dr. Sabha said, we have to look clinically when is the right time to operate.
Would you like to add something? Is there any role of epithelial mapping, sir?
जैसे हम कह रहे हैं कि we can carry on, but I think so the take-home message is very clear that if somebody is a chronic contact lens wearer, have a very good look at the eye and tell them that whatever the measurements will be, if they are wearing for such a long period of time, the measurements will be different if they are not wearing the contact lens and if they are wearing the contact lens. All the other things are correct. And so therefore, you should wait for a week, 2 weeks, depending upon, as Amir has very clearly said, depending upon the condition of the eye and whatever it is. It may be even longer than this thing if there are some chronic changes of the contact lens wearer in the conjunctiva or in the limbus or on the blood vessels as we normally see. So you have to decide. But the important thing is, whenever a patient comes to you, you should always ask them, are they a contact lens wearer? And then take it from there, and always ask them when they have they stopped wearing the contact lens or not. And that because there are not a lot of papers which have shown that if you are a long time wearer of contact lenses, and if the measurements taken with the contact immediately after taking a contact lens off or a week later are slightly different also. So that thing has to be taken into mind. Thank you.
The important thing for a contact lens wearer are like we can see like blood vessels all across the limbal area. And a few ghost vessels which will start bleeding as we start making flap or removing epithelium for the PRK. So one has to be really careful with that. We normally measure a flap size as far as like white to white, but in these cases we have to take a notice about where the blood vessels are coming in, because the last thing that we want is like blood vessels leaking under the flap, because this can lead to DLKs and other problems like permanent pigmentation. So this is like an important thing that let's suppose if we have got a large size cornea and the blood vessels are coming up to like 8 millimeter optical zone, then we even have to minimize the size of the flap. Then we cannot be greedy like to increase the size of flap. That can lead to troubles.
Very rightly said.
Can I add one thing more? And sometimes if you are grossly, the cornea may look good, and sometimes when you're trying to lift the flap, you may find adhesions coming up. And sometimes when you ask them, even at that time, you will come to know that the patient will tell you that there are sometimes subclinical corneal problems with the contact lens wearer, and they may have some inflammation in the past, and when you take off the flap, it will be difficult.
So as already discussed by our worthy panelist, we have to stop contact lenses at least 1 week before preoperative assessment for soft contact lenses, and hard contact lenses 2 weeks. But this is not hard and fast rule. We have looked at the corneal warpage, clinical examination, repeat topographies to rule out whether there are changes in the corneal topography or not. It can cause irregular astigmatism, changes in corneal thickness, and the most important thing that we have to look at the epithelial mapping in these cases. So when we look at the epithelial map, so this is the patient with corneal warpage. You can see you can see these kind of spots in such patients, and like this. But on posterior tangential map, there is no hot spot. But in ectatic patients, when you look at the posterior tangential map, you see hot spots. So this is the way you can rule out the patient of corneal chronic contact lens users. So there is always an epithelial hyperplasia in such patients. So always do epithelial mapping if you are in doubt. Pre-op cycloplegic refraction, is it mandatory?
It is important, not mandatory in every case, but I mean you have to individualize every patient. It's important when you are dealing with hypermetropes, because you know the element of latent hypermetropia is there, so that has to be addressed. It's important when there is accommodative issues are there, or when you are suspecting pseudomyopia, or patient having young patients in which there can be accommodative problems. So if there is a difference in the pre and post cycloplegic refraction, then that has to be considered. Before we go on any refractive procedure or we plan it, a full examination is mandatory, which includes everything. So whenever you are in doubt, especially as I mentioned, these are the group for which it is important, yes. So we practically do not do it in every patient, but these are the patients which we should take into consideration, especially young patients.
In my practice, I normally do it as like in every patient. I would prefer not to do a refractive surgery procedure without having a cycloplegic refraction.
I normally, I will agree with Dr. Sophia. What we do is, if you have got a very good, or I think so we can add on this thing, if you find some astigmatism or something like that, which is, on topography it is different, and on the patient astigmatism is different, that could be one of the reasons where you can do it. Hypermetropia is very commonly, I mean, there's no second question about it, hypermetropia, you have to do it a cycloplegic refraction. I will never immediately do it. In early myopias, in those myopias or simple myopias, I think so, and if you do not find anything, we normally don't do it. But as I think so, there's no hard and fast rule, but in hypermetropias, and if you find pseudo accommodative or accommodative spasm patients, or if you find there's a difference between refraction, I think so then that is very important to do a cycloplegic refraction.
Cycloplegic refraction definitely has a role in hyperopic patients. Hyperopic patients and mixed astigmatism patient, it's a mandatory step in, especially in these patients. We can rule out accommodation spasm with the cycloplegic refraction, and sometimes overcorrected myopes. If you find out during refraction that the patient is accommodating a lot, then it's again a mandatory step. You have to do cycloplegic refraction to rule out. And otherwise, you have to dilate a patient to see fundus of the patient, peripheral retina, which is another important step, so it's better to do cycloplegic refraction. Refractive surgery in pregnancy and lactation. What if a patient comes to you and says that she is in her first trimester, just the first month, second month, and she has to go abroad and she wants to get it done before she leaves? What will you do? It's her first pregnancy, and what if she comes in her second or third pregnancy? Will you still do, or you will consider not doing it?
I will not do it. Pregnancy has its effect, as we all know. Hormonal changes are there, and it has effects on the body tissues, on the stroma, curvature, and sometimes patient can get a refractive error as well, which then reverses back. So ideally, you have to wait for the pregnancy to be over, for the menstrual cycle to be assumed, and for the body tissues to get back to the normal. And lactation, initial phase is very important, shouldn't do it. And there is a theoretical risk of the medicines which they use to be excreted in the milk as well. So that there is a theoretical risk for that as well. So ideally, all these phases should be over, weaning should be done, and the tissues should be back to normal, then it should be at. We all know it is not an emergency procedure, it's an elective procedure. If the patient has waited that long, I think she can wait. This is my opinion, but.
Over to Amir.
I think we've had a lot of discussion about this before.
I'll keep on asking till the time you will say no.
My approach to these type of problems is different, because I've had a lot of discussions with Dan Reinstein, even with Dan Coe, and other people. If the patient understands that we need to retouch, I would go ahead with it. The only procedure I would not do is smile in these cases, because in smile, then I'll have to go in with the PRK to retouch. So that would not make any sense.
I think so. We all agree on this thing that if you have got a pregnancy and everything, that you have to take very cautious view about this thing, and only in case of emergency, as Amir has said, that is after taking a proper consent and everything. But we always have a discussion, so I will just put it that way, that if you ask this question in an exam and if somebody says, okay, I will do it in pregnancy, he is going to fail. But because you see, there are a lot of things which as experts you can do a lot of things which you can do it, but there are something which are bookish and textbooks type. So for a textbooks kind of a thing, for somebody who because this is a program for general ophthalmology, for them I think so it's a no-no area of touching anybody who's pregnant or lactation.
Yeah, that's absolutely right, because it's I think it makes more sense. Retouching refractive surgery is not that simple a thing, especially if you've done a customized treatment in the first thing, and then you want to enhance over a customized treatment. That is even more difficult. So you need to have a lot of experience before you plan for a treatment, and then you need to have a plan that if the number pops up again, how are you going to treat that?
Right, sir. So this is an absolute contraindication. Because of the hormonal changes, definitely there is a negative impact on corneal biomechanics. There is a change in refraction, change in corneal thickness and corneal curvature. So we have to wait 3 to 4 months after childbirth and after cessation of breastfeeding. And there are many patients in which we have seen ectasia progressing. So it's better not to do and take it as a absolute contraindication. A patient comes to you, he has primary open-angle glaucoma, and glaucoma is well controlled, and the patient is on 2 drugs, topical anti-glaucoma medication. ये glaucoma वाले भी हमारे कुछ बैठे हुए हैं, वो भी शायद add on करना चाहें कुछ. But for the last 5 years, patient is using these medications. What is your take? And then second scenario, a patient who is not well controlled on all the medicines, they are planning to have the trap done, but the patient insists that he wants to get rid of his refractive error.
These two are different scenarios, so I'll deal with the general guidelines. Glaucoma is not an absolute contraindication, but we have to assess each case separately, and you gave us 2 scenarios, so I'll deal with one. It has to be controlled, and the glaucoma specialist has to be on board as well. Visual field should be stable, and look at the fundus and everything, and OCT findings. And you said that he's controlled on 2 medications. So obviously the corneal thickness is going to change after the procedure. So IOP readings is going to be different. So that has to be kept in view, and use Goldman planation interrometer later on. And then you will be relying probably more on the visual field findings and everything. So accurate assessments can be done on that. The second scenario involves surgery. He first wants to get rid of glasses and then go ahead with trap. So after trabeculectomy, his refractive error might change, depends on the astigmatism and that. So that can be an issue, which I think Dr. Ahmed can add up to that.
For me, for glaucoma, I'm a little more careful. There are multiple reasons behind it. First thing is that we're going to use steroids after surgery. If they're going to be steroid responders, it's going to make things more difficult. Now, the other thing is, as Dr. Saab has already said, like Goldman's is out of question because we cannot get a reliable reading with a Goldman because of corneal thinning now. So we have to rely on other elements like visual field and OCT. Visual field is also not an absolute reliable because most of the patients are illiterate, or even if they are illiterate, if you have tried it yourself, it's quite a tedious and irritating process because I got it done myself. And it was like quite a nasty thing, sitting in front of a machine for half an hour, pressing in buttons, and one really gets tired. The OCT changes will come up significantly later once the problem has happened. So all these things are like pushing me away from refractive surgery as for a glaucoma patient, whether it's stable or not. Unstable definitely needs to be treated as glaucoma first, whatever the patient says, because he can have it done if he wants to from another center. I would not do it in an unstable case. In stable, maybe after all the consents and everything, but still I would not be very much inclined to it. Now, the other thing to look into is a clear lens extraction. That is like a better option than going in for a corneal refractive surgery procedure. So these are like options that are good for me, but it could be like different for other people. So it's like a total open world for everyone to make his own decision.
Sir, I will add another question for General Mazhar. Sir, have you ever seen a patient of glaucoma with normal ocular surface?
Oh, thank you very much for. What I was thinking about, I would say, in Pakistan, if you do any kind of a surgery, that will be the reason why he is going to get another problem. अगर आपने कैटेट सर्जरी की है तो उसने कहना मेरी इसका आँख में पानी है, मतलब मेरी आँख का ऑपरेशन हुआ उसके बाद ये हुआ. तो ये एक ऐसी चीज़ है जिसमें मतलब I think so one has to be very careful, and I would, even if I is stable and everything, I'm going to call whole the family, and I would rather have a stamp paper telling him that this can happen, this can happen. So one should be very reluctant. And as very rightly pointed out, that what happens when we use anti-glaucoma drugs with the anterior surface of the cornea. And I think so there are not one paper, there are thousands of papers now that the effects on the tear film the effect on its the acquisition, the suppression, and whatever this happens to the front surface of the eye, the epithelium, hyperplasia, and everything like that. And afterwards, when he's going to keep up, on one hand, we gave them this teardrops afterwards for a considerable period of time. And in these cases, when you disturb the surface, corneal surface, it's going to be a problem. So I think so, it's not an absolute contradiction, but I think so one has to be very, very careful, and you have to explain in a more elaborate way, even if you want to do it, and telling them that what can be the effects of this thing. Thank you.
I saw smile on my glaucoma madam's faces जब मैंने corneal surface की बात की. So इस पे एक मैं आप लोगों को बताऊं कि एक पेशेंट था हमारा जिसका refractive error was only -1. He came from UK and he was after me, known to us. बहुत मैंने उसकी मिन्नतें की, हाथ जोड़े, प्लीज़ मत कराओ. एक ड्रॉप वो यूज़ कर रहा था. But he was after me and I kept on telling, and then I calculated and ocular surface and everything, and finally I did his surgery. He is happy and everything, but अभी तक मेरे दिल में एक परेशानी रहती है कि वो ocular surface उसकी definitely tear film come already with drops, ocular surface ख़राब हो रही है. With refractive surgery, definitely we are changing the tear film, definitely it gets affected. So अब long term क्या होगा अभी तक तो वो नहीं आया मेरे पास. It's been 5-6 years, but it's definitely a relative contraindication. We can do in controlled cases, जैसे books हमें बताती हैं, no visual field defects, no nerve damage. It can cause decreased corneal thickness, underestimation of IOP. Extremely important to counsel the patient. Correction factor while checking IOP after surgery. Corneal thickness आपने change कर दी है, बाद में IOP ज़ाहिर है आपको देखना है, खुद भी देखना है, patient की भी बहुत counseling करनी है. Post-op steroids जैसे sir ने discuss किया. So if you ask me, I now at this stage, after so many years in refractive surgery, I think I would not like to do refractive surgery in glaucoma patients. So yeah, that's what I was about to ask. If you want to add anything, आप उधर दे दें. No. Okay.
Because it changes the corneal biomechanics, and intraocular pressure is the. So I also tell my patients that no surface procedures. So if they undergo a LASIK or any corneal refractive procedure, the corneal biomechanics is changed forever. So we monitor glaucoma mainly based on intraocular pressures mainly in our setup. We don't have OCT available and visual fields, and patients are sometimes not they don't produce very reliable visual fields as well. So when this one parameter is is unreliable after doing this refractive surgery, it's very difficult to monitor patients, and it's difficult to manage patients post-operatively. So yes, like Sir Amir said, that the other refractive procedures are open for them, lenticular procedures. So yes, go ahead, because removing the lens is beneficial for their glaucoma as well. So that can be done, but no surface procedures.
Patients भूल भी जाते हैं. अभी आप corneal topography करें और आपको flattening नज़र आ रही है और उनका आपकी सर्जरी हुई है कि नहीं, तो फिर हाँ वो तो 15-17 years पहले हुई थी, वो याद ही नहीं है. तो इस तरह भी होता है. तो you have to make your decision according to your clinical judgment and according to the patient. Another question, similarly, when patient comes to you, she is diabetic, well controlled, on oral medication, no diabetic retinopathy. Would you like to do?
Diabetes is another important topic. And there is no hard and fast rule, no absolute contraindication, but each patient has to be assessed separately, because diabetes affects the eyes in so many different ways as well. It affects your cornea, wound healing, it affects your retina, as we all know, it affects your lens as well. So a full examination is very important. As you said, no diabetic retinopathy, but you might get it later on. No diabetic retinopathy, well controlled maybe, but you have to explain it to the patient that if he might get diabetic retinopathy later on, and he might get macular edema or things like that, which is going to compromise his vision. As I think I overheard you that patient always attributed to your surgery. Whatever goes wrong, they start before surgery I was like this, and after that this happens. So if diabetic retinopathy is even taking its course, it might be attributed to your procedures, although you explain it to them. Laser is not going to penetrate to the retina. And at that time they say, yes, we understand, but actually they don't understand. So well controlled, cornea okay, healing, and no diabetic, very young patients maybe, but explain everything to the patient, what they might encounter in the long run. And rule out lenticular opacities which may be there, rule out everything. A full examination is mandatory. You gave me a very easy scenario, no diabetic retinopathy in anything. So maybe yes, but as I said, counseling is very important.
Now, sir, if scenario for you, if a patient has diabetes for the last, say, 12 years, early diabetic changes, pre-proliferative change, mild NPDR changes, patient is on oral hypoglycemic, but her HbA1c is 7.5 to 8, not less than that.
I think this clearly indicates that the diabetes has not been well managed, so needs to go to a medical retina clinic and to a diabetologist rather than coming to a refractive surgery clinic. So these type of patients do have got like other psychological problems as well, because they're having difficulty in life. So I would not like to own their psychological problems by doing refractive surgery.
Well said, Amit. I think so. That is the very important thing कि वो जो आपका मरीज़ है ना, वो सारी प्रॉब्लम्स आपके बैग में डाल देगा, क्योंकि आपने सबसे ज़्यादा पैसे लिए हुए हैं. उसको डायबिटीज़ की गोली जो है ना, उसको से वो एक गोली 10 रुपए की 20 रुपए की मिल जाती है, लेकिन आपने जो 2 लाख रुपया लिया है वो उनको सबसे ज़्यादा चुभेगा, और वो कहेंगे सारी एट्रीब्यूट उसको करेंगे. देखिए, and I think so, even if you have got I think so, anything what the scenario which you have Dr. Sadi has said, and there's no go, it's an absolute contraindication. Even those cases which have got no diabetes, I would, and if you feel like it is just an early diabetes, still go for an OCT. Let me tell you beforehand. Even if you think of doing a refractive surgery, do an OCT, because the subtle ERM changes, you may find them, and they are very, very difficult to treat. Even what to talk about in refractive surgery, even after putting a lens implant. These are the patients who are going to cause a lot of problems. So make sure that you do all whatever you have got in your investigations before you even touch a diabetic patient. But as rightly said, the moment you hear of diabetes, your blinkers should be on, and you should try to avoid them.
Especially like ophthalmologists like me who are not into medical retina, like surgical retina, we do not look into retina the way the medical retina doctor would look into. They can like judge out the ischemic areas, the non-ischemic areas, the peripheral neovascularizations, the collaterals coming up. So for that thing, it might be like we might have done a refractive surgery in such a case, and it outbursts like within 6 weeks or so. And there is a hemorrhage even after putting in a pressure of a femto. So that's not fair with the patient and with the procedure as well. And then we just try to hide behind different things. I think that would be unfair.
Patients की तो खैर क्या बात करें, अभी ये it's not related to refractive, लेकिन 2 दिन पहले मैंने एक पेशेंट देखी और वो आई कि मेरी आँख का हाल ख़राब हो गया जब से मैंने सर्जरी कराई है. सर्जरी वॉज डन कहीं और से, कैटरेक्ट सर्जरी, और 2022 में, और शी केम कि जब से मेरी सर्जरी हुई है उसके बाद से मेरी नज़र ठीक नहीं हो रही, ख़राब होती जा रही है. जब उसको देखा तो शी हैड डेंस विट्रियस हेमरेज एंड शी वाज डायबिटिक. कभी बिकॉज ऑफ द डायबिटीज़, नो इट्स नॉट बिकॉज ऑफ दैट, मैं पहले बिल्कुल ठीक थी, अब मैं ख़राब हुई हूँ सर्जरी के बाद. सो देयर आर कॉन्सेप्ट्स विच यू कांट चेंज, विच यू हैव टू री इन्फोर्स Coming back to diabetes in refractive surgery, so it's a relative contraindication. What the book says that if the HbA1c is strictly controlled, less than 6.5, for a minimum period of 6 months, no evidence of systemic or ocular complications, no signs of lenticular changes. Corneal sensation is very important to be checked. You have to rule out neuropathy. Slit lamp examination to exclude tear film abnormality, epithelial defects, basement membrane irregularity. And then at the end, if everything is normal, then LASIK is preferred over PRK because of the slow healing epithelial response in such patients and more chances of punctate epithelial erosions. So dry eye syndrome. A patient comes to you with a lot of frothing on the eyelid margin, and his refractive error is -5. Difficult to open the eyes, but still insisting that I want to get refractive surgery done. This happened actually with me. She could not open her eyes, बिल्कुल आंखें बंद थी, फोटोफोबिया था कि नहीं पहले आप ऐनक उतार दें, उसके बाद फिर मैं ये ठीक हो जाएगा बाद में. ठीक है, तो वो आप क्या करेंगी उस पेशेंट के साथ?
जो सिनेरियो आपने दिया है उसमें तो एब्सोल्युटली नो. मतलब कि फ्रॉथिंग भी है, एंड शी कांट ओपन द आईज, सो दैट आईज हैज टू बी ट्रीटेड फर्स्ट. And if generally if you are talking about if dry eyes is a contraindication, it's not an absolute, but it depends on the severity, mild, moderate, severe. So a full examination is again mandatory. Look at the tear film, breakup time, corneal sensation, fluorescein staining, everything. And dry eyes has to be treated first. And we all know that refractive surgery affects the corneal surface, it can make it worse, especially the LASIK procedures. So first treat the dry eye, and if it is very much under control, then you can go ahead, but not the scenario in which you described me, but generally you can go ahead, but after and before, a lot of vigilance needed. LASIK is a definite no. You can go for a smile, or patient can't afford, then PRK maybe yes, but a lot of lubricants and everything, and a lot of explanation in mild cases. And the cases which like ocular surface diseases are involved, like you said, it looks something very bad, then that scenario, no.
I agree with Dr. Savar till the point that we should not be doing a severe dry eye case. In a mild dry eye case, we have to explain them that they might need lubricants even for life afterwards. Dry eye is a condition that can even get worse with or without refractive surgery procedure. So they have to be very clear about it. Now, there's a very interesting concept that was coming in when we started SMILE sometime in 2017. Zafar Sahab started before us. We basically started because one of the basic reasons was that we'll be able to do dry eye cases. But there have been lots of studies published now which tell us that 6 months down the line, the tear film behaves the same in both the cases, whether we have done SMILE or we have done femtolasic. So the advantage of doing SMILE in a dry eye patient is no more there. But having said that, patient has to be very clear that dry eye will get worse with time. It never gets better.
I think so. Dry eye is a problem, and that one has to. But I think so. Explain to all the thing. But I think so. What kind of a test would you like to do before in a refractive surgery? Before doing a refractive, do you just do clinical examination on a slit lamp, or should we go for a shimmer test, or should we go for a latest thing, or do you think only just having a slit lamp examination should be enough to give you an idea?
In our practice, we normally use multiple tools with it. But if on a slit lamp you can see a very clear, thick tear film, then going into very deep analysis does not make any sense. You can do that. There's no one stopping you from doing it. But logic should always prevail, and that is important. For exams, yes, you need to do a Shermer's. can do a tear breakup time, you can do all these things. But there is a thing called clinical experience. And these are like two schools of thought that I've seen my friends in US who would do everything to have a legal protection, and friends in Europe and in UK who would take clinical judgment as far more important. So I take clinical judgment as to be like.
I think so. I fully agree with it. I think so. If you see something very, very, if you feel there's a bit of a the tear film is there, or if you see any filaments there, if you see, I think so. Doing a BUT test is also a very good thing. Just put a drop of fluorescein and you can make it out. I think so. Clinical judgment is there, and so if you have got a good clinical judgment, you will always make out whether there's any problem or not. And only in those very severe cases in which you have got clinically, you can, if you see clinically something wrong in the eye, I think so that is the time when you should not do anything.
I think what I have noticed while we were doing different tests for the dry eyes, that most of the patients during Schirmer test, they have reflex watering, whatever you do. So वो कभी ठीक आता था, कभी नहीं आता था. And tear film breakup time is one test which is very reliable, which you can do on slit lamp, and you can check the tear film if you have any doubt. So I normally try to do tear film breakup time in all of these patients. Why it is very important to check for the dry eyes? Because another important thing which I showed earlier is the epithelial mapping and the corneal topography. If the patient has dry eyes, you have to see the epithelial mapping as well as the corneal topography. You have to repeat topographies if you have any doubt about the dry eyes, because it affects topography, it induces higher order abrasion, affects visual acuity and refraction. There will be change in K reading, it changes the corneal thickness, there will be inaccurate biometry, biomechanics will be affected, dissatisfaction after effective surgery. So this is not an absolute contraindication, but a relative contraindication. A patient with mild dry eyes, you have to treat first. If the patient gets treated, then you can proceed. But if the patient has dry eyes which is persisting, then it's better to avoid refractive surgery. So coming back to that patient, वो मैंने पहले जिसका जिक्र किया, I'm treating that patient, उसको सब कुछ किया, at least उसकी आंखें खुल गई हैं, और वो she is still coming back. Breakup time उसका 5-6 seconds पे मुश्किलों से पहुंच गया है. She is still insisting, and I'm still refusing. You know, it can't be done. Sir, there is there are a lot of patients we see in our practice, in those who are high myopes and those who have been advised 360-degree prophylactic laser before proceeding for refractive surgery or any procedure. So do you recommend doing 360 degrees prophylactic laser in patients with white without pressure or with just the lattice with no holes in tears?
Here the scenario, atrophic holes. That is, atrophic holes can be innocent as well. I mean, in the sense you have to have a full examination, and you said that it can be associated with lattice as well. This is again a very tricky scenario. I think I would personally go for laser before going for these cases, but sometimes if they are innocent, there is no vitreoretinal traction involved, then you can observe them afterwards, a very close vigilance. And LASIK can be an issue because of the fluctuation in the intraocular pressure at that time, which might induce vitreoretinal traction. So, but if you are in doubt, then go ahead for laser, I think. This is my thinking.
I absolutely agree with Dr. Saiba, because not for atrophic holes, definitely, but if there is lattice present, the important thing is, like, is there any advantage or disadvantage of putting in laser? The question that pops in my mind. One thing is, there is no disadvantage. There might be an advantage if with time anything pops up in there, hole comes up, or there's attraction and there's a tear. So you've already covered yourself. So applying laser to those lattice or weak areas, I would certainly do that, but not too white without pressure.
Won't it induce holes in the future if you apply laser
Laser does not induce a zone. Don't use that high energy. That
So I would like to
burns it
request
out.
retina specialist
Yeah,
to
with,
comment on.
with the prophylactic laser, you don't need to do charring of the retina. What you need to do is just apply a gentle laser, a gentle mark that leaves behind. That's good enough.
I'm very happy that one of our veteran surgeons is putting his hands up. But just I'm going to give it a brief scenario of this thing. कि अगर आप ये सारी मीटिंग यहाँ से हम चेंज करके ना सारे यहाँ वेटो रेटिनल सर्जन्स बैठ जाए ना और ये आप एक सवाल करते हैं कि ट्रोफिक होल्स को रेटिनल पेरिफी में करना चाहिए नहीं करिए देयर विल बी ए कंट्रोवर्सी एंड आई बीइंग ओरिजिनली अ वेटो रेटिनल सर्जन सिंस 1980 मतलब मेरा ख्याल है मैं 88 में से जाना अमेरिकन एकेडमी में जाना शुरू किया था उसका एक रेटिना तो दिस कंट्रोवर्सी इज स्टिल गोइंग ऑन टिल नाउ कि वेदर वी डू इट और नॉट So if I would be the one answer to give, Amir has very correctly described it. I think so because now we have got so many vitreoretinal surgeons around town. I think so if you find something in which you feel that you should better give him have a look at them and decide about it. Then let's take an opinion of Kashif about this.
Most of the patients, thank you very much, Sir Dr. Kashif from Lahore. कि ये सवाल तो रोज़ाना हमें भी फेस करना होता है मगर क्योंकि मेरा सवाल वैसे दूसरा एक पहले था कि आई मीन डज इट ऑल्सो डिपेंड्स ऑन द टाइप ऑफ रिफ्रैक्टिव सर्जरी एज वेल इफ ब्रेक है या ट्रोफिक होल है मगर आप उसको सिंपल पीआर के वर्सेस ऐसा प्रोसीजर लाइक लैसिक जिसमें आपने प्रेशर बढ़ता है
अच्छा
तो पहला सवाल तो ये कि क्या वो प्रेशर बढ़ने से वो
एक इसका मैं आपको जवाब दे दूं सर इसमें एक मेरी बड़ी डिस्कशंस हुई थी एंड नॉट बिकॉज दिस आई एम वेरी मच कन्विंस अबाउट दिस थिंग कि देयर इज नो इंटरनेशनल पेपर एनीवेयर जिसने हैज बीन प्रूवन कि जी आपके इस प्रेशर की वजह से रेटिनल डिटैचमेंट हो गई थी मतलब दिस हैज बीन ये एक नहीं मैंने 25-30 एक रिव्यू आर्टिकल्स आए थे हमने पूरा इसको किया था सो देयर इज नथिंग लाइक दिस हाँ 100 जिसमें ये है कि दिस प्रेशर विल नॉट लीड टू होल मतलब रेटिनल डिटैचमेंट सो दैट इज नथिंग यू डोंट हैव टू डिसाइड आपकी किस टाइप की सर्जरी करनी है
just to re-emphasize, जो eye pressure जो कि जिसे हम बहुत scary होते हैं यानी there are like two different machines that actually carry on with the eye pressures. One is in which there is a handheld apparatus and then there is an arm that comes in. The total difference of pressure between the two is less than 10 mmHg.
Okay.
So if like say I'll be more blunt with the names. Let's say okay, if you're using Smile for eye pressure, so it goes up to 30. In LDV, it goes up to 40
or 50, yes.
Not even 50. Okay. It's 40 and less.
Okay.
Because above that, there'll be a central retinal artery occlusion. And then you'll have troubles. So it's not possible it goes above 40. And that's not bigger pressure to cause any problems onto the retina. And there are like lots and lots of studies for that.
Well taken message. So it's not a big problem. About the whole thing, so do you think if there is a patient, because most of these patients are always myopes who are coming for refractive surgery, and especially most of them are in their 20s or 21 or 22, and they don't have a EVD developed at that time mostly, and you never know what will happen afterwards. So what about the patient who have been treated, their breaks have been treated? If they come now, I mean, they have, for example, supratemporal break, well laced and everything, he is -4 or 5, and he comes for and wants a refractive surgery. What about this scenario?
मैं इसी का जवाब आपका जो है ना if you have treated a prophylactic laser कर दिया whatever the reason you can go for refractive surgery as simple as that. I think so that is why because this is mainly for general ophthalmologists if you find a patient like this who has got if you do have I think so the first question is कि क्या आपको पहले fundoscopy करनी चाहिए नहीं करनी चाहिए so that is the first question. I think so you have to dilate them and have to have a look otherwise आप periphery में hole कहाँ देखेंगे पहली बात कितने करते हैं that is also very important that we should see the periphery of the retina by dilating them before we do for LASIK surgery. Is it been practiced all over the world? No, it has not been practiced all over the world. So they have a gross look around it. It's not. लेकिन अगर आपको कोई ऐसा नज़र आता है then you have a look at the retina, see if there's anything. If you require a prophylactic laser, go for it. Show it to your colleague or if you are yourself very confident, do it. And then all of these studies which we have said is they have not been able to prove that LASIK or SMILE or PRK will lead to exaggerate the retinal detachment symptoms.
Okay. Thank you.
But sorry, लेकिन इसके साथ साथ मैं ये बता दूं refractive lens exchange अगर आप करेंगे at the age of before of 45 years old without PVT development, 40 to 45% recorded है कि उनको arterial attachment हो जाएगी. So मेरे ख्याल इसके बाद we'll have a discussion on this thing. ये बाद में discuss करेंगे.
Sir. Atrophic hole doesn't require treatment. You can observe or follow up the patient, counseling of the patient. If you find a tear or the round holes, such patients need prophylactic PRP around it, and then wait 2 to 3 weeks after the PRP and then do it. My, again, concern is about the 360-degree PRP. So 360-degree PRP is not recommended before doing any femtolesic or PRP or PRK. So it is not recommended because it can initiate holes in the future or tears in the future. Sir, because of limitation of time, I would like to skip few questions and I would like to come on this one because इसके बाद मैं आपको एक और केस दिखाना चाह रही हूँ. So एक patient आपके पास आया, you calculated, you saw the topographies and you calculated PTA, which is
percentile tissue alteration or ablation. Percentile.
नहीं, मैं वही बता, sorry, मुझे समझ नहीं आई आपकी बात. Percentage of tissue altered. PTA is percentage of tissue altered. एक patient आपके पास आया जिसका आप जब calculate किया तो PTA comes up to 42, 43, लेकिन residual stromal bed is good, 300, 310. So would you do the refractive surgery in that patient?
Percentage of tissue altered is very, very important because that tells about the risk of ectasia. So 40% is borderline or high, so keep it below that. Even if your residual stromal thickness bed is, as you said, good. So then you can do a procedure in which you can preserve tissues more. Because in, femtolesic, traditionally the flap is 120 micron, although some people are doing it 100 micron or 110, but traditionally we say it is 120 micron. And in case of PRK, it is only epithelium which is removed 50, 55 micron. So you can save about 70 micron of tissues there. So 40 is no. You have to change the procedure. You should not go ahead with the procedure you have planned. And if it is still there, I think I would not do it because the risk of ectasia is high. And if still you want to go ahead, make sure you do a CXL or tell the patient later on that this is what I'm going to plan. This is my opinion.
For me, going in with a higher PTA, I would not recommend that. As Dr. Sab has already said, like we can change the optical zone, we can change the type of procedure, we can add on CXL, all these things are there. But once we are dealing with the unhealthy cornea, it is usually asking for trouble. So it is like something that we have to be really sure that why PTA is higher, because thickness might be there, but have we got a proper epithelial mapping done? Have we got other factors looked into? Because if PTA is higher, then we have to look into other factors and we have to be absolutely sure that we are not touching a diseased cornea.
Thank you, sir. Gigi, please.
Regarding the percentage of tissue altered, we take into account the flap thickness, the depth of ablation, and of course the corneal thickness. So all these things, how do we calculate in SMILE? Dr. Mushtaq is sitting here. How do you calculate in case of SMILE? There is no, pardon? The cap thickness. You take into account the thickness. Second thing is, 3 days before I had a patient with 41 PTA. So I reduced the flap thickness to 100 instead of 110. So is that normal procedures?
Yes, we normally do flap of 100 microns.
And either we can alter the diameter of the ablation depth?
You should not alter the optical zone if the patient is high myope, because there is something which is known as efficient optical zone. So in high myopes, when you reduce if you plan 6.5 millimeter optical zone, after that, when you check the optical zone on topography after doing the refractive surgery, it is always smaller than that. It's either 5 or 5.5 in high myopes. So अगर आप उसको 6.5 से छोटा करेंगे, optical zone और कम हो जाएगा. So in that case, patient will experience more higher order abrasions after the surgery. So it's not recommended to reduce optical zone in such patients. If you have to reduce the optical zone और आपकी वो thickness भी कम करके भी पूरा नहीं हो रहा, it's better to go for phakic ICLs
And
instead
even
of
41% is not accepted.
41, depending upon the age of the patient. If the patient is very young, बिल्कुल भी नहीं, और 41 तो even then 41 भी नहीं. ये जैसे मैंने
The alarm bell starts ringing once it's above 35. So as Dr. Saide said, like if the patient is high myopic, still if you're using a 6.5 zone, it's not necessary to drop down to 6. We can drop down to 6.2 or 6.3. And then as you've done, like thinning out the flap, that is another thing. Add on CXL, that is another thing. So these are like, there are multiple options.
Thank you very
So
much.
you did the right thing, I think.
But I would suggest, if I was doing it, I would have switched to PRK to save at least 70 micron rather than 10 micron.
the percentage of tissue altered, it has to be less than 40%. 40 means less than 40% of the total corneal thickness you can ablate, not more than that. So if it is more than 40, there are higher chances of ectasia, and you can alter the ablation depth, flap thickness, or the optical zone accordingly, as is shown here, that after reducing the flap thickness from 120 to 100, you will come back to 39, जो आप पूछना चाह रहे थे. इसमें हमने जो है optical zone को change नहीं किया. Now coming to the last question, because of time ख़त्म हो रहा है, I would like to show this case which we saw in our setup. So the patient had refractive error of minus 4.75 with 4.25 of cylinder in right eye, and in left eye minus 1 sphere and minus 2.25 diopter cylinder at 180 degree axis. Pachymetry in right eye was 518 and in left eye was 521. So just looking at the pachymetry and looking at the refractive error, PTA तो हम calculate कर लेते हैं ना, एक rough calculation, 4 and 4, 8, तकरीबन 9 diopters बन गया ना. तो 9 diopters with pachymetry of 518. Would you go for that patient? एक मिनट मैं scans आपको दिखा दूँ. इसको screen को enlarge करें please. So ये patient की गैलीली जो मुझे available थी, pachymetry is 518, ठीक है. K readings 41, 45, astigmatism 3.7, जो कि topography पे है. Treated was 4.25. अब ये आपको right eye की topography है और ये left eye की topography है. Tomography, not topography. 42, 45, flat and steep with thickness of 5 to 1. तो अब ये just by looking at the scans, do you think these scans look normal? मेरे पास सिर्फ यही है क्योंकि पेशेंट यही लेके आई थी.
Right eye is tricky, very tricky.
Do you want me to answer?
Sir.
Yeah, इसमें like आपके पास तो लेके आए स्कैन, लेकिन आपके पास क्योंकि गैलीली मौजूद है, you can always repeat a Galilei to make it more centered.
So the patient came to me in January. She got refractive surgery done.
अच्छा, करवा के आया?
जी बिल्कुल. With these scans, ये भी जब फिर मैंने कहा तो मेरे पास ये scans भी आए और मेरे पास फिर एक प्रिंट आउट भी आया जिसमें सारी ट्रीटमेंट हुई हुई थी. ये हमारे श्विंड वाला जो प्रिंट आउट नहीं आता पोस्ट ऑपरेटिवली, वो भी था जिसमें ऑप्टिकल जोन वाज 6.5, सॉरी ऑप्टिकल जोन वाज 7 with that refractive error which was treated, जो मैंने आपको ये दिखाया. And this was the topography which she had.
With this scan, I would not. I would repeat a scan in a proper sense, और फिर then I will do it. क्योंकि I'm not happy with the scan actually. It's off-centered.
Sir. So this is what exactly I want to show. This is the last slide which I am showing. कि अगर और कुछ नहीं तो hotspot तो नज़र आ ही रहा है ना ये. So you have to.
Yeah, this hotspot could be just because of off-centration. Epithelial mapping is important.
Reduced signals हैं. We can't comment. हॉट स्पॉट है, थोड़ा सा हमें लग रहा है कि ये ठीक नहीं है, इधर से भी मिस्ड एरियाज़ हैं, यहाँ पे 24 एलिवेशन है विच इज़ हाई फॉर गैलीली. फॉर लेफ्ट आई ये आपको टंग नज़र आ रही है, 17 तक ये 11-12 ठीक है, बट दीज आर सस्पिशियस स्कैन्स, दीज आर नॉट नॉर्मल स्कैन्स. और चलें अगर ये नॉर्मल भी होता, फॉर एग्जांपल अगर ये नॉर्मल भी है, अगर आप PTA कैलकुलेट करें विद दैट रिफ्रैक्टिव एरर विच वाज ट्रीटेड इन दैट पेशेंट, so PTA is 51 in right eye and 29 in left eye. So was that justified to go ahead and do the refractive surgery? And the answer of that doctor, because मैंने तो confront किया कि ये क्या किया, तो answer was कि machine ने तो calculate कर दिया था और उसमें तो कोई red signal नहीं आया. So I have done it. So this is the take home message which I would
Dr.
like
Sadia,
to...
I have faced a similar situation. A refractive surgeon in fact showed me कि ये क्या हुआ, इसको ectasia क्यों हुआ है. And I said, just show me this, what was the PTA? We calculated, he had no idea about what PTA is. And when we calculated it, it was 47%.
47.
And he ended up in ectasia, that
So
patient.
this patient, I had to counsel her a lot. She has not returned yet. She will ultimately end up in ectasia, I am pretty sure about it, with those scans. So
I think you're absolutely right about it, because ectasia would not pop in the next day.
Yes.
It would take certain time. There is a honeymoon period जिसमें कि patient बहुत खुश होगा. The surgeon absolutely satisfied, thinking about कि everything is gone well. And then they turn up like one day when you're least expecting. And that day is when you're busy, and that day is when you're not having good time. तो वो and once you see them, तो that is a nightmare.
she came to us because the next day her flap was re-lifted. I don't know what was the reason. There were impurities, or she came with DLK with in right eye. उसकी vision अच्छी नहीं थी, वो तो अपनी second opinion लेने आई, और वो फिर जब ये सारा देखा तो आगे से ये भी था. So अभी तो जनवरी से अब ये जून आ गया. She had to go back to UK. She just came from UK to get it done and go back. She landed up with it. So take home message is, please calculate PTA. PTA is very important even if residual stromal bed is normal. अगर आपका residual stromal bed जो है वो 300s में भी आ रहा है लेकिन PTA high है, तो you cannot go ahead with refractive surgery. You will end up in ectasia ultimately sooner or later. So I think with this we should end here. Thank you very much, worthy panelists and the audience, for your patience listening, and I hope आप सब कुछ सीख के जा रहे हैं यहाँ से, and we have been able to communicate something, the basics which should be kept in mind while you plan a patient of refractive surgery. There are a lot more questions which I have planned, but because of the limitation of time, we cannot proceed with those questions. Thank you very much. Thank you, Dr. Amir Star and Professor Sophia.
Thank you so much for the invitation to you. Thank you.
Shields. ठीक है सर, कल हमने कर लिया था, कोई बात नहीं.
All the participants to kindly take your seats. The time is now time to start the session. Speakers are Dr. Samira Irfan, Dr. Maqsood, Dr. Noor Fatma, Dr. Rashid Beg, and Khwaja Khalid Shoaib. Are any of these present amongst the audience? So, as usual, we follow our traditions of not coming in time. डॉक्टर ब्रिगेडियर आमिर साहब, ये जो हमारे ज़ीशान और ज़िया साहब हैं अवेलेबल, और ये जो थे ये प्रोफेसर साहब तो बैठे हुए हैं, ज़ीशान So we have two speakers at the moment, Beg Saab हैं और Maqsood हैं. So two speakers are still not available. That is a situation and that is a state of affairs, and then we ask for quality in the conference. सर आप जब कहेंगे फिर आप शुरू करूँगा मैं. हाँ 5 मिनट देख लेते हैं. आ जाए सर वैसे, अदरवाइज सब ठीक. Bismillah ar-Rahman ar-Rahim. Oh good, Professor Samira is also around. Thanks. How are you? So with the name of Allah, we start our proceedings of this symposium on orbital interventions. I have the honor to have the chair, Professor Ziaul Islam, with us. I will be moderating the session. We have a couple of speakers, alhamdulillah, got quite years of experience, and One thing I will request to the speakers that we have to stick to our timings. That's very important. Although I have no way to stop the presentation, but I will insist and request that please adhere to the timings. That's also a senior or juniors. We should, we know that how much we have to talk. So because we want to give ample time for discussion afterwards. That's what I have stressed always that it should be the discussion which is more important, interactive discussion, because that's how the participants learn from each other. So I request first speaker, Dr. Samira Irfan, who will be talking on ocular surface changes in thyroid eye disease. Late by 5 minutes, so this presentation is for 5 minutes.
Thank you very much, Professor Tayyab, Professor Ziaul Islam. Thank you so much for the invitation. मुझे बता दीजिएगा 5 मिनट, फिर मैंने भागना है. वो साथ वाले हॉल में दूसरी टॉक है. सर वो मेरे ड्राई आई का है उधर साथ, तो मैं कैसे आऊँगी? वो अभी मेरे से पूछ लें जो एक आध सवाल पूछना है. ठीक है जी. सो ऑक्यूलर सरफेस डिजीज इन थायराइड आई डिजीज. ये जो है दिस टॉक, दिस इज इन रिस्पॉन्स टू अ चैप्टर दैट आई वाज इनवाइटेड टू राइट बाय Xavier Books on thyroid eye disease. And previously it was thought that the ocular surface is affected in say 10 or 20% of the population, and that is also in acute thyroid eye disease. But when I was doing research, I was surprised for this chapter. The prevalence is 65 to 95%. And OSD, the ocular surface disease, is in both phases of thyroid eye disease, in active as well as in inactive thyroid eye disease. And 97% of patients, they experience symptoms of ocular pain, dryness, grittiness, and blurred vision. And if you treat the ocular surface disease, then their quality of life improves. So they are not that much affected or worried about their aesthetics, but it's the visual problems that they are more affected by. And if you correct the thyroid, this ocular surface disease, their quality of life improves. So few facts that you need to remember: that the cornea is hydrophobic, and the 3 layers of the tear film. This mucin glycocalyx layer that makes the cornea hydrophilic, and then so that the tear film can spread over it. But because of problems in thyroid eye disease, this blanket is lost, and whatever lubricants you give, the cornea is hydrophobic. Those lubricants, they are not going to wet the eye until you address this blanket, the mucin glycocalyx layer. So cornea is, as soon as there is one dry spot on the cornea, there are 70,000 corneal nerves innervating the cornea per square millimeter. So one dry spot, all layers of clear tear film are secreted and they wet the cornea. But this does not happen in thyroid eye disease. Why? Because number one, there is this aqueous deficiency due to inflammation of the thyroid, of this lacrimal gland, and the accessory lacrimal glands, because there is acute conjunctival inflammation as well. So the aqueous production is drastically decreased because of inflammation. And this happens not only in the acute phase, but when the acute phase subsides, then the lacrimal glands, they shrink and the aqueous deficiency persists. And that you can easily diagnose by elevating the lid, and you can see these, and then you can do CT, MRI, and you can see the swollen glands. So second is evaporative dry eye disease. Why does excess evaporation occurs? Because of all the changes that are occurring in the eyelids. Lid retraction, and then lid lag, and then this flaring, this lateral flaring of the eyelids. So the eyelids, they cannot close onto each other during blinking and spread the tear film onto the cornea. So the cornea gets dried up. So these things, they persist during the quiescent phase, and then there is lag ophthalmos, and then there is exposure keratopathy even during sleep, and increases the evaporative loss, and that disturbs the tear film and the health of the cornea drastically. And then meibomian gland dysfunction, this is present in 100% cases of active TED and in 80% of cases of the inactive disease. And when the meibomian glands, they are disrupted, then even though the aqueous deficiency may not be there, but evaporative loss increases. And then there is lid inflammation, blepharitis, and superior limbic keratoconjunctivitis, filamentary keratitis. All these changes, they seriously impair vision and quality of life of these patients. So the risk factors of ocular surface disease: increased age of onset of thyroid eye disease. These aging patients, they already have compromised tear production, increased duration, smoking, climate, radioiodine, and all the drugs. So my time is getting up. So why is early diagnosis important? Because thyroid eye disease is a chronic and progressive disease. Dry eye disease is a progressive disease, and if we diagnose it early, we can treat the complications early, and we can improve their quality of life significantly. So management is proper assessment why this patient has the dry eye disease. Is it aqueous deficiency? Is it meibomian gland deficiency? Or is it due to all the lid changes that are occurring? So we have to identify aggravating factors, tailored treatment for each patient, and patient education that it is a chronic disease and you have to really manage it properly. So I'm well in time. Thank you so much.
Thank you very much, Professor Dr. Samira. I think excellent talk, and in a very, this is an example she has set for other speakers. So,
any question about
yeah. That's what I'm saying, that we have, although we have decided to have the questions at the end, but because Dr. Samira has to attend another run on dry eye symposium, so I will request the audience, if you have got any questions, please address to Dr. Samira.
Superior limbic is actually under the tarsal plate. There is already conjunctival inflammation, and it's a combination of lid viper. As the upper lid closes onto lower lid, वो रगड़ा मारती है, and that. So to avoid that, lubricants, longer acting lubricants, preservative free, acetylcysteine, bandage contact lens. So these help. And tacrolimus. Tacrolimus is a magical drug that improves not only lacrimal gland secretion, but meibomian gland secretion, as well as goblet cell count.
So you advise 0.03%?
0.03%.
Yeah. Tacrolimus. This is also good for allergic conjunctivitis as well.
Perfect.
Yeah. So any questions, other questions, or I have some observations? So, Dr. Samira, this is where, sorry, yes, Beg Saab.
Tacrolimus ointment is available in Pakistan also.
It's a skin cream which is available in Pakistan.
Yeah,
so that skin cream, there is no nozzle. So you have to guide the patient that either with a fingertip you apply inside the conjunctival sac or with a cotton tip. It causes a little bit of stinging and burning because it is hyperosmotic, because it is made for the skin. So you have to tell the patient that it will cause a little bit of burning, but after 2-3 minutes you can put in a lubricant and that stinging goes.
Well,
but it is magical.
Yeah, it is available in Pakistan in the skin, for skin ointment. So I really always ask my patients, because when you go and purchase it, tell that they may tell you that it's not for eyes, but it is. We are using it for eyes for the last many years, and in refractory allergic conjunctivitis, it is a wonderful drug. Or in dry eye, as Dr. Samira said, so you can also use it.
Thank you.
So there are Excellent basics. You have just refreshed our knowledge. So I just want to add to my knowledge is what are the causes of aqueous deficiency and MGD because of TED?
Active thyroid eye disease is an inflammatory disease. There is inflow of all the inflammatory cells. So these lacrimal gland and the accessory lacrimal gland initially are inflamed, and then they heal by fibrosis. And so the aqueous production, because it's a T cell inflammation, once it settles, the lacrimal gland secretion is abruptly decreased. So is meibomian glands. Meibomian gland, the whole lid is inflamed, and meibomian gland secretion, they become thick. And since there is lid lag and lid retraction, when there is blinking, the act of blinking, there is contraction of the pretarsal orbicularis that compresses the ducts of meibomian glands, and meibum comes out. When this blinking is impaired, meibum stays pooled up in the ducts, and there is back pressure and atrophy of meibomian glands. So in addition to inflammation of the meibomian glands, there is back pressure because the action of pretarsal orbicularis is affected because there is lid retraction and because there is failure to blink. So this pooling up that causes back pressure, atrophy of and dropout of meibomian glands, and they're lost.
Thank you very much. We always, always get something from you.
You mentioned the role of cyclosporins, and how long do you use it, your experience?
Cyclosporin, again, that which is available in commercial form, that is 0.05% or 0.005%. My patients, they come with dry eye disease from all over Pakistan. They've been using this C-Spore and the other preparations, 0.05 for 6 months, 1 year, 2 years, and their Schirmer test is 0. Why? Because this C-Spore, this 0.05% is like water. What we need is, minimum is 0.5% cyclosporin, and which we have to prepare ourselves. If you cannot have 0.5%, then tacrolimus is 100 times more potent than cyclosporin in every respect. So use tacrolimus instead rather than that C-Spore, which is like water. It's very dilute.
Thank you. I think that's why we use also as a capsule. Vibramycin is a very standard treatment in diabetic eye disease.
Vibramycin is tetracycline, and tetracycline is anti-angiogenic, anti-inflammatory. It improves meibomian gland secretion. It reduces inflammation. Dry eye is basically an inflammatory disease. So this tetracycline has 4-5 excellent effects. That I have to tell in the next talk. Lekin ye tetracycline is amazing. So use that instead.
Thank you, Professor. We are really grateful. So I now invite Dr. Maqsood. He will be talking about an atypical presentation of orbital disease. Dr. Maqsood, you will keep to the time. I have put my alarm on.
Assalamu alaikum. I am presenting a typical case of a 10-year-old female child. She was having swellings below her medial canthi on both sides. There was sometime discharge which was containing some thing of blood. She always used to complain about the nasal obstruction, and this was happening since last 3 months. There was on history, there was also change of voice she was giving from the last 6 months. She was afebrile. You can see the picture of the child. There are bilateral medial canthal swellings on both sides, and also the thing of blood coming out from the right nostril. So So this was the visual ocular examination, which was without any significance. The history is very important in every patient who is presenting with any like ocular or orbital or eyelid disease. So we took the history. There were history of left side multiple neck swellings 3 years back, and somebody took a biopsy from the nodes. It was B-cell non-Hodgkin lymphoma. She also gave the history of chemotherapy and radiotherapy, and there was no family history for any cancer. On general physical examination, she was pale, as you can see from the picture also. Pulse, BP was okay. Cervical lymph nodes, they were still palpable. We did the thyroid examination, abdominal and neurologic examination. It was not significant. The cogitation test was negative on both sides. As you can see, the swellings, they were reddish below the medial canthi, tense, cystic, and mildly tender. We cannot palpate the posterior border. There was fistula on the left side, as you can see. So what we made a huge list of differential diagnoses. That it can be acute and chronic dacryocytitis, it can be dacryocele, or there can be some stone there causing preseptal cellulitis, or maybe in fungal infection, or again it can be a primary tumor, or anything from anything elsewhere in the body or in the surrounding areas. It has migrated. We did the lab investigations, routine lab investigations, which were within normal limits. Regarding enzymes, the alkaline phosphatase and the LDH, which were the non-specific markers of cancer, they were raised. We did the ultrasound abdomen and pelvis to look for any primary or metastasis. It was normal. The CT scan of this region, the paranasal sinuses, orbit and head was done. And we see a humongous mass spreading from across the sinuses. So we then tailored our differential diagnosis to towards the oncology. We took the biopsy transcutaneously from the right side, and it turned out to be the lymphoma. So lymphoma, any group of blood disorders that develop from lymphoid cells, it can be of two types, T cells and B cells, Hodgkin and non-Hodgkin. In the ophthalmology, the non-Hodgkin one is more predominant.
You have 1 minute.
Okay, sir. Hodgkin is confined to the lymph nodes. Orbital lymphoma is associated with 30 up to 35% of cases of systemic lymphoma. Hence, a patient with orbital lymphoma should have a complete workup to rule out systemic lymphoma, and vice versa. In Japan and Korea, they are more prevalent. So for localized lesion, as we all know from the literature, it can be radiotherapy can be done. But if the disease is systemic, so chemotherapy should be done. And for very localized disease, surgical excision is the treatment along with radiotherapy. So visual prognosis is good if this lesion is treated with radiotherapy, but they need, of course, the lifelong follow-up. So the take-home message is that whenever a patient comes to us with any eye problem or eyelid problem or orbital problem, we should look for the whole body.
Thank you, Dr. Maqsood. What was the exact diagnosis?
Sir, it was non-Hodgkin B-cell
lymphoma.
Yes.
That's it. Yeah, thank you. So have we Dr. Noor Fatima? Our next speaker.
Thank you.
Is she around? Noor Fatima. So we can take questions for Dr. Maqsood now. Maqsood, उधर आ जाएं. If there are any questions addressed towards Dr. Maqsood, please raise your hands, address the chair, and then ask the question. No questions? Ji, Dr. Amer.
Yes, sir.
Just a comment. Lymphoma is a pretty common condition in the orbit and can present in varied ways and in various sort of masses, either unilaterally or bilaterally or in sinuses, involving the sinuses as well. So this is something which you need to keep in mind when you're dealing with orbital masses. And it's pretty common, and if you treat it early and well, they respond quite effectively to radiation and chemotherapy.
Thank you, Dr. Amar Saab. I think it's a good observation. B-cell lymphoma, if actually is usually a good prognostic lymphoma. It's a good prognosis. Sometimes we do not just observe the patient, but this was cosmetically so obvious, and it was bilateral. So in that case, of course, we need to have chemotherapy, to which it is very sensitive, and it is easily treatable. Prognosis is very good. But the one unusual thing about this patient was its location. Location of the lymphoma, which we have come across, is usually in the orbit and not going into the sinuses. That's a little bit uncommon, and at the same time, the age of the patient. It is, all types of lymphomas are reported in children, but most of the times we come across in the younger, a bit later age population. So thank you, Doctor. If there are no questions, we can proceed to the next. Thank you.
Okay, welcome, sir.
So I request Dr. Rashid Beg. He is our guest from Karachi, Aga Khan University, and he will be talking about a case of orbital apex syndrome secondary to malignant otitis externa.
Assalamu alaikum. So thank you for inviting me for this presentation. So my topic today is orbital apex syndrome secondary to malignant otitis externa. These are my learning objectives. Orbital apex syndrome is a rare condition where multiple cranial nerves and blood vessels in the orbit are damaged, leading to a variety of symptoms affecting vision and eye movement. Orbital apex syndrome is symptomatically related to superior orbital fissure syndrome. The distinction is the precise anatomic involvement of the disease process. Orbital apex located where the four orbital walls converge. The orbital apex incorporates the optic canal and the superior orbital fissure. The nerves involved the optic nerve, oculomotor nerve, trochlear, abducent, ophthalmic branch of the trigeminal nerve. So this is the orbital apex. Four orbital walls converge and form the orbital apex, and these are the bony openings like optic canal, superior orbital fissure, and the inferior orbital fissure. So these are the structures passing through the orbital apex. In the annulus of, within the annulus of Zinn, there is the optic canal passing the optic nerve and the ophthalmic artery. Within the annulus of Zinn, these are the superior division and inferior division of the oculomotor nerve and the nasociliary branch. Outside the annulus of Zinn, in the superior orbital fissure, these are the lacrimal, trochlear, and the frontal nerve and the superior ophthalmic vein. Causes of orbital apex syndrome are inflammatory, infectious, trauma, neoplasms, diabetes, vascular causes, visual loss and ophthalmoplegia involving the multiple cranial nerves, optic disc edema, subsequent optic atrophy, ophthalmoplegia with variable diplopia, mydriasis and ptosis, abscess of corneal sensations due to the involvement of the sensory nerves, relative afferent pupillary defect, choroidal folds, periorbital facial pain and hyperesthesia of the forehead due to cranial nerve, trigeminal nerve involvement, proptosis with or without orbital congestion, chemosis, and or connectable injection. So we have reported a case of orbital apex syndrome in a patient with malignant otitis externa. She is a 37-year-old female with 3-day history of vertigo, right-sided head, earache, discharge, right-sided facial weakness. Over a period of 2 days, she also developed visual loss, painful ophthalmoplegia, axial proptosis of the right eye. She is poorly controlled, long-standing diabetes and hypertension. Visual acuity in the right eye was perception of light, and the left eye is 20/25. Eye examination shows the right-sided axial proptosis, complete ophthalmoplegia, dilated and fixed pupil, pale optic disc surrounding pale retina with a cherry red spot at the fovea with cattle tract signing. So our provisional diagnosis was right-sided orbital apex syndrome with central retinal artery occlusion. We have ordered the CT scan and MRI, which shows the soft tissue thickening and fluid in the middle ear cavity along the external auditory canal, no bony erosions or evidence of mastoiditis. MRI shows the significant inflammatory changes along the right side of the head and neck, soft tissue thickening and edema of the right external auditory canal, fluid in the middle ear and mastoid ear cells suggestive of malignant otitis externa, inflammatory changes extending into the right orbit evident by proptosis, intraorbital fat stranding and edema of the orbital muscles, significant proptosis of right eyeball compared with the left one. So these are the MRI images showing the proptosis of the right eye. This image shows the fluid levels and inflammation of the external auditory canal. External auditory canal, soft tissue thickening, malignant otitis externa leading to osteomyelitis, mastoid fluid, temporal bone erosion, orbital fat stranding, all causes apex syndrome, and they have advised PET CT utility and diffusion weighted MRI for early diagnosis of the abscess. Malignant otitis externa typically spreads inferiorly. Orbital apex involvement is exceptional. This is the first reported case, only 3 cases reported afterward till now. We have managed the patient with IV broad spectrum antibiotics. IV methylprednisolone started after ID consult. The patient was kept under close observation, but despite aggressive medical treatment, the patient could not survive because of the overwhelming infections and sepsis. Poor prognostic factors include uncontrolled diabetes, delay in treatment, and central retinal artery occlusion at the time of presentation. Malignant otitis externa alone, 85% survival. Malignant otitis externa with orbital apex syndrome, there is a less than 30% survival rate. So orbital apex syndrome is a rare condition that presents with a complex of symptoms, including ophthalmoplegia, proptosis, and visual loss. This is the first reported case to our knowledge of orbital apex syndrome, secondary to malignant otitis externa. The closest match was a case reported in which otitis media resulted in orbital apex syndrome. In our patient with the soft tissue inflammatory reaction, started from external ear, spreading all the way to the orbital cavity, hence making it a very rare finding. Painful ophthalmoplegia is an important presenting complaint. Systematic approach to the evaluation of eye movement symptoms is necessary to identify the etiology and initiate treatment. Timely and aggressive treatment of the primary etiology is necessary as orbital apex syndrome causes high morbidity and mortality. Orbital apex syndrome can cause complete or near complete visual loss due to optic nerve atrophy. This was also the case in our patient. The role of steroids in orbital apex syndrome associated optic atrophy has been advocated. Multidisciplinary approach involving the otolaryngology, ophthalmology, infectious disease, and now emerging options of treatment like IV immunoglobulins, hyperbaric oxygen is also advocated. Take home message, the orbital apex syndrome, malignant otitis externa is a neurosurgical emergency. Screen for diabetes in all malignant otitis externa cases. Demand MRI plus ID consult as first red flag. Future directions, biomarkers for early detection and telemedicine protocols for rural areas. These are my references. Thank you very much for your attention.
Thank you, Dr. Saab. Dr. Beg, it was a very interesting case discussion. Are there any questions, please? Yes, Dr. Maqsood. खड़े होके माइक ले लीजिए. Have we got Professor Khaja Khalid Shoaib? No.
सर आपका ख्याल है कि ये मिडल ईयर से मिडल ईयर से इन्फेक्शन ऑर्बिटल कैविटी में चला गया थ्रू सॉफ्ट टिश्यू.
Exactly.
तो बीच में तो बोन्स भी है.
Exactly.
तो बाउंड्री इज देयर. ऐसा नहीं हो सकता कि वो सेपरेट हो और ये अलग एक सेपरेटेड एंटिटी हो.
So initially the patient presented with this vertigo and ear discharge and ear pain. So it was first presented in the medical and the ENT people. And after that, the patient developed this orbital involvement as well. And within a few days, it's a very fulminating and devastating, aggressive infection. So it spreads from the external aortic canal, middle cavity, and then spreads into the orbit.
Yes, actually the bone is there. So
you are asking why it spread to orbital apex from the middle ear.
I'm asking how it spreads. Like
oh yeah, that's why or how one and the same thing. So what is the linkage? What was the age of the patient?
37. 37.
Not diabetic?
She's a poorly controlled diabetes.
Oh, that was a precipitation. So it could have been, well,
So
this is what their conclusion is, but in the discussion we can say that it might have been a coincidental as well.
Yeah.
That's one, I mean, if you are not satisfied, then we can explain you that it could be because of, as a coincidental.
Two different diseases.
Yeah. So, the, sir.
Okay, thank you.
Did you involve ENT people?
Yes. ENT and infectious disease, they are all on board.
Okay. The one important thing which actually was really took the initiative out of your hands was retinal artery occlusion at the time of presentation.
Yeah.
So what do you think in all cases of orbital apex syndrome, there is a risk of pressure and central retinal artery occlusion. So have you got any figures? What percentage of orbital apex syndrome end up in central retinal artery occlusion, number one? And number two, what is the protocol to emergency treat the central retinal artery occlusion in such cases?
So because orbital apex syndrome involves the orbital apex and all the nerves and vessels, like especially ophthalmic artery also there. And there is a pressure and compression of these vessels can lead to central retinal artery occlusion. And because the patient is in have other problems like other uncontrolled infections, diabetes, and the patient presents late with us with this visual loss. And on examination, on the first examination, we have found that there is an optic atrophy and the pale looking retina with the signs of central retinal artery occlusion. We haven't treated the central retinal artery occlusion because
I mean, if in case there is an orbital apex syndrome, you diagnose it and central retinal artery is still intact and you are afraid that so how can we prevent that? From the house?
Exactly.
Yeah.
Exactly.
So I think we need to direct the treatment towards the primary cause of
Primary cause.
the central retinal artery occlusion, which is inflammation and infection or whatever. So that needs to be treated on an urgent basis, and we try and hope that if we can control it in time. But unfortunately, as you know, that if central retinal artery occlusion has been there for even 3 or 4 hours, then the recovery is unlikely.
Yeah, you're right.
So it's a difficult situation, yes.
Exactly.
So there are, thank you, Dr. Beg, thank you very much. Are there any other questions to any of the previous speakers? Dr. Smira has already given her answers. Dr. Maqsood is around. So any other questions or any point of discussion or orbital interventions before we wrap up the discussion? Mike.
Two separate foci. I mean, it's not necessary that it has spread from there. So, I mean, there's no, we cannot say for sure because of the immunocompromised status of the patient.
Well, actually, this is what actually I just try to satisfy Dr. Maqsood on that point. It could be coincidental, independent findings, but the presenter and those who have treated the case, they are the best to judge. They say that it was because of otitis externa. So, and the patient was diabetic, so probably, I really nothing, I said nothing. Dr. Beg, I think the same question. Yeah, wait. A coincidence could be. Yeah, could be coincidental. Thank you. Any other questions? There are some of our youngsters are sitting at a distance. Are there any questions or issues? Because we have time and we should utilize, and people like Beg and Dr. Amir and Dr. Sophia, they are around. और भी बैठे हैं, बहुत सीनियर्स बैठे हैं यहाँ पर, उनसे आप क्वेश्चंस पूछ सकते हैं रिगार्डिंग ऑर्बिटल इंटरवेंशंस. और so if there are no questions, I think people want to have a cup of tea. So I will request the chair to kindly wrap up the session. I know.
Bismillah ar-Rahman ar-Rahim. I think this was very interesting session, this orbital intervention. I just went through all these cases, and one of my advice was, they see around the orbit, there are all sinuses and nose and so on. So I think we must involve the ENT surgeon so that we can always get help from this, because ENT is all surrounding the orbit. And I must say that we should take advantage of their opinion as well. So with this, we would like to conclude the session. Thank you very much.
Draw my attention to the OSP President, Federal, Dr. Amir Yaqub, that there is a mechanism, there has to be a mechanism to stop this absence of speakers without assigning any reason. So we have 2 absentees today, and I think we should, in APAO they say that if you don't appear after your confirmation of your abstract, you will be banned from future presentations. So I think, without justification, I think we should take action in these cases, and we should at the end, all those who were absent without justification in this conference, they should be, okay.
Only informed yesterday that he's not coming, and Noor Fatma, I don't know where she works or.
I will recommend she should be banned from the next.
She hasn't informed at all, so okay. I think we'll look into it, and
someone should be made an example.
Yeah.
Thank you. So I request now to all the speakers, 3 speakers, to come forward and take their shields, and there will be a group photo at the end with the speakers.
Okay, ji, assalamu alaikum everyone. I think lunch ke baad ab we are ready to start again. So we are going to, this session is about prescribing glasses in children. And the topic was chosen to address the various confusions and possible differences in decision making by the concerned clinicians and optometrists regarding what to prescribe and what not to, and especially at what age. So I hope it will be a very productive and interactive session. I am Professor Sumaira Altaf, and I'll be moderating the session today. And I'm very happy to introduce our star-studded panel for today, which is Dr. Samira Irfan. She is an acclaimed international and national speaker, and with 79 publications and numerous awards to her name, including a lifetime achievement. Dr. Samira Irfan, please, you are welcome. Dr. Mubashir Jalis, a very well-known name, nationally, international experience, decades of experience in pediatric ophthalmology, and we look up to him for lots of decisions that we do make in our squint patients and also pediatric refraction. Besides a lot of other clinical expertise. Dr. Mubashir Jalis, you are welcome, sir. Professor Hanif Malik, my colleague and counterpart at Al-Shifa Eye Trust, Rawalpindi, and he has also a vast experience in pediatric ophthalmology and deals immensely with, especially with refraction, optometric decisions, and also a renowned surgeon in the field of pediatric ophthalmology. Last but not least, Dr. Mufarriq Shah, an experienced and well-known optometrist with his PhD done in Australia. He is working as associate professor at Pakistan Institute of Community Ophthalmology in Peshawar. We are so happy to have you with us. So, this is such a diverse topic, the refractive, the refractive errors and the management of refractive errors in children. And there's so much that affects our decision and whether to prescribe glasses, there's always a lot of confusion regarding it. So we'll be discussing the different types of refractive errors, the basic know-how about it, and then we'll be having some case scenarios at the end, which will hopefully engage the audience and also will give them the opportunity to discuss different case scenarios with our panel. So hyperopia is the most common refractive finding in children, and the prevalence of at least 6 to 8% of cases of around जब 6 months के old बच्चे होते हैं उनमें around 3 to 4 diopters का hyperopia होता है, and this leads gradually regresses. However, it has been seen that only 1.5% of this total hyperopic patients eventually develop accommodative esotropia. So most of these cases, they remain aligned and grow out of their hyperopia as they grow. So if you treat all of the kids who are significant hyperopes, you are unnecessarily treating about 75% of the cases. So you need to be careful about which of the hyperopes that you are going to treat at what age. Dr. Samira Irfan, may I may I ask you to give us your input or about the natural progression of hyperopic refractive errors in children and what to expect, how to manage the physiological hyperopia that we see in children.
Right. Assalamu alaikum everyone. Thank you, Professor Sumaira Altaf. It's lovely to be here, and this is a very, very important topic, and especially for the budding ophthalmologists. I mean, refractive errors, actually, optics has been removed from this FCPS exam. And this is, honestly, this is so wrong. Because all these patients, they are your patients, ophthalmologist patients. They are not the patient of an optician or an optometrist. They are per se your patients, and if you don't have a clue that optics and refraction hai kya, so how is this going to help the patient? So this is a very, very important topic. 45 or 50% of the population of every country are kids. And pediatrics of the or SAT, knowing about the refractive errors is, I think it is mandatory for every ophthalmologist. So please participate in this session. I think Dr. Sumaira has arranged an interactive teaching session. So please get your concepts clear and ask any question that really you want it answered. So it should be an interactive. Right, so regarding the question, I mean physiological hypermetropia, because the eye is 17 millimeter long when a baby is born. And as I told you in the morning, it grows maximum from the age of 6 to 9 months. And by 1 year, 80% length is acquired of the adult age. So in that 80% growth, the hypermetropia is reduced from 90% to 45%. So if a child comes to you with any other problem and you are just doing a routine refraction and you find the child has 4 diopter hypermetropia or 5, but the child is asymptomatic. Asymptomatic means he's not rubbing his eyes, the eyes are not squinting, and so you don't have to correct it. We only correct hypermetropia when it is causing a problem. And the problem the children, they come up with, they are rubbing eyes, or watery eye, or an eye going in, or in even high hypermetropia, the eye goes out. And especially in cases in which there is an Aico hypermetropia. One eye is emetrope, the other has high hypermetropia. That eye, due to amblyopia, it can go out as well. So in those scenarios, you have to step in and you have to correct them. Otherwise, the physiological hypermetropia, it gradually reduces on its own if the axial growth continues, if we or the parents don't interfere with the emetropization process, which I explained to you in the morning in myopia. Emetropization process is hampered with if the child is starting to use the eye for close, and that is when digital screens are introduced to babies, 6-month-old, 1-year-old. And then the hypermetropia, because the child is accommodating all the time, the axial growth stops there. The eyeball stays small and the level of hypermetropia stays there. Otherwise, natural progression is that hypermetropia, it starts reducing after the age of 4, and then by the age of 9, 10, 12, every child should be off glasses. Nobody needs glasses after 9, 10 years. So hypermetropia, it's high around in a baby, and then it stabilizes by the age of 3 or 4 and then starts reducing.
Thank you, Dr. Sumaira. My next question would be, if you find hyperopia, significant hyperopia in a child, would you undercorrect according to the age? And if you do, why do you undercorrect?
I have to ask.
Yes.
Okay. Why do we need to correct? Child has problems, problems of rubbing eyes, watery eyes, squinting eye, and then you check the vision, and you find if the child is more than 3, you can check the vision accurately, almost accurately, and if you find there is amblyopia, then of course you have to correct it. But if you find an isohypermetropia, one eye is emetrope, the other is high hypermetrope, and it is amblyopic, then in that case you have to correct it fully. Or if it's an ESO means the eye is going in and it is accommodative pattern to it, you have to fully correct it. And by full correction, you means hypermetropia is classified into latent and manifest. And latent is due to muscle tone. And I found that in most clinics, most hospitals, the refraction is done under cyclopen. Cyclopen does not relax latent hypermetropia. It does not relax the ciliary muscle tone. And the difference between latent and manifest, there is a difference of 1 to 2 diopter. So if you are doing cyclopen refraction, you are giving 1 to 2 diopters less correction. So in a patient who has esophoria or esotropia, you have to do an atropine refraction and give full correction.
Thank you. Like you stated earlier, that the rationale behind...
Dr. Mubashir was to say.
Please, go ahead, sir.
There is another type of patients, they are not so common, where they are hypoaccommodative. They have high number and they don't accommodate. You see them that when you do pre-cyclopenic infection, then you see that there is a large number, for example, 6 or 8. And when you do atropine and whatever you are going to do, you find that there is no change in the number. So the pre-cyclo and post-cyclo are same. In these patients, I have found that if you give them full correction, then they improve very early. So we need to give them full correction because they are not accommodating at all. When they start accommodating later on, then you can reduce the number accordingly.
So you would still give them full cycloplegic refraction?
Yeah, and there are patients who are hypoaccommodative. They don't accommodate at all.
In hypoaccommodative
They have a large number,
patients.
and you have to give them full correction.
Age.
They can be any age, 8 years, 6 years.
The question
10 years.
here
I've
was
seen
about
patients
the...
of any age. Young kids, yeah.
Okay. Like Dr. Samira, the question was about the undercorrection, and I think वो आपने point discuss कर लिया कि undercorrection हम क्यों करते हैं? Because then you leave behind enough of the physiological hyperopia so that the normal accommodation and the normal process of axial elongation can continue. Yeah. So thank you very much. So the next, briefly we'll be discussing myopia, जिसमें pandemic हमारे situation बन चुकी है, and everyone who is working with children and even young adults, they realize कि आपकी OPD में रोज के कितने ज़्यादा myopic patients आते हैं. So Professor Mubashir, what are the special considerations for correcting myopic refractive errors in children? आप जब कोई मायोपिक पेशेंट आता है तो आपकी क्या स्पेशली आप उसके बारे में सोच रहे होते हैं?
बेसिकली तो when the patient मायोपिया का पेशेंट आता है और स्पेशली अब जो बच्चों में बहुत ज़्यादा हो गया है, small kids they are coming with minus affections. So there are 2 or 3 things which I have to consider. First is what is the infection, pre-cyclo infection, and his behavior, especially when if you can do autoref. Whether there is a changing reflection on autoref, it keeps on changing, that means the child is accommodating too much. And then we have to see what is his vision. Now, if he comes for the first time, I will always go for cyclopedic infection because, especially in the children where the infection is changing. Yes. Because actually what happens is in autoref, the picture is like there's a picture painting, they're showing some distant object. And you assume that he is looking at a distant object, but when child goes near to the autoref, that it's an object which is very close to him. So there's sudden increase in his accommodation. So what happens that there is jump in myopia and masking of hypermetropia. So you have to do psychopathic infection in these cases, otherwise you cannot find out the true number. So for the first time, I always go for psychopathic infection. Later on, I may skip sometimes when I find that it has stabilized, vision is good, and there is not much change in infection, so I can just manipulate the glasses. But the first time, I think that you have to do psychopathic infection in myopia.
True. Because if you're not doing, maybe आप overcorrect कर रहे हो, because अगर वो बच्चा accommodation, like you said, if the child is using accommodation and you have not done a cycloplegic refraction, so you might correct the myopic refraction जो उसको चाहिए, right? So,
excuse me, the one thing more, I think everyone has observed these cases. There is a condition of ciliary span, which is we see patients who have very high number, blurred vision and headaches. And when we do vision, they are hardly 20/60 or 20/70, and the blurred vision. And when we do cyclopathic infection, the number suddenly goes down to 0,
yeah,
or almost normal. And these are the children who are having basically ciliary spasm. And I have observed that these are the cases who have A-type personality. They don't need glasses, but they need psychotherapy.
yeah.
I asked them, the parents asked the children that they should relax. It is good, it's okay to get less marks sometimes. You should not always be a topper in the class. Try to enjoy your life. Basically, they need psychotherapy and counseling.
Yes.
Basically, they don't need glasses.
And some of these children might have low hypermetropia, which presents as myopic refractive error, right?
One thing in the myopia, which nowadays is very common, is that children, they are used to mobile. With mobile use, there is accommodator swamps, and with autoref, you will see that she is -1, -2 diopter myope. But when you are doing, and the visual acuity is even 6/18 or 6/15, but when you are doing cycloplegic refraction, then the eyes get relaxed and there will be no refractive error. So for these children, you will be advised that actually they do not need. And some children even come because the optician at the optical shop, they just give the autoref number because their visual acuity is decreased due to accommodator swamp and gives induced myopia. They prescribe minus lens and they further exaggerate it, and the myopia increases. So in such cases, we should counsel the patient that they should reduce the mobile use, screen time, because these things are nowadays very common. And even nowadays, the autoref reading, most of the cases, they will give you hypermetropia undercorrect and myopia overcorrect because of these accommodators.
And these children also, they don't accept the glasses that you
Exactly.
prescribe
They have
them.
severe headache.
Their symptoms
Yes.
don't go away, and they are not very happy children, and the parents are worse.
Exactly.
they don't want to come back to you if you are not correcting it. So, so what rate of myopic progression, Dr. Mubashir, would you say is significant enough to warrant additional therapies for myopia, like atropine or bifocals or orthokeratology, etc.?
Pardon, can you repeat?
What rate of myopic progression would be significant enough in diopters?
So I think rate of progression is point.
For a younger child, say less than 5 years.
If it is increasing by more than 0.5 or even if it's more than that, then of course we have to do something, and then glasses, of course, we are giving him.
Yeah.
That was the point we discussed yesterday when
Yes.
we were discussing the role of atropine and other things. So progression is very important, and we have to be very careful about it. And
So-
at what number we have to give, at what level? So I think if vision is 6 by 7.5 or 20/25, individually I usually don't go with glasses. If it's binocularly 20/20, but if vision is 6/9, 6/12, something like that, then I will give him glasses.
Especially in older children, if it is like an increase of 0.25 diopters, would it still be over 6 months? Would it still concern you?
0.25?
Yeah.
No.
This is normal.
This is normal.
0.5 per year. under 5 years and 0.1 mm of axial length. This is normal.
Yeah.
If it is more than this, then you have to go for myopia progression management.
So we have to also judge accordingly what kind of therapy we are opting for in myopic patients, whether to go for atropine, glasses alone or not, or atropine and ortho-K are the most talked about and most effective therapies that are seen today. So the next refractive error that we are talking about is astigmatism. We see that more and more children are now coming up with significant astigmatism, and we need to know and treat it accordingly. It has been seen that between the ages of 6 to 12 months, around 23% of the children, they come up with significant astigmatism. And this, with the rule astigmatism, usually it starts dropping and becomes around those, what is left behind is around 9% at the age of about 5 to 6 years. And there are a few factors that may increase the likelihood of infant astigmatism, and which is family history, myopia, associated hyperopia, systemic or ocular conditions like allergies हैं बच्चों को या ptosis है, prematurity की history, it's again premature babies are significant, have higher incidence of refractive errors and including astigmatism, and also present times का जो dilemma है increased screen time and gadget use. So Dr. Hanif Malik, considerations for prescribing spectacle corrections for this was Dr. Mufarik Shah. I would like to ask you, what are your considerations for prescribing spectacle corrections for astigmatic refractive errors in children? When would you prescribe?
Because
spherical equivalent के बजाय आप separate astigmatic cylindrical correction देंगे.
For selling one thing, there is, we call it as meridional amblyopia. So if we do not correct astigmatism, then meridional amblyopia will occur. Now, one thing is that usually in children, if they are under 5, then the cylindrical number they usually decreases. But if the family history is strong for high astigmatism, then in those cases, the cylindrical error usually they do not decrease. One. So if even the research shows that when the cylindrical error decreases, this converts into the spherical error. Like a patient, if he has minus 0.5 myopia with minus 3 cylinder, then the minus 3 cylinder will decrease, but the myopia will increase. And if he has hypermetropia, then this minus 3 cylinder will decrease and it will compensate the hypermetropia. So the best thing is, if the patient is 2.5 years, you start Lia symbol, teach them, and go to optimum visual acuity. If you cannot go for the optimum visual acuity, then in the majority of cases with the rule astigmatism, the cylinder decreases and you can undercorrect. But in majority, with the rule astigmatism, usually in some cases they decrease it. It depends upon the lead tone. In some cases, if the lead tone is some floppy patients, they have tight lead tone. So in those cases, also the cylindrical number, they decreases, so you have to keep undercorrect. But if you can measure the visual acuity and with undercorrection, the visual acuity decreases, then you have to go for full correction. But these are usually, you can do it in 5 years or above. Under 5 is a bit difficult. Otherwise, the procedure is the same. But the most important thing, some people consider their children, they cannot tolerate oblique astigmatism. But actually, the problem is not the type of astigmatism. The problem is in the excess. It is easy to confirm the excess of with the rule astigmatism and against the rule astigmatism as compared to confirm the excess of oblique astigmatism. So even in adults, if you do the autoref, those who have against the rule astigmatism, you will get 3 or 4 reading the same most or less. Similarly, with against the rule and with the rule, the same. But in oblique astigmatism, even the autoref will give you 3-4 different. One axis, one rim will go 45, other 50, other 55. So the accuracy of astigmatism is astigmatism is more important.
Okay. Thank you. I hear a lot that minor cylinders are tolerated well. Do you agree with that?
What is mean by minor cylinder when you are
Minus
prescribing?
with the rule astigmatism. If you
These are two different things.
This is a typical lay term that is often used by many optometrists.
No, this is
The reason why
Yes, I will explain because this is a misconception. There is no such type as minus
You
cylinder
can always
and plus
transpose it,
cylinder.
yes.
Suppose I prescribe a patient plus 3 sphere with minus 2 cylinder. Right? People say the patient tolerate this more as compared to if you transpose this. But actually, when you go to the optician, they all have plus cylinder. With the optician, you give a patient minus, suppose plus 2 with minus 2 cylinder, the optician will not have minus cylinder on the prescription. There will be all
Sir,
written
would you
on
like
plus
to?
cylinder.
I agree. I agree.
So what is the difference? These are basically the front surface and the
The
back
back
surface
surface,
cylinder.
yes.
So the
It-
back surface
it is-
cylinder are more tolerable as compared to the front surface cylinder. Why? Because the distance of the front surface is greater as compared to the back surface, so the abrasions are greater. These we usually consider in the RGP contact lenses. The back surface and the front surface we prescribe. If the corneal astigmatism is high, we advise the back surface RGP lens. If the lenticular astigmatism is there, then we advise the front surface toric RGP lens. So these we can control and we prescribe. But in case of spectacle, if you write minus cylinder or plus cylinder, the optician will have that plus cylinder.
We have a few case scenarios in which we will be discussing this again. Anisometropia is another thing that needs to be addressed in children especially, and sometimes it goes unnoticed. Children come back with lazy eyes, and this is one of the most common causes of having amblyopia and lazy eyes in children. So, anisometropes represent a unique example of ocular development where the two eyes of an individual with an identical genetic background and exposed to identical environmental factors can grow asymmetrically to produce significantly different refractive errors. And like I said, this results in amblyopia, significant amblyopia sometimes, and goes unnoticed. And many of these cases we have found out during our school screening programs. So, Dr. Hani, what is the maximum acceptable anisometropia for prescribing glasses in children? Which means कि आप क्या anisometropia अगर significant है तो क्या आप उसको full correction देंगे, क्या वो tolerate कर सकते हैं?
एक तो मैं बात करना चाहूँगा जो पहली डिस्कशन हुई है, cycloplegic refraction is the gold standard. So every ophthalmologist should do cyclorefraction in children. You can judge which patient will get the amblyopia, what refractive error that child has, even if the child is 6 months, 8 months, 1 year. If there is symmetrical refractive errors, then there are less chances of amblyopia. And if there are asymmetrical refractive error or anisometropia in a young kid, that child will develop. The chances of developing amblyopia, you can judge those chances. Now coming to anisometropia, I usually remember the word 2. So if the patient is on cyclorefraction, there is difference of 1.5 to 2, I will consider it, from the fellow eye, I will consider it as anisometropia. In myopia, yeah, 2, but -2 to -3. And above -3, I will definitely, according to age, I will give that child glasses. And astigmatism, if this is like -1.5 to 2, again 2, So if there is disparity between the two eyes of 1.5, I will give that child definitely glasses, and I will address the anisometropia.
What if there is a very high difference, like in unilateral aphakic children? 2 महीने का बच्चा है, उसकी एक आंख में लेंसेक्टमी हुई है, and we are prescribing like 22 diopter की glasses, and the other eye has the normal physiological error, like maybe +1 or +2.
That's a very difficult scenario, that one eye is aphakic and the other eye is aphakic. So what to do? If you will give them glasses, there will be an isoconia, there will be an isometropia, there will be prismatic effects, lot of things will happen. So in these kids, what to do? Will you prescribe glasses? Then there is a big difference, +20 and 0 or 1 or 2. So what you can do? In Pakistan, yes, contact lenses is an option, but they are not like easy to use in our society. They are not available. So if you will give them glasses, then that will be the problem. So ideal situation is that you give them contact lenses, and as long as when they reach like 2 years of age, so go for early IOL implantation in those children. So, but if you are not implanting the IOL, you are not giving the contact lenses, then at least you give them their glasses. Or you can do this, that if you are giving them glasses, don't prescribe them for 24 hours. If you are doing patching, or if you are able to do the patching in those kids, like 4 hours, 2 hours, 3 hours, at least at that time give them glasses and do patching for them, I think.
What I usually do is, in these cases, because they are very common nowadays, so 2 things. One is contact lenses are available. I prescribe to children. So nowadays these are available, no problem with the high power and flat DC contact lenses. We can prescribe, and I usually advise one thing. Sometimes, just Dasab said that some people, they cannot afford. This is not only the prescription, this is also affordability, because these are special lenses and they are expensive. But you cannot leave the patient like this. If you leave, because the first 6 months are very sensitive, and deprivation amblyopia, and you cannot improve visual acuity after the 2 or 3 years in these children. Those who are unilateral aphakic, at the age of 3 years, you do prescribe the patient therapy, they will not. So what I do, I just prescribe glasses for aphakic eye, and for the other eye, I put the frosted glass. And tell the patient just for 2 hours, because there is anisoconia. As Dr. said, anisoconia, the patient will not be able to tolerate. And even anisoconia also develop amblyopia. So if you prescribe plano glasses in one eye, and suppose if he doesn't have any refractive and +20 are like that with the other, then it will not improve. So just frosted with the normal eye, and give the effective prescription in the other eye, and tell the patient they just use it 2 to 3 hours in the morning and 2 to 3 hours in the evening. So the amblyopia will not develop. Once it goes just, that's said, to 2 to 3 hours, then put IOL. But you should not wait till that for IOL. Otherwise, the eye will be deviated and dense amblyopia will be there. So these 2 options.
Okay, thank you. Dr. Samira, आप कुछ ऐड करना चाहेंगे?
Well, regarding congenital unilateral cataract, that's a totally different subject.
Yes.
A very tricky one.
Yes.
And whatever you do, you will not restore sight. It's extremely difficult. What I do is, my plan of management, I delay lens extraction. Usually these congenital cataracts, they are central opacity. I have yet to see a total cataract. Total, it's never total. It's usually central. What I keep them pupil dilated, keep the pupil dilated. Maximum eyeball growth occurs between 3 to 9 months of age. and hypermetropia reduces. The difference between two eyes, the refractive error reduces. So you keep the pupil dilated from the side of the lens opacity, light goes in, it stimulates the fovea, axial growth continues, and by the age of say 9 months, 6 months, 6 months is good enough, enough of hypermetropia is reduced between the two eyes. And at that time you can do aspiration irrigation. At 2 months, I don't think, it's such a huge difference between two eyeballs that whatever you do, you will not equalize the vision. And if you're not giving good vision to that eye, what's the point of doing all that horrendous, adventurous surgery? Regarding unilateral anisometropia, not aphakia, and isometropia high. I have children who have a difference of even 10, 11, 12 diopters between the two eyes. I've corrected their amblyopia by full correction, and then they are managing well. They do not have a diplopia. It has been proven by research that the children can tolerate an isoconia of even 7 to 10 diopters. So give full correction so that myopic progression stops, correct the amblyopia. Don't worry about anisoconia. This brain it's a master computer. And there is an immense power of neuroplasticity in the brain. So children adapt to high cylinders, to high anisometropia very well. And I give full corrections.
I will just...
12. I have children who have corrected their amblyopia with 12 and they do not have diplopia. 12 ka difference, yes. They are managing very well. Myopia, they are myopes.
In these cases, like suppose, as to one eye is minus 10 myopia and other is 1 myope. So majority of these cases, they have axial myopia. The axial length of the two eyes are different. If the high myopic eye has greater axial length, then larger number difference he or she will be able to tolerate. If there is no difference in the axial length, then the patient will not be able to tolerate. And research shows that those children who have high axial length in the one eye, the cone size is greater. So the minus lens, it reduces the image size, but the cone size of that eye is greater as compared to the other eye. So it again maximizes the image size. So that is why they tolerate the high difference if it is axial anisometropia.
And mostly it is axial.
Yeah.
Mostly it is axial.
Just a few, one experience and just a few comments. Though it's not that much related with that, but just remember that the patient who have meridional amblyopia, even if they are quite old, like 15, 16 years of age, if you correct them fully and they do patching and all that, they improve very early. There is a great potential in them to improve. Number two, whenever I see a patient, for example, he comes with a vision of 2200 and 6/6, 20/20, and he has a large number in one eye, I always try to give him full number just to see what is the potential. And many times we find that the children who came with 2200, he becomes 20/50. So there is a potential, then you can think of many other things. Then another case which I just encountered a few months back, she was a large exotropia with the minus 12 number in one eye, in that eye, and the other eye she was 20/20. And I just to check her vision, that's my rule that I always give full number and just to see what is the potential. And I was surprised that with minus 10 she was 20/20. Really, but that was very, I was even shocked at what is this happening. And when I did surgery and I told her that you just must use contact lenses and go for effective surgery and all that. So these are few things which you have to be, as they say, that you have to have as much as information about your patient as possible.
Thank you.
Pardon?
Semblyopic.
They neglect the non-prominent eye. They use the prominent eye. You understand? Means the normal vision, they use the normal vision eye. They don't use the other eye, even after correction.
That's the basic issue of myopia therapy. That's what we are discussing.
So what you do for that?
One thing is, like, if the anisometropia is due to myopia, then if suppose a patient has suppose -12 myopia in one eye, so this -12 myopia doesn't happen at the time. From childhood, actually it was -1 myopia, 1.5, and then it gradually increases. So at childhood, that -1 myopia is used for, myopic eye is used mostly for the near, and the other eye is mostly used for the distance. Once the difference is increasing, then initially the visual acuity has been developed. Once the difference is increased and then the patient is not used, then again the visual acuity is suppressed. So once the visual acuity has been developed and then suppressed, then in later stage you can prescribe patient therapy and this will improve. And minus myopia especially.
Thank you.
Some hypermetropia. One madam said that one is manifest hypermetropia and one is like latent. But the manifest hypermetropia is divided into two. One is the absolute and what is the facultative. You might have seen many students. They have +4, +5 diopter refractive error, but visual acuity is 6. Why? Because that facultative hypermetropia, that patient covered through accommodation. So initially, due to that accommodation, the facultative hypermetropia, the vision was developed. But later on, as the age increases, the facultative hypermetropia converts into the absolute hypermetropia. Absolute hypermetropia is that which can be only covered with the glasses. Facultative hypermetropia is that which can be covered with accommodation. So in these cases, the visual acuity initially it has been developed, but then suppressed, then the patient therapy works well. Because the
You
visual
mean that
acuity-
you must slowly increase the number, not a full correction, not full correction.
Not the patient will not be able to draw that.
But you know,
Usually there
in
is
medial, in lateral geniculate body, pervocellular, magnocellular layers, 2 layers, okay? You know about that. What about that cellular layer? It will also decrease. If you don't use the proper number, it will also, it will be small. It will not grow.
No, this is not that you are willingly not using. Something is better than nothing. The difference is, suppose a patient has, the best vision is with +3 diopter, he has 6
No,
vision.
if the patient is not using his usual pathway, you understand? So definitely in lateral geniculate body, his cells will be small.
He is using
Excuse me,
because of
I'm sorry, but
hypermetropia.
I have
It
to
is covered.
interrupt. We are running short of
Yes.
time. Thank you very much.
He is
We can
using that,
continue
it is
the
covered.
discussion after the case scenarios, please. Thank you. So we have an orthophoric 1-year-old child having a retinoscopy of +10. This is a cycler fraction done with cyclopen at 2/3 meters. So what would you prescribe? Would you prescribe, and what would you prescribe?
So
Anyone from the
can I
audience?
just ask Dr. Mehra, why did you do the retinoscopy? Why? For an orthophoric child, why did the child come to you and you did the retinoscopy?
We do that as a screening exam in all children.
Okay.
At 6 months, at 1 year,
He's not
and
having
at 3
any
months.
problem, parents are fine, or you just
Even
did it?
children who come with epiphora, with lacrimation, or any other symptoms, we screen them for refractive errors.
I just want to add, the screening is so important. My daughter was born in Australia, and only once the ophthalmologist check, then they will be able to discharge. The gynecologist cannot discharge until and unless the ophthalmologist check the baby. So screening is so important. So I think every child should be screened.
And we do a full exam for every child that comes
Excellent.
to our clinic. Yeah. So this was just part of the screening, like my fellows would know. So yes, anyone, please, from the audience?
I think here 1-year child with orthophoria. At this age, it's about +3 or 4 is normal.
Yeah.
So we will minus it, and then the distance 1.5. About 5 or 6 we can give.
Yes. So, but is the consensus there that we should treat this child having such a large hyperopic refractive error?
Plus 10 refractive error means the
It is
eyeball
the
is
retino.
too small.
It is plus 8. The retino is plus 10. Plus 8.
The refractive error is 8 to 10.
8
so
to 10.
generally, by the age of 1 year,
yeah,
the fovea is not developed fully. And if the eyeball is small, fovea develops at the age of 3 months because the axial growth occurs and the layers of retina, there are 10 layers all over. But at the fovea, there are 4. And those 4, it's not that they reduce ho jati hai number mein. It's that they are pulled away from the fovea as the eyeball grows from the age of 3 months onwards. And so that at the fovea, only 4 layers remain so that we can have a 6/6 vision. So if in such a high hypermetropia means axial growth has been interfered with somehow. That was the reason I wanted to know कि वो बच्चा क्यों आया आपके पास. Somehow the axial growth has been affected कि वो light नहीं गई है आँख में, वो आँख वहीं रुक गई है 17 या 18 millimeter size पे. I would do axial length उसकी I would like to do. और उसमें foveal development नहीं हुई हुई. And that child is going to develop ametropic amblyopia अगर दोनों आँखों में है. So I will give minimum plus.
So in these cases, after deducting this physiological hyperopia, we will give the number like +5, +6 in these kids, and I will have a closer look on them. So that I will do cyclorefraction after every 4 months in these children, so that if the axial length is growing, so we can address that.
What the guidelines?
So the consensus.
That is very important.
Yes.
You know, to some extent, you must give lessons to this
No,
child.
the point, Dr. Saab, is कि आपने जो पूरा correction नहीं करना, आपने उसको blurred signal देना है. That blurred signal will increase axial growth.
He will develop central vision because he will not develop nystagmus.
What the guidelines suggest, like American Academy and National Medical Research, the most important thing which we usually ignore is dry retinoscopy static. Even at the age of 6 months, at the age of 1 year, you do dry retinoscopy, right? And this case, suppose if it's cycloretinoscopy +10, with dry retinoscopy, he will have like +5, it will be neutral +5, +7. So the difference between the dry retinoscopy that we calculate is facultative hypermetropia.
Yeah.
So for the first, you divide by 3. 1/3 of that facultative hypermetropia will be added with the absolute hypermetropia, and you will give him that glasses. Like if the dry retinoscopy shows that he is +5 diopter hypermetro, right? And the cycloretinoscopy shows that he is +10 diopter. So there is a difference. Like the net, suppose net is +10, there is a difference of 5. So divide by 3. So one part will be added with that absolute hypermetropia. So there will be a blur that will progress the axial growth as well, and amblyopia will also not occur.
Okay, thank you very much. So the consensus of the House is that we'll be prescribing glasses with undercorrection and leaving enough physiological hyperopia for this short eye to grow. The next scenario is of an 8-year-old boy presents with myopia of -3 diopters, refractive error, and intermittent exotropia. His parents notice that he squints frequently, but then corrects it also with it being an intermittent exotropia. How would you manage this case?
Yes, you should prescribe glasses and also do orthotic exercises, pen push, or something like ties you should use to focus that tie, because then his muscle will develop. You understand? So
Yes.
both should be done.
Yes, thank you.
And it usually happens during when the child is inattentive. Usually when the child is inattentive or he has high-grade fever, so he can come to intermittent exotropia. So for these patients, you should prescribe glasses plus orthoptic exercises, both.
This case scenario was included because of two reasons. One is this age, and the other is this see the refraction. So many of the clinics having a myope of 8-year-old might not go for cycloplegic refraction. And this is something that we have discussed earlier. If this is the child that is coming to your clinic for the first time, go for a cycloplegic refraction, come up with the exact myopic refractive error that the child needs. And obviously, yes, we will be prescribing the full myopic correction that the child needs. Why full? Because we want the child to accommodate. जितना माइनस का रिफ्रैक्टिव एरर होगा उसकी अकोमोडेशन रिलैक्स रहेगी उतना उसका इंटरमिटेंट एक्सोट्रोपिया वर्सन होगा और उसका कंट्रोल खराब होगा सो वी वांट द चाइल्ड टू अकोमोडेट तो हम उसको फुल
सपोज इफ इट इज प्लस 2.5 देन व्हाट विल यू डू
प्लस 2.5
यस इन चाइल्ड
देन अगेन इट आप साइक्लोप्लेजिक रिफ्रैक्शन के बाद हम उसको प्लस 2.5 है That's what you are saying. Okay, so if the child is 8 years old and he has no visual problems, so we won't be giving him, we won't be prescribing anything.
That needs only orthoptic exercises.
Yes.
And if it is 2 years, 1 year, and cycloplegic refraction is plus 2.5, and then again he has intermittent exotropia, then what will you do?
We will not prescribe anything.
Plus नहीं देंगे आप. It will worsen the extreme.
No.
They say one thing like if a child has intermittent exotropia and he or she doesn't have any refractive error, though minus lenses, even at the age of 8 years, 6 years, you can prescribe -1 to -1.5 lenses. And in those cases, if you check the visual acuity, in majority of cases actually most of the clinics, they do not have LIA symbols and these things, and even at the age of 2.5 and 3 years, we can take visual acuity. So if a patient do not have any refractive error and he has intermittent exotropia, you check the visual acuity will be success, and if you put -1.5 diopter in both eyes, again check the visual acuity. If the visual acuity is dropped more than one line, then you decrease. If it is dropped one line, because the orthopic exercise, usually the people, the parents, this is the responsibility of the parents.
You know, in a very small children, like 2 years or 3 years, the patient, parents, they are worried about intermittent exotropia. So in that condition, what will you ask your parents or mother, father, how will you do counseling? Suppose
generally we go for alternate patching if it is significant and the time is significantly if it is less than half of the day, the child will not become an embryo. But if the child starts preferring one eye, then you are आप separation को avoid करना चाहते हैं. So in that scenario, आप अगर 2 साल का बच्चा है, तो you can ask the mother or father to start patching about half an hour or so. But that is all that you can do, and only in those cases where there is significant misalignment for a longer duration of time. Otherwise, if it is intermittent XT with good control and there is no significant refractive error, you just need to observe that child and you will keep him on your follow-up, and a monocular age-specific visual acuity assessment is the key.
And the most important factor that retinal pathologies should be ruled out. That is very important.
Yes. This is the difference.
That is the refraction and the refractive error would be prescribed after you have evaluated the eye.
No, the most important, what is the proper management plan for this child, which usually we were doing in Australia but not possible in here. If the patient has intermittent exotropia, then there are 2 options. One, the main thing is to obtain binocular single vision. So for that, the first line of therapy is prescription of minus lenses. If he or she doesn't have any refractive error, then minus lenses and orthopic exercise, right? If these fail, then at this stage, you prescribe Fresnel prism on glasses. With the Fresnel prism, what will you do? You will gain the binocular single vision will be maintained. and no amblyopia will happen. But the disadvantage with this is that with the passage of time, the exotropia will increase and you will increase the power of the Fresnel prism. Once it gets with it, you will have to, if the orthopedic exercise is not working, like you the push up, the eye is not coming to it, then this you have to prescribe Fresnel prism, and with the passage of time, the power of the prism will increase, the deviation will increase, but the binocularity will be maintained. Once it gets to the maximum, then you will patch that eye, you will measure the deviation, patch that eye for 72 hours. After 72 hours, you again check the deviation. If both are the same, then go for surgery. And it may take years. If both are not the same, then again you prescribe Fresnel prism and maintain the binocular single vision. And what the enter that completely constant exotropia and stable, then go for surgery.
So prism
Thank
and
you
patching,
very
both
much.
are the answers.
Yeah.
You mean prism plus patching, both are the answers.
And even in
Prisms
just initial
for
stage,
manifest.
with intermittent exotropia, patching will break the fusion, and intermittent exotropia will shift to constant exotropia. You will increase the ability.
Constant.
So in intermittent, usually if you maintain with the prism, amblyopia will not occur. That is why we are describing the
Intermittent
prism.
XT, if you are doing the patching, that will become manifest. So in intermittent XT, in my opinion, patching is not.
No patching,
no.
only exercises that are less. Even
Okay.
a 2-year-old can do it.
Only exercises. Okay, that is the answer.
If
Yes.
exercise fails,
Minus
then
classes and exercise.
If the patient have cycloplegic refraction plus 2.5,
We will not.
and he has intermittent
Can we
esotropia, not exotropia, esotropia, then what will you do?
Sorry, can we go on with the rest of the, because we are out of time, and I just want to go through a few more scenarios. So the 2-year-old orthophoric child with no visual complaints having refractive error -3 on routine screening exam. So what to prescribe, please? What to prescribe?
First confirm with cycloplegia and then.
Yes, after cycloplegic refraction, it is -3. So are we prescribing? Yes? No?
we prescribe.
I will ask for whether outdoors the child is rubbing the eye, whether he's closing the eye, whether he's doing this, slit like eyes. If it's doing that, I will give.
This is an orthophoric child with no visual symptoms.
Then, okay, we can wait.
2 years age.
You can assess visual acuity even at the age of 20 year with the Lia sample.
So
you
we
have
will
other-
not-
If you leave it myopic, the myopia will progress. Under-corrected myopic correction will
Zero.
progress the myopia.
उसको ऑन कर दे माइक इधर दे so yes, it is a myopia alert.
I think the 2 years has no outdoor activity. Usually they are inside the
Yeah.
home, so their need is not to see at far. So I think there's no need of, and the child is asymptomatic as well. So I think there is no need of giving any prescription to this 2-year-old child with ortho.
Thank you. So we have established that this is axial myopia and no other ocular findings are there. So, so yes, there would be a myopia alert. We'll be counseling the parents for not to give screens to the child, although they are not going outdoors that much, but should be avoiding screens जो कि आजकल बहुत छोटे बच्चों के हाथ में भी आ जाती हैं. So the next scenario, a 7-year-old myope girl with -2.5 diopters of air and an esotropia of 14 prism diopters. She is 6'6" in both her eyes with her glasses, but her parents are concerned about her eye alignment.
7-year-old myopia.
She is a myope of -2.5 and esotropia, which is more pronounced for near. and she has good vision in both her eyes. She doesn't have any visual symptoms. She is happy with her glasses, but her alignment is disturbed. And for that, हम क्या करेंगे?
Full correction दें, near work बंद करें.
The most important thing is BSV, binocular single vision, depth fusion, and stropses. If we leave this just with the prescription, in future, this child, he will not be able to go for Air Force, Army, and this thing, because the binocularity will be disturbed. BSV will be disturbed. So most important is prism in these cases, to maintain the BSV.
Okay. So can we go for bifocals in this? Would you like to give her a trial?
No, prisms.
You would like to go for prisms?
Can I say 7-year-old जो है जो ये सारा दिन ऐसे करके बैठा होगा है. So you have to stop that. EZO will disappear.
Yeah.
Tell her to go outdoors. So it will be fine.
No,
और अगर वो आपकी बात ना माने तो क्या
Myope
give her-
energy,
So-
they are stuck inside. They are doing near work all day. तो EZO तो होना ही है.
The child is myope, but whether
So if we
using
cannot,
glasses or not, that's another
वो भी नहीं पहन रहा होगा.
So the
इधर तक
other,
तो vision है इसकी.
can we go for bifocals to relax her accommodation and break the cycle? Do you think?
You have to check the AC over A ratio. If the AC over A ratio is high, then you can go for bifocal. If the AC over A ratio is the same, then prism. Bifocal only advisable if the AC over A ratio is different.
More.
Like, it is greater for the distance.
So the AC over ratio is more because, like as I've not written, sorry, but I spoke that it is more for
Okay,
near.
if it is more
Yeah,
than AC
it
over
is
A,
more for
then you
near.
can go for bifocal instead.
Okay.
Yes.
Thank you. So this case scenario was very kindly shared by Dr. Mufarriq Shah. It's a case of partially accommodative esotrope managed with contact lenses and prisms. You can tell us about it, Dr. Mufarriq?
In most of the cases, we usually prescribe like with accommodative esotropia, we consider that prescribe the full correction. But if you prescribe the full correction and the esotropia is just reduced, like in this case, the first picture was not there, the esotropia was 60 prism diopter, but with the correction, fully correction with the contact lenses, the esotropia was 16 prism diopter. So in such cases, if you live like this, like majority of cases, the parents are happy now, the esotropia is decreased, and the doctors are happy that the esotropia is decreased. But actually, in such cases, you are going to develop ARC, abnormal retinal correspondence. So in such cases, you prescribe the prism. These are compulsory to nowadays in our society. The prism are not prescribed, but there in the state, usually more than 40% cases you are prescribing the prism because the main aim is to maintain the BSV. Second thing is like usually I have mentioned one another case. In adult cases, we usually have the accommodative esotropia in the patients. They are at the age of 18 years, 20 years, 22 years. They say that we put up the glasses, esotropia comes. When we put on the glasses, no esotropia. Because of that facultative hypermetropia, because blur is stimulus for accommodation. When the patient is putting up glasses, the accommodation exerts and the esotropia increases. And why it's maybe because most of the time in that day, 4 times, 5 times the patient is putting up glasses, he sees blur, and blur is stimulus for accommodation and also converges to the esotropia. So for more time, we prescribe high DKV contact lenses for these patients, and once they use it for 5-6 months, then there will be no esotropia, even without correction. So in these cases, the one disadvantage is like the patient will tell you, my visual acuity before the contact lens, it was like 6/9 and 6/12 because of the accommodation he was covering. But once you have converted the facultative hypermetropia to the manifest hypermetropia, then without correction, his or her visual acuity will be drop out. So you will explain the patient that we are going to convert your facultative hypermetropia to absolute hypermetropia, then uncorrected visual acuity will be decreased, but your eyes will get straight, and then you can proceed for the refractive surgery. That's it.
Thank you. Any comments from the panel?
I would like to know his vision first. What is the vision here with correction?
I already
But
mentioned.
the vision with correction is 6/9 partial and 6/12.
So why isn't he 6'6"? Why isn't he 6'6"?
He's not, I'm patching therapy. He comes to me for
You
the
are
first
doing
time.
patching?
Yes.
Okay. Okay.
So, fitting a child with contact lenses, in my experience, has always been a very big challenge because parents की बहुत ज़्यादा resistance होती है. Even the children are not very happy putting something in their eyes.
It
So-
depends on constant. You are right, but you need like to give more and more and more time. One of
Yeah.
the doctors have told that we don't have, Dr. Samira, that we don't have enough time. He was telling you that we should have optometrists so they can give more time to the patient. So this is what you are right. We need more and more time and constant, and every 2 to 3 months week follow-up
Yes,
initially
yes.
without consultation fee. For these patients, this is a package, no consultation fee, a second visit, third visit, and fourth visit. So this is easy for them, they usually used to come.
Okay. So coming to the next scenario, 1.5-year-old child with alternate esotropia of plus 55 prism diopters and cross fixation. Presents in OPD wearing 1.5 diopters of air glasses for last 6 months. इनकी जो retinoscopy थी, that was plus 3. And he was wearing glasses of plus 1.5 diopters of air. What do you think the case is? It is a case of infantile esotropia? Yes? Do you agree with the initial management of the case?
What about the ocular motility?
That's normal. Cross fixation hai, but the ocular motility is fine.
Because sometimes in binary ocular sectional palsy also it happens.
So, do you agree with the initial management? This is actually a case that came to my OPD a few days back.
Is this atropine refraction?
Plus 3 was the retino with cyclopin.
So why cyclopen? For an ET, why don't you do atropine?
Madam, because हमारे जो most of the patients coming to us like from DI Khan or whatever, वो day
मेरे
trip होता
clinic
है.
में भी आते हैं,
हाँ,
from
so
all
we
over.
don't do atropine the same day.
Then you are
obviously.
reducing by 2 to 3 diopters in such a small baby. So you are giving under correction by 2 to 3 diopters.
Even if they are coming from far-flung areas, you can do atropine refraction on the same day also. That will give you a better idea than
Cyclo though is not right for an ET.
Okay. So what if it is infantile ESO with all the, you know?
I would, infantile ESO देखें, अगर आप ये DD करना शुरू करें ना for all congenital ESOs, infantile is minimal. Most of them are missed or underdiagnosed accommodative ET because everyone is doing cyclopen refraction on the same day.
Okay.
और ये ऐनक भी जो पहन रहा है, this is absolutely wrong. Eyeball should be in the center, it should be centered. Date पहन रहा है, he's seeing through 0.75.
Yes.
So refraction
however,
भी
there
गलत है,
was-
ऐनक भी गलत है.
ऐनक भी गलत
Citation भी गलत.
और prescription भी गलत. So my point is, if at all we do an atropine and we come up with a similar refraction and it is an infantile esotropia, would you still go for this management of giving plus 1.5 diopters to a 1-year-old esotrope?
अच्छा, can I did एक study थी कि जितने essential infantile भी हैं ना जी, when I came back here 15 years ago, I never used to bother giving them 1.5 या वो. And उसके बाद क्या हुआ, when they grew to 3, वो आँख amblyopic हो गई. And फिर दोबारा जब repeat की, उनमें cylinder आना शुरू हो गया. So these children, it's extremely important कि आप atropine refraction करें. Even छोटा सा भी cylindrical error है, you correct it. Because it keeps on growing and it will lead to amblyopia. और तब से अब तक I give even 0.5 का भी cylindrical error है ना, I give. So it's extremely important कि full atropine refraction हो, full correction हो, and you give the maximum और फिर देखें कि जी फिर surgery की ज़रूरत है कि नहीं है.
Okay. So
But another important is you already told that he has cross fixation. If you check him, no outward movement. So in such cases, important thing is that even if you do not prescribe glasses, you just prescribe two pair of glasses, one glass with the right eye frosted and the other with the left, so that he can use the lateral gaze. You just prescribe the Joe for 2 hours, the one pair, and 2 hours the other pair. Otherwise, he is not using the lateral recti muscle. And these are usually
ये सही कह रहे हैं. I mean, what I
so
tell
these
them.
are very important. The frosted glasses on one eye, so that the eye can move outward. Is cross fixation. So more important are the frosted glasses.
I don't give frosted glasses, but I give के parents को कहे कि कोई भी toy ले, एक आंख पे हाथ रखे and tell them to look outside. So do
this
this.
responsibility to parents.
They have, in a month they are
This
better.
is the easiest way that the child will do. Just put on the glasses for 2 3 years.
Sir, आपके कोई comments around? What is the smallest plus that you would advise to an infantile esotrope? Dr. Mubashir.
Infantile isotropia, well, of course I will just look for that cross fixation is maintained, vision is good, and then all those things which have been told by Dr. Mufarriq Shah, that patching or the frosted glasses, and then you have to do surgery in any case. So at
In
least
any case.
I wait for at least 2 years. Though there are people who go for early surgery.
If you are doing patching in intermittent exotropia and we are suspicious that XT will increase, so if we are doing this frosted glasses or patching in this case, maybe we will increase the esotropia. What's your comments?
I think it will break the cycle.
ET में तो आएगी ना, जब वो सीधी होगी तो ET में आ जाएगी.
I don't suggest
Break कर
the
देंगे ना.
patching frosted glasses. No amblyopia with the frosted glasses.
Intermittent
It's just for
XT
2
में
hours.
patching, I was
If
saying that
you
the only
prescribe for 2 hours,
partial
right
patching
eye,
of concussive
right eye 2 hours. Tomorrow you will apply, so this will stimulate. Tomorrow you will apply, and this
anyone
will
from the
stimulate.
audience,
No
please.
amblyopia.
Infantile esotropia and plus lens.
I'm talking of the esotropia, that we will increase the esotropia.
Increase नहीं होगा.
मैडम जब वो जब
Break कर रहे हैं.
अच्छा. So let's go to the next scenario, a 4-year-old with compound astigmatism. So इसकी रेटिनोस्कोपी फाइंडिंग्स ये हैं और इसके रिफ्रैक्टिव एरर हम प्रिस्क्राइब कर रहे हैं. तो this, would you prescribe or this?
Again, same question.
It is the same.
It is the same.
I
But
will
if
do
I
the cover
prescribe,
test.
my
Doctor,
question,
cover test
what-
first.
अच्छा, the thing is कि आप इनको जो I would prefer giving the first और मैं लिख के भेजूंगी और जो उनकी प्रिस्क्रिप्शन बन के आएगी वो that would be with the -3 cylinder rather than the +3 cylinder. So
With the forcimeter you check, both will give the same reading. These
they are the same.
No change. This is basically with the manufacturing. Either it is on the front side. This is a misconcept. This is either on the front surface or the back surface of the lens.
आजकल तो सिर्फ बैक वाली आ रहे हैं, आजकल तो प्लस की आ रहे हैं.
प्लस सारे प्लस की आ रहे हैं. मैंने आपको बताया कि अब पेशेंट को आप दे दें उसका वो चेक कर, that will be
I
plus.
talked to them and they said that we are just making all plus cylinders. There's nothing like minus
Agreed.
cylinders anymore.
So, but sometimes when you have esophoria with this kind of refractive, you might prescribe a higher sapphire than the cylinder. So उसमें बाज़ दफ़ा आपकी preference होती है कि आपको sapphire ज़्यादा plus का मिल जाए. So then आप उसको transpose कर.
Actually, what is the mechanism? Like you just bring that. It means, like suppose one is the +6. If you give him +6 in both cases, in both these cases, both of the foci are back. Right? This is compound hypermetropic astigmatism. Both of them.
Hypermetropic,
So
yes.
if you give one +6, so the one foci will come to +3 and the other will be 0. So that focal length you will put back with the -3. Or if you give one +3, then the one focal length with the +3 will come on the fovea and the other will be 3 diopter behind that. So you go 3 cylinders, they will bring on the fovea. So
Yeah,
in both
it's the
cases,
same thing.
actually the stump conite is reduced. So the same mechanism.
डॉक्टर मेरा ICA में जाऊँ?
जी मैडम बस this is the last slide. Improving compliance to spectacles. Thank you very much, Dr. Samira. Can we have the shield, please? Madam, जल्दी से आपके साथ shield का हो जाए.
जी जी जी.
So, thank you very much for your patient listening. The last
This is long
aspect is कि हम
discussion.
जो भी prescription देते हैं जब तक उसमें compliance अच्छी नहीं होगी बच्चे की और वो spectacles नहीं पहनेगा तो आप you must remember that children are copycats. उनके environment में आप glasses वाली individuals बढ़ा दें, उनके toys, उनके friends, उनके siblings और this is an uphill task for the parents and the doctors to prescribe glasses. Thank you very much.
ये फ़ोन किसका पड़ा हुआ है यार? ये फ़ोन पड़ा है ये ध्यान। क्या हाल है खैरियत से हैं आप ठीक है Okay, I think we can start on. So the purpose is to discuss about diabetic eye disease. I think some of panelists here is here, others will join us. Dr. Tariq Marwat, would you like to come on the stage? So the plan is to discuss about diabetic cataract as well as diabetic retinopathy, and these are the learning objectives. So timing, what technique of cataract surgery we would like to prefer in diabetes, what are the intraoperative challenges and post-operative management, and current management of diabetic macular edema, either we are dealing medically or surgically, and similarly for diabetic retinopathy. And especially it's very important what and when should we intervene surgically in diabetic retinopathy. So let's talk about the cataract first. So, Tariq, how would you evaluate and optimize diabetic retina in the cases where you're going to perform cataract surgery? So what would you do?
Bismillah ar-Rahman ar-Rahim. Definitely, if the cataract and vitrectomy has to be performed in one setting, sometimes there is an issue that there is a tractional retinal detachment in the posterior segment, and proper biometry is a challenge. So what I used to do in such cases, you can always take a biometry of the other eye, but my approach is that I do not put IOL in the first instance.
So suppose you are just doing the cataract surgery, like
Yes,
there is diabetic retinopathy, you are not planning anything, just doing cataract surgery.
Doing cataract surgery.
So what would you do?
Like regarding technique, we go for phaco.
Yeah, what I meant to say is if suppose you are suspecting some diabetic retinopathy, there is some diabetic retinopathy, but no surgical intervention is required.
Yes.
How would you evaluate that case? So what investigation or diagnostic thing would you like to do before proceeding for the cataract surgery?
For any case in which I cannot see the posterior segment and there is a chance of posterior segment pathology, like in diabetic cases as well, I would like to go for B scan. And I always prefer to do the B scan myself. Because this is sometime you see certain pathologies when you are performing B scan in the real time. So you cannot actually trust in somebody's else B scan done by somebody else. So the B scan is one of the modality that you should perform before going for surgery. Another thing is that whether to go for combined surgery or two-stage surgery, cataract first and then retinal surgery. So if you think that the surgery will be a very complicated one and you are not planning it well, so better to go for cataract surgery first, then reassess the posterior
Dr.
segment.
Mazhar, would you like to come? Dr. Mazhar, please. No, just come over.
So better to do phaco first, then reassess the posterior segment, and then redecide and plan.
Thank you.
I think planning is very important in such cases.
Dr. Mazhar, initially we're talking about diabetic cataracts. So how would you evaluate and optimize diabetic retina before cataract surgery? So you're planning to do cataract surgery. What sort of the diagnostic things would you like to do before proceeding with the cataract surgery?
I think so. It's very important. I think so. Not only the retina. If you have already discussed the management of diabetes, we have to look all over those things. And then when we come specifically to retina, I think so. If you have got a cataract, and one thing is this there that it's always very difficult to see the retina. It becomes difficult to see. You may be able to see bit of the things, but the subtle things are a bit difficult to see, like ERM and membranes, depending upon the opacity, the level of the opacity it is. One thing is there, which I have come to this thing, that if you have a mild cataract or doing an OCT may be very helpful. So sometimes what you don't see on, if you don't have a very good using a 90 diopter or whatever super field, you may do a OCT just to be save yourself from this thing. So that is what I would evaluate it. And naturally, I am sure you've talked about the visual acuity and everything like that, and pupil reaction is also very important to see them. All those things which we normally do, they have to be seen, and once you have to gone through it, only then you should try to go for surgery.
Thank you. I think the most important thing in the cataract, as Dr. Mazhar pointed out, intensity of the cataract. Are you able to see the retina well or not? So similarly, Dr. Tariq mentioned about B-scan is really important when you're dealing with these cases. You want to make sure that there is no posterior segment pathology, otherwise you may plan to do combined surgery. So you need to check it. And very good point mentioned by Dr. Mazhar, that OCT can tell you a lot. Sometimes there can be tractional maculopathy there, so your plan might be different in this case. So in the cases where you suspect there is altered macular reflex, or you're seeing some other changes, or even no view, you need to have a check for that. And mostly common investigations, we talked about OCT and B-scan. These are common. And Dr. Tariq rightly pointed out, it's always important to do B-scan yourself, because you can see better. It's a dynamic thing. If you just look at the view, maybe the cross-section won't be coming from the area which you were looking at. So it's always important that you do yourself. Other question is, Dr. Mazhar, if somebody has got diabetic macular edema or PDR or both, would you treat it before cataract surgery, or what will be your plan in that case?
I think so. The question is if I can do photocoagulation if it is a PDR, I will definitely try to do as much laser as I can before I will attempt going for a cataract surgery. There will be two school of thoughts about this thing, whether it should be done that way, or in case of a DME, if I can make out that the cataract is a bit early, or if it is not that dense and I can make out DME, then again I will like to treat them before I go for cataract surgery. One thing, or why the question would arise, why? Especially in DME, you should be 100% sure that if it's a DME, the patient is not going to be, whatever the expectation of that patient is never going to be it will be suboptical. And by giving him injection, at least you can start off the process, and most of the time, depending upon the severity of the cataract, most of the time you can evaluate the patient beforehand and do whatever it is possible. To make sure that if you're given an injection or if you're giving a lasers, you can check it, visualize by doing an OCT, which can give you a subtle appearance that if there's a big kind of a chunk over there, hillock or anything like this, which is a DME, that has been reduced, and then you can do the surgery. And there are a lot of studies which have shown that if you have a DME naive or PDR naive patients who has been going for a cataract surgery, the process may increase further. And I see a lot of patients who have been operated cataract surgery, and then they have been told by the treating physician afterwards that they have got a problem with their retina, this and that, and they are never satisfied patients with that doctor. So it's much better to tell the patient that this is the problem, that the cause of your vision reduction is not the cataract itself, but it is also the diabetic maculopathy or PDR or whatever it is. And until unless we treat that thing, your vision is not going to improve, even if you do the best possible surgery or whatever prevalence. I think so it's very important telling those patients before the surgery that what kind of a vision you could expect. And if you try to give them, and two things, if you have not seen them or if you have not checked this thing, this is going to be a problem. And even if you have checked them, you have to be much sure to tell them exactly what kind of a vision they should accept. Thank you.
Thank you. Dr. Tariq, how would be your approach?
I think
in such
is
cases?
The DRCR network has suggested, if many times we have patients who are having the OCTs previously performed, and now we cannot see the fundus clearly, but there is an evidence that this patient was having DME before. So in such cases, injection before surgery is also recommended, and I think we should go for an anti-VEGF injection before going for cataract surgery.
Yeah, I think very important points highlighted here. You need to see the condition. Is it the cataract which is causing poor vision, or is it a diabetic retinopathy, or is it a combination? So that's why you need to talk to your patient, tell them that after removing the cataract, they will require further management. Or other option, as Dr. Tariq pointed out, you start the treatment. If somebody is having diabetic macular edema, the laser-wise, Dr. Mazhar mentioned, if there is significant cataract, you may not be able to do the laser treatment. So you start the treatment. If you go with injection, you give injection. You go ahead with the cataract surgery in a few days' time. And then you reassess your patient. If the patient requires laser treatment for proliferative diabetic retinopathy, you go for. If patient requires injection, you continue the injections further. So these are basically usually the imaging. Fluorescent angiogram, yes, if there is a significant cataract, it may not help, but you have to correlate. If the vision is quite significantly poor, there is slight cataract, you may go for FFA even in that case, and you would realize that there will be macular ischemia, which was responsible for poor vision. Considering the surgical things, as we know in diabetics, the pupil can be small, may not dilate very well. The cataract, in comparison to the normal age population, it will be more in diabetic patients. So, Dr. Tariq, how would you manage small pupil or dilate the pupil or dense the cataract? Any other precautions would you take?
I think small pupil is a challenge, but with experience you can deal it. Still, if you have the iris hooks or the mylinguine ring, that definitely helps a lot. Poor dilatation is always a challenge in such cases. I mean, you can use isonephrine eye drops if you have. Still, if it is not working, you still need some intraoperative dilating measure like the ring or the hooks. Dense cataract, if the cataract is dense enough, it is hard enough that it's difficult to deal with phaco, you are always having another option. The manual small incision cataract surgery is one of the choice that you can go for.
Yeah, thank you. Dr. Mazhar, what will be your approach?
I think so. I agree with normally if the pupil doesn't dilate, I think so. It's one is you always give a harsh word to your OTA staff that make them dilate them, and if still it doesn't work, that is the problem. And I think so. We have isonephrine available nowadays.
Yes.
This is what the other thing is. Intracameral adrenaline is one thing which I give, and sometimes I do use the hooks, but since Megalina is not available much in Pakistan, I use hooks. But normally what I do is, if you don't have a hook or anything, you just go inside the eye, stretch the pupil by putting 2 hooks on the tooth, and just give it opens up a bit, and then you can do the surgery. And if it is, if you are not very happy with it's a very dense cataract, I think so. I always use dye. There's no harm, and it's available, and it's give you. If your capsule access is good enough, you can even a small cataract you can do it the surgery. But there's always a difficulty. The third question, should I carry on? The third is the IOL choice.
Yeah, I think other important capsule exercise you mentioned about.
Yeah, it becomes difficult. It becomes difficult. The smaller the capsule access, the difficult the surgery becomes.
Yes.
So it's all in your hand that how you would like to increase the size of the capsule access by either using the hooks. If you don't have a hook, you can dilate them manually with your normal. I use 2 instruments. The IOL hook and the normal second-hand piece, and just give it a bit of stretch the pupil, and then put adrenaline in it, and then when you put the viscoelastic, it gives you a good enough place to use your surgery enough. I mean, so you can't have a 5 or 4.5 or 4 millimeter of capsule access is good enough for experienced surgeons to go through it. It's always a bit of difficulty, and these kind of surgery, and then again, most of these patients may be on some anti-prostatic drugs or things like that. You have to be sure about these things. So these are all surgeries that diabetic patient, along with the prostate enlarged, or if they have tumescent and iris may be coming. Agreed.
What's your
I think so.
approach?
My approach is very simple, is that you keep on trying it to do it. Don't stop it. What happens is, the caps, when you're doing hydrodissection, it should be, first of all, you should do a complete hydrodissection. Don't go for hydrodelineation first, because then it becomes more sticky. So if you go for a hydrodelineation first, and that means that you're leaving a lot of the soft lens matter behind, then it becomes very difficult to control it. So if you do a hydrodissection first, that means just go under the anterior capsule and then hydrate it, so that your first fluid goes around it completely. And once it goes around completely, if you see that reflex going completely, then you are safe enough.
But these cataracts are more sticky as compared to the normal
But
cataract.
still, I think so, in my experience, that they may be very sticky, but you can still maneuver it. And if you feel sticky, then do it not once, but 2, 3 from different places. But make it sure that you have got a hydrodissection first completely. And if you don't do a hydrodissection first, instead, once you do a hydrodissection, from the next angle you do a hydrodelineation, then you've got different layers. And then it becomes very difficult to rotate them. And especially if they are kind of a mid-dense cataracts, then it becomes difficult for you. So if you make sure that you have got a hydrodissection at a same plane in all the area, then it's rotated. Once it rotates, then the things are much easier for you.
Yeah,
So the rotation is one thing which I think so you make sure that they move around.
I think few things we can try, as we talked about. Intracameral, we can inject like phenylephrine or lignocaine, so that may help you to dilate. Other thing, viscodilatation, as Dr. Mazhar mentioned, you can inject over the margin of the pupil, try to dilate. Iris stretching is another option if you don't have iris hooks, and Malugan ring is very good, but unfortunately it's very costly, and iris hooks are quite cheaper in comparison to that. Rexes wise, I think it's, if you have got the reasonable pupil size, you can do, even if you are not seeing the rexes, if you keep going round and you make sure that you are joining it, you can make, so in that way you can manage it. I think coming to important question is intraocular lens choices. Dr. Mazhar, I think you were quite keen to answer about that.
We are going to have another session on premium IL, but one thing is very much clear about this thing. In a diabetic in a patient who is a diabetic, I will always do, possibly I will always do an OCT to check, because I'm sure about it, because it's a diabetic also. And so my choice will be a monofocal until and unless I'm 100% sure that his retina is absolutely fine and there are no signs of diabetic retinopathy. So if I can't see his retina, if I'm not sure about it, I'm never going to put a multifocal lens. As simple as that. So there's nothing much, I will not even discuss with him. And even if he talks to me, I said, this lens is not for you.
So the choice is monofocal?
Monofocal, I think so.
Because you can have a lot of complication later on. Suppose
So
if the
thing is that
is advanced.
if you are sure about his retina, that it is absolutely, I mean, diabetes, if it's a cataract, it's very early cataract, and you do not see anything in his retina by your examination and by your OCT, and absolutely fine. Yes, you can, then becomes a relative contraindication, it's not an absolute contraindication. But if I see a minimum change on OCT, even a subtle kind of an ERM membrane coming up, no EDOF, no multifocus. As simple as that.
Dr. Tariq, what's
Yes,
your approach?
I think in my practice, I'll always go for a monofocal lens.
In diabetic patients?
Not only if you see any minimal changes, but if the patient is a diabetic for more than 15 years or more than 20 years, there is a highly likelihood that he or she will get some sort of retinopathy or maculopathy at some stage of life. So monofocal.
Yeah.
Even PCO is more in diabetes as compared to the normal patient.
Yeah.
Posterior capsule specification, that is more.
So I think in diabetic patients, important thing is that how is the central retina in macula. So what Dr. Mazhar was trying to mention, you need to do OCT. Yes, diabetes was an increase. It may possible patient is pseudophakic, they later develop diabetes, you have put the multifocal. But you need to make sure that macula is functioning normally. And so OCT is the must thing if you're planning a premium IOL. Coming to EDOF lenses like VVT and others, usually worldwide criteria nowadays, what is the criteria for monofocal, same is for there. So you can technically use them, but unfortunately the cost-wise, EDOF lenses are almost like a similar cost as multifocal lenses, and there is slight compromise in the reading with the patient. So you have to discuss with your patients, and even slight problem, it's better not to go for. You become a safe choice and use the monofocal. Post-op management, your normal cataracts, a diabetic cataract, do you have any difference, Dr. Tariq, or same regime you use for both?
If you are talking about regarding the macular edema,
Especially if
Yes.
somebody can develop or not, so to prevent it as a
If-
prophylaxis.
yeah, if there is existing macular edema,
There is no existing otherwise. In normal, no, then what would you be your?
then I think I would not
Just
go
normal as
for
you do in,
just
do
a
you use
normal.
non-steroidal in every
Non-steroidal
cataract cases?
anti-inflammatory.
What about Dr. Mazhar, you? Any
I give a
difference?
non-steroidal anti-inflammatory drug, eye drops,
In all
pre-op to every
cases?
patient.
In every patient. So
Ah,
even diabetic
so-
cataract, nothing will be different, it will be same.
I would be the same, but if you give a non-steroidal anti-inflammatory, there are two benefits. One, dilatation may help, and the other thing is it may prevent. I mean, it's a bit of controversy, but still there are a lot of people who feel that giving a non-steroidal anti-inflammatory drug 3 days pre-op may be more beneficial for as a regression for cystoid macular edema.
So I
We
think
have
that-
seen in our patient, people with the normal macula, mean that macular edema is resolved, but after surgery, it again develops. That is because of the positive and negative pressure as well as prostaglandin release. So it is safe to use non-steroidal anti-inflammatory drugs in diabetic patient.
I think even generally in the cataracts, we all prefer non-steroidal as a combination when we are dealing with the cataracts. So in diabetics, we may not be, but as we were talking about, somebody already had diabetic macular edema, yes, you will continue intravitreal injections later as well. Diabetic macular edema, investigations-wise, Dr. Mazhar, what's your, if somebody comes and you can see clinically that there is diabetic macular edema, so what investigations would you like to do, or what you routinely do investigations in diabetic macular edema patient?
If it's a patient, known patient or diabetic macular
Well, you have
edema,
seen, you're thinking
you
that
can
there
see
is-
it.
yes.
I think so. OCT and OCTA is nowadays a normal norm, and which we normally see
You
these
do
cases.
both OCT and OCTA, both you do?
Since I've got both of them, so I don't mind
Right.
telling them
So
patients
you
to
do.
learn. But most of the time, it go for OCT,
OCT.
because unless you're a bit of confused with anything else, or if you want to see a subtle kind of a new vessels, or you want to see a subtle kind of, in case of diabetic retinopathy, the only benefit would you get from an OCTA in a case of a diabetic retinopathy is that you may be able to see, because you have got a cataract also, you may be not be sure whether he has got new vessels on the disc or new vessels, as well as they may give you a bit better picture upon that thing. And since we are looking for, rest of the things are almost the same, I would go for this thing. And as far as FFA is, only if I'm something, when I'm really confused with something, that what it is exactly is there, whether there's any severe damage or is there an ischemic retina or whatever it is, I can't see mainly. Yeah, I'm talking about a case who's pre-operative for cataract surgery. Is not a normally, I do not go for FFA until unless I want to visualize something or want to have a diagnostic problem, because I would rather, if I see an OCT, a diabetic retinopathy or anything, I will treat it with an anti-VEGF, as we've already, Tariq has already said, and then see it. And afterwards, I may go for an FFA if I find out there's something sinister going on. Because even with the good FFAs, with the cataract on, it's always become a very difficult, it's always it's not very good views. So you may not be able to guess unless you have got some diagnostic problem. So OCT is very safe and very easy and patient friendly. That is also very important.
What about you, Dr. Tariq?
Most of the time OCT is sufficient. If you are suspecting some ischemia or sometimes the fundus look is not very bad, but actually the vision is drastically affected. And you think that this is not only the cataract which is causing this decreased vision. There may be some ischemia as well. Then I think wide field FFA is one of the good choices.
if
So
available.
What about if diabetic macular edema you have diagnosed clinically? Would you definitely do OCT, or you will go for injection without doing OCT?
I think if I get a patient for the first time and I have not done the OCT before, OCT should be performed as a control or as a diagnostic tool. Later on, you can treat the patient.
Yes. But treatment naive, you would always do OCT
Treatment naive
first.
should always have
Yeah,
OCT.
I think it's a very important point. When you get the patient with diabetic macular edema, it's always better to do OCT. One reason that you're documenting, because you're starting management of the patient. Secondly, important thing that you can see the vitreous component there. Is there any tractional there? Because if the tractional, it may possible that patient will not get the response. And later patient will say, Doctor Sahab, aapne to 3 injection bhi laga diye, kuch nahi hua. But before, if you had OCT, you would know that, and you can tell the patient, we can try injections. If it gets better, it's good. If it doesn't, then you have a solid proof there. And FFA, again, as Dr. Mazhar mentioned, you will be in selective cases.
Yes.
You would do good.
What about the dense cataract, very hard and dense cataract? We know.
In diabetic macular edema, if you can see, or because in
If
that
it
case
is
you
not
have to take.
visible, even you cannot do OCT. So
Yeah, well, you have to go with the.
FFA में भी आपसे बड़ी मुश्किल से नजर आएगा उसमें FFA भी करना मकसद है कि उसमें FFA में भी बहुत डिफिकल्ट है जब डेंस कैटरेक्ट हो जाएगा कुछ नजर आएगा तो फिर आपको क्लिनिकली यू हैव टू जज इट ना कि जी वेदर यू हैव टू टेल एंड अगेन द इंपॉर्टेंस ऑफ टेलिंग द पेशेंट बिफोर हैंड दैट पहले एक तरीका ये है ना कि आपको यू हैव अ प्री ऑप नॉलेज अबाउट द पेशेंट दैट ही हैड अ DME और यू हैव ट्रीटेड हिम एंड नाउ ही हैज गॉट अ डेंस कैटरेक्ट then doing any investigation is of no benefit at all if it is got a dense cataract where you can't see anything. The only thing is that you make sure he is sitting, his immediate family members are sitting. मैं हमेशा हरे को कहता हूँ कि it is not only the patient because once sometimes the patient may be very happy with it but his son or his wife or whatever it is, they are the one who will always cause problems कि डॉक्टर साहब इसको तो नजर कुछ नहीं आ रहा वहाँ से मैंने विजन चेक कराई है इतनी है तो आप मेक श्योर करें दे आर सिटिंग विद यू एंड टेलिंग देम कि यार ये प्रॉब्लम है पहले ही प्रॉब्लम थी आप तो अचानक आ गए और यूजली व्हाट हैपेंस इज they have got a treatment done with you for about an year back in which you said there's an early cataract और अभी हमने इंजेक्शन लगा दिए हैं फिर आप आना 3 महीने बाद वो 3 महीने के बजाय they come back after 1 year. By that time the cataract is completely dense, they can't see at all and they say कल cataract surgery कर दें आप. This is the normal norm in Pakistan. So you have to be very sure to tell them I can't predict what the result is going to be. Cataract has to be done, but you are जो मैंने पहले किया था वो सब बाद में करो कितनी नजर होगी ये अल्लाह जानता है ठीक है दिस हैज टू बी वेरी मच क्लियरली मेक हिम अंडरस्टैंड इन द लैंग्वेज इन विच अंडरस्टैंड दैट इज ऑल्सो वेरी इंपॉर्टेंट अंग्रेजी बोलने की जरूरत नहीं है वहाँ आप उसकी जो लैंग्वेज है पश्तो है इवन आप सवाल अगर सवाल से आया तो मैं ऐसे कहता हूँ पश्तो वाले को लेके आओ ताकि समझाओ इसको दिस इज वेरी इंपॉर्टेंट
And I think documentation is very important. You need to document it because later sometimes these patients go away. They may not come. You will get letter from the court or something. When you will remember that. Oh, I have already mentioned about things, and that will. Coming to the management treatment, anti-VEGF. I believe both of you first start with the anti-VEGF. Is that right in diabetic macular edema, or still you would go for steroid or Dr. Mazhar? Your first choice would
first
be
is always anti-VEGF. There's no second thoughts
and
about it.
which anti-VEGF would you go for first? If the cost is not the issue. If cost is not the issue.
At the moment, if what I do is, you have not written my favorite Avastin. So यहाँ से शुरू होती है ना वो
Yes. I haven't written intentionally. I haven't written, but yeah, that is another.
No, because this is what is.
Yes.
I think so. What it is like. Ground reality is this that if it is a role of anti-VEGF, हमारे पास patient का it's our workload is like this that we have got a spectrum of patient coming from very poor to the highest kind of it.
So if the cost is not the issue,
the cost is not the issue. I will go for aflibercept.
You will go for aflibercept.
Aflibercept.
What about you, Tariq?
In my practice, 80 to 85% cases I go for Avastin and 15-20%
But if
cases.
cost is not the issue, in such
yeah, Eylea.
You will go for aflibercept.
Yes.
Right. But how many of us are doing Avastin injections? Such बोले हैं यार. How many of us?
Almost 100%.
So mostly we are doing, and okay. What about most of the injections? Are we doing Avastin or the other injections? most number of your injections, which one is Avastin or?
Avastin.
So I think we all know Avastin is more commonly, and even not here in Pakistan, even in US, it's one of the, UK is different because legally they're not allowed to, but otherwise most of the places in the world, if you talk about any continent where Avastin is allowed, I think mostly that's the first choice. And we also know it works very well, so that's no problem. So aflibercept cost. What about the Vabysmo? Because it recently came up. What do you think? Still you're not convinced, or?
No. First is the cost. And then most of these patients are, I would rather go for a drug which I know is
okay, because it's there for some time.
And then we know that we are very confident. Yes. And there are very few patients who will say, "हमें सबसे महंगा लगा के दो." Those who say, "मुझे सबसे महंगा लगा के दो, मैं और लगा लूँ." That would be my, because frankly speaking, even in the Western, we have all gone through the different meetings and everything. It's still something, it's still the jury is out to exactly what is going to be. Is it going to be better than, आप एक ही मीटिंग अटेंड करें ना, अभी हम यहाँ बैठे हैं जहाँ हमारा कोई स्पॉन्सर्ड नहीं है ना, तो जब आप जाते हैं ना बायर की यानी कि आलिया वाले के पास, तो वो उसी स्टडी को लेके कहेगा कि इसमें ये चीज़ अच्छी है, दूसरे के पास जाएगा वो कहेगा उसी स्टडी को लेके कहेगा इसमें ये चीज़ अच्छी है. So you have to make and understand that there head to head there's hardly any difference in protocol T है ना, वो जो protocol T है ना जिसमें वो सारी drugs जिसमें देखेंगे, they have not been able to find out any significant difference really to make Avastin better है या आलिया better है.
I think at 2 years they all are similar. So but they will not tell. They will tell, oh, 1 year result, ours is better.
किसी में एक जरा निकाल लेते हैं, ऊपर ले जाते हैं, वो हम सुनना पड़ता है. लेकिन overall अगर आपके पास choice है, तो I think so. And if you are very happy with Avastin, making sure that is sterile, proper तरीके से आप लगा रहे हैं, and you are making sure जो अपनी तरफ से कोशिश करके कर सकते हैं, तो I think so. There's nothing better than Avastin. I still, and as we all do it, हमारी practices में, and we have got a very good results with that.
Dr. Tariq, what about you? Vabysmo wise, still you're not convinced?
Yeah, I think I'm now convinced, but मेरा तो तरीका यही है कि मैं wait करता हूँ. I give it a time to see the results. और अब तो तकरीबन 8 महीने हो गए.
Okay.
और probably I will start from next week, but up till now I have not used Vabysmo in any patient.
We are not talking about diabetic retinopathy, लेकिन I can tell there are few patients जो हमने switch किया from Alia to Vabysmo. They have 2-3 के patients they have really make a difference. अब whether it is because of the drug or whether it is just because the switching over effect, वो भी कीमत है, लेकिन ये है इसमें कोई थोड़ा सा फर्क आता है.
I think we should be innovative. But at the same time, we should be conservative and safe for the patients as well.
Yeah.
So I think, our panel and we agree that anti-VEGF is first treatment of choice in diabetic macular edema. Yes, it depends on the cost as well as efficacy-wise. We know that aflibercept and Vabysmo have got the longer duration of action. Aflibercept up till 8 weeks. Vabysmo we know about it's 12 to 16 weeks. But it depends on other factors in diabetic macular edema as well. How is the diabetic control, their blood pressure control, their cholesterol levels. So there are a lot of things you have to measure and manage besides that, sorry. So steroids, when would you use, Dr. Mazhar? And which one would you use? And
in diabetic, because we are just talking, I will resist my only to diabetic retinopathy. Only in refractory DME. And what do I mean by refractory DME? That is also very important to understand. If it's a patient who, after you giving minimum of 3 to 6 or whatever it is, your 9 injections, there's a different ball game about it, how many injections. But in Pakistan, what we have seen is, उसने 1 साल 3 लगाए, अगले साल 2 लगा दिए, 1 साल 1 लगा दिया, और 5 में 6 साल आ गया. उस वक्त आपने उसके देखने के रेटिना का हाल क्या. And if you think so that there's an edema, and as we say on OCT, we find that the layers are not disorganized and the ellipsoid layer is okay, in which your vision is improving, and the thickness is more, I always give combination of triamcinolone with Avastin, or if he's somebody who can afford it, Alia. So ye laga ke 1 injection of this one, and then 3 injections of anti-VEGF, whatever they want to. And after 4 of these injections, if that refractory DME is improved upon, only then I will go for the cataract.
So it's in refractory DME. Normal DME, you go for anti-VEGF directly.
Anti-VEGF. For normal DME, it's just anti-VEGF. I will not give it to steroids. If it's a refractory DME, then I will go for steroid. But then I'm going to give it for 4 months because it's one steroid injection with anti-VEGF and then 3 anti-VEGF, and then only I will try to do a cataract surgery. Because most of the time, even if you do a cataract surgery, the results will be not be as good as one could expect.
What about you, Dr. Tariq?
Definitely, as sir mentioned, one indication is the refractory DME. I'll also go for suprachoroidal triamcinolone along with anti-VEGFs in those cases in which I see foveal hard exudates. These are also very challenging cases. And also if I have some evidence of ischemia in the macula, say a patient has already done FFA or OCT angio and there is ischemia, sometimes you see patients with a mixed type of macular edema. Some portion is exudative and some portion is ischemic. So in those cases as well, I inject anti-VEGFs along with suprachoroidal. Then I keep injecting anti-VEGFs for 3 months. And then again on 4th month, I aid upon the suprachoroidal again.
So you will repeat again then in refractory one?
Yes.
And your OCT you do after 3?
Yes, after 3 months, yes.
So yeah, I think if we look at the studies or real world evidences, anti-VEGF first treatment of the choice, steroids reserved for the cases where there is no response coming, which we either label as a refractory or chronic macular edema. In those cases, steroids have got role. Unfortunately, we don't have dexamethasone, fluocinolone implants here, but the worldwide there is availability. People go for that as well intravitreally. In Pakistan, I think previously we were using more intravitreal steroids, but because of suprachoroidal, now we are moved more to suprachoroidal injection, and we have seen good response. Now coming to very important thing, laser photocoagulation. Suppose there is a DME patient, and along with that there is proliferative diabetic retinopathy. So Dr. Mazhar, would you manage just with the injections, or would you do laser, or what would be your approach?
I mean, if it's a frank PDR patient I will always go for lasers. I'm saying we know that there are studies which are showing that anti-VEGF are important. But if there's one case on just PDR where you find NVDs and NVEs somewhere with a dry macula on OCT and on your examination, I will just go for PR, pan-retinal photocoagulation until that. Now let's have another scenario in which I find PDR along with diabetic macular edema. It may be a bit controversial, but I normally go together with that. What I do is I do a laser first, and then on the same day I give an injection to them. And continue the same process, because what I have seen, मेरा patient जो है 3 महीने के बाद he's gone. मुझसे पूछा ना क्या एविडेंस है, बस मेरे पास एविडेंस ये है कि मुझे पता 3 महीने तक वो मरीज़ उसका बाप उसके जो भी हैं लवाकिन तब बर्दाश्त कर लेंगे, 3रे महीने के बाद हो जाएंगे. तो 3 महीने का मेरा पैटर्न ये है कि मैं अगर PDR और DME है तो मैं इंजेक्शन भी लगाऊंगा और PRP भी कर दूंगा, और 3 इंजेक्शन लगा के उसको जितना मैक्सिमम पॉसिबल कर दूंगा, एंड देन इफ इट इज़ अ कैटेटर यू कैन डू द कैटेटर. लेकिन आई विल ट्राई टू फिनिश मैक्सिमम पॉसिबल लेजर्स विच कैन बी, मतलब आपकी 3 सेटिंग्स हो जाएँ तो आई थिंक सो मोस्ट ऑफ द टाइम यू हैव फिनिश्ड बाय PRP. दैट आई वुड नॉट टू हैव लेस देन 3000 burns and periphery में, and then also with the same thing you injections. Now if it is something like that, if it is a macula sparing, a foveal sparing kind of a thing, sometimes you can find circinates somewhere roaming around near the arcades and everything, then I even go for focal PRP, because I know there are a lot of papers in the world which says कि अभी ये चीज़ PRP ख़त्म हो गई, लेकिन हमारी पाकिस्तान की population में, let me tell you, I have been doing laser since 1985-86 से कर रहा हूँ, and I still see those patients, those who are alive, जिनके मैंने उस वक्त treat किया है, even with हम उस ज़माने में grid करते थे, और हमने ये focal जिनको photocoagulation के जिनके circinate develop होते हैं, याद रखें कोई दुनिया का पेपर नहीं है on anti-VEGF. When you ask them what is the studies after 5 years? Is it like this कि 3 years जो studies हैं वो 5 years तक पहुंच चुकी हैं, लेकिन उसके आगे से there's no evidence what is going to happen if you stop using anti-VEGF, and we know in our Pakistan our patient is never going to be using anti-VEGF for 5 to 10 years. They always feel कि 3 injections होंगे तो इसके बाद खत्म है. Still there's a place for lasers. Still I think so it should be, one should learn it, and still there's a place for a grid and a focal photocoagulation, and they still work.
If the patient have resolved edema, each and everything by doing lasers and anti-VEGF, each and everything, okay, and patient have dense scar in the retina, and the disc is compromising pale, so and she developed cataract. So what will be your approach for that patient?
No, if
you have less hope for the vision.
हाँ, देखें वो तो देखें these are difficult decisions to make. If you see disc has gone pale, ठीक है, ischemic disc हो गई है, ठीक है, disc भी pale हो गई है, retina में आपको पता चल रहा है कि it is ischemic retina, then whatever you are going to do is not going to be.
हम तो जनरल साहब के साथ भेज देते हैं कि पिंडी चले जाएं.
हम देखते हैं वही ना. So again इन सारी चीज़ों में जो है ना सबसे important चीज़ है, मैं आपको बताऊं, हम घूम फिर के जो आते हैं ना, it is how good you explain to the patient. देखिए कोई रिजल्ट्स किसी के हाथ में, if the macula is involved, if the optic disc is involved, जो मर्जी आप कर लेंगे उसमें वो कॉम्प्रोमाइज होएगी, लेकिन उन लोगों को बताना पहले, समझाना पहले वेरी इंपॉर्टेंट. आई थिंक सो टेक होम मैसेज वुड बी कि जिनको इसमें, लेकिन मैं इस पे with lot of evidence I have discussed with those people, those who were doing lasers in the past also ना, not the new, अभी जिन्होंने सिर्फ इंजेक्शंस लगाए ना, वो नहीं, जिन्होंने वो देखे कि वो आई हैव माय गॉड में पेशेंट जिनको मैंने 20 साल पहले 30 साल पहले जिनके PRPs किए हैं वो अभी तक स्टेबल हैं, स्टेबलाइज हैं. देयर आर लॉट ऑफ पीपल जिनकी विजन ख़राब भी हुए हैं. जब हम एक स्टेटमेंट देते थे कि इवन आफ्टर डूइंग PRP 20 to 30% विल स्टिल लूज विजन, ये आज से 30 साल पहले भी यही हमारी, और ये स्टेटमेंट अभी भी है, और इवन आफ्टर एंटी-VEGF भी यही स्टेटमेंट कि स्टिल व्हेन वी गिव इंजेक्शन स्टिल दे डोंट. God knows what is going to happen, लेकिन I think so we should have the take home messages कि आप लेज़र ज़रूर रखें और सीखें किसे. The important thing is how to apply the laser. ये अभी हम एक और जगह मीटिंग में हम तीनों बैठे थे. It is not that कि लेज़र होना चाहिए, it is मशीन रखने का कोई फ़ायदा नहीं. मशीन को लेज़र करना किस तरह, आपने पेरिफेरी में कितना लेज़र लगाना है, कहाँ तक लगाना है, किस तरह से लगाना है, that is most important. And I think so this is, I think so, is going to be part of our training also. जो part 2 की ट्रेनिंग में कि we should make sure that all our trainees should go through system in which they do lasers. And हम जब होते थे तो हमारी तो पूरी मतलब लिस्ट होती है, हम देते हैं कि जी लिस्ट करें अपनी पूरे लेजर्स के, एंड देन द कंसल्टेंट सीज देम कि किस तरह से आपको लेज़र करना है. इनएडुकेट लेजर्स उसके बाद आप जो मर्जी कहें कि पेशेंट कभी ठीक नहीं होगा, एंड लीडिंग टू विट्रस हेमरेज, रिकरेंट विट्रस हेमरेज हमारे पास आते ही वो हैं जिनके इनएडुकेट लेजर्स. क्योंकि आप देखें विट्रेक्टरी करने के बाद भी एंड रिजल्ट क्या है, हमने करना तो लेज़र ही. एंडो लेजर इज व्हाट इट इज PRP.
I think for me also the mainstay treatment for PDR is photocoagulation. एक चीज़ जो मैं अक्सर अपने ट्रेनिस को बताता हूँ, बेसिक पैथोलॉजी क्या है डायबिटिक रेटिनोपैथी में या डायबिटिक मैकुलर एडीमा में. बेसिक पैथोलॉजी है VEGF लोड, और VEGF लोड जो है सिर्फ एंटी-VEGF से कम नहीं होता, लेज़र से भी कम होता है. याद रखें आज की कोई भी स्टडी मल्टी सेंटर रेंडोमाइज क्लिनिकल ट्रायल का ये मतलब हरगिज़ नहीं है कि वो ETDRS या जो DRS स्टडीज़ थी उनको, मतलब वो भी अपने ज़माने की बेंचमार्क स्टडीज़ रही हैं और मल्टी सेंटर रेंडोमाइज क्लिनिकल ट्रायल्स रहे हैं, और उन्होंने उस वक्त जो एफिकेसी लेज़र की बताई है दैट स्टिल रिमेंस. हमारी जैसी जो सोसाइटीज़ हैं जहाँ पे बहुत ज़्यादा इंजेक्शंस अफोर्डेबिलिटी के लिहाज से भी और कन्वीनियंस के लिहाज से भी पॉसिबल नहीं होते, लेज़र इज़ अ गोल्ड स्टैंडर्ड ट्रीटमेंट.
Thank you. So I think consensus is that PDR with or without diabetic macular edema, you need to do pan-retinal photocoagulation, and it needs to be a good photocoagulation. You want to come up till the arcade, one disc diameter above, one disc diameter below. Nasally, you leave some area. Temporarily, you come up to 5 disc diameter area roughly. Apart from that, periphery, as much as you can go, one burn apart, grayish-white burn you need to do, and proper razor. As Dr. Mazhar mentioned that even repeatedly you do at certain areas, no point of, that patient will definitely have recurrence of hemorrhages, NVD will keep on growing. So you need to have
एक point मैं add करना चाहूँगा, especially for trainees. When the PDR and DME, they coexist, and you are planning PRP, so you sometimes get titerated macular edema. The macular edema actually exacerbates. तो आप पहले से मरीज़ को ज़रूर explain किया करें कि शायद आपकी central vision deteriorate हो जाए for some time. दूसरी बात एक बहुत important, recently मेरे पास एक patient आया था who was on dialysis और young लड़का था और उसको bilateral PRP हुई थी और he got bilateral exudative retinal detachments. बहुत ज़्यादा परेशान और तो ऐसे cases में जिनमें blood retinal barrier compromised हो बहुत careful PRP करें. Better to do it, to do one eye first and then go for another eye, and always keep the patient on steroids.
And it also matters duration-wise because people mostly use 0.1, I use 0.05, so that's a bit more gentle and less chances of inflammation in that way. So yeah, regarding injections, Dr. Mazhar, you do PRN, you do treat and extend, or you just give fixed doses of 3 injections, what you do? In diabetic macular edema we are talking about.
मैं ये कह रहा ना कि मतलब ट्रीट एंड एक्सटेंड भी हमने देख लिया है, PRN भी देख लिया है, फिक्स डोजें देख ली, तो मेरा ख्याल है जो मैंने अपना निकाला, मैंने कहा है कि 3 महीने का जो है ना आपके पास पाकिस्तानी मरीज़ आपके पास आएगा, कंप्लायंस उसकी 3 महीने में होगी. अगर आपके पास PDR और DME का तो आई वुड गो फॉर 3 months and give him injection, because after 3 months most of the, but if you, frankly speaking, if some patient is coming who is good enough, who understands the things, so I will always treat and extend. And but initially 3 loading dose is a must. And because we are just managing of DME, so if we case, then I will always give them 3 injections and then see how the thing.
What about you, Tariq?
Yeah, initial 3 injections and then treat and extend. But I always try कि patient का जो laser part of treatment है वो इन पहले 3 महीनों में मैं complete करूँ.
So in diabetic macular edema, I think the point of discussion here is because in wet AMD it's different condition in which you have to keep on doing it for many years in some patients. Here, once the fluid is absorbed, you stop it. Basically, you want diabetic control to be better. You don't need to continue, keep going for a longer period. Dr. Tariq Khan, would you like to come up as a panelist? So we were trying to find you. That was not hall 1. This was hall 1. Okay. So, मैं भी आपको इधर ढूंढ रहा था काफी देर से, मुझे नजर नहीं आ रहे थे आप क्या कह रहे हो, हॉल 1 में बैठो.
इसके बाद जितने सवाल हैं ना वो तारिक जवाब देंगे, हमने बस हमारी ज़बान थक गई है.
अच्छा, surgical management of advanced diabetic retinopathy. So let's, first is diabetic vitreous hemorrhage. So, yeah, so first tell me about anti-VEGF. Who will you, patients in which you will do anti-VEGF in diabetic vitreous hemorrhage?
The picture you have shown.
Well, yeah, let's suppose this picture I have shown.
I'll do a B scan first.
You'll do
to
B
know
scan
about
first.
the TRDs कितनी है कि नहीं है, ठीक है? And anti-VEGF, there's no TRD, retina flat है, I'll go for anti-VEGF and good control of diabetes.
1 injection, 3, or what your plan would be?
जो पूरा plan है 3.
3 you would go for.
Well, keep on monitoring the patient.
Sure.
जैसे clear होगा and you apply the laser. अगर वहाँ पे वो है, tractions हैं, so then I'll give anti-VEGF, but I'll make the patient prepare for the surgery within 1 week.
And that is in a case if vision gets worse.
Yes.
You would try. What about you, Dr. Tariq Maru?
I think vitreous hemorrhage, मैं अक्सर ये बात करता हूँ कि this is a disease which should be treated by vitreoretinal surgeons, not by the medical retina doctors. I would suggest कि आप एक injection लगाएं. That is what my approach is. I inject. पहले मैं B scan कर लेता हूँ, assess कर लेता हूँ. There is no TRD. I go for 1 injection, and I ask the patient to come again after 1 month. I see if there is an improvement, significant improvement, then I will treat the patient with another injection or maybe PRP if the view allows. लेकिन अगर कोई significant improvement नहीं होती तो I go for early vitrectomy. और मैंने आज तक I would like to say this कि कोई भी vitreous hemorrhage के केस में early vitrectomy की है, मैंने उसको regret नहीं किया.
Secondly, we should see the other eye also.
Yes.
अगर वहाँ पे ऊपर TRDs and you expect the TRDs इसमें भी हैं. What I do is first I make the patient fit for surgery. उससे कहता हूँ कि अपना HbA1c control कर लें, hepatitis B, C के test करा लें. When he's fit, then I inject and then I prepare this patient for surgery within 1 week. बाकी अगर वो worse नहीं हो रहा, तो we can always follow the patient and keep on injecting anti-VEGF. Anti-VEGF I inject only to decrease the vascular component of the fibrous tissue.
What about you, Dr.
मैं usually वही in between करता हूँ usually कि मैं जब vitreous hemorrhage के साथ आता है along with all the investigations which you already talked, I give him an intravitreal anti-VEGF and tell him to come back after 2 weeks. If after 2 weeks if he is fine, if the hemorrhage is going down and I can do a laser, I will go do a laser. If it is, I prepare the patient. So if after 2 weeks if he is the vitreous is still dense, I will go for the surgery.
Yeah.
And
So
secondly, sometimes I plan the surgery. अगर surgery करेंगे चले पैसे आएंगे.
So
And the patient comes with a clear vitreous. वो PRP हो गया पैसे के.
So I think important thing here is vitreous hemorrhage. One thing you want to make sure it's related to proliferative diabetic retinopathy, or is it due to some other cause? So even in diabetic patient, you need to make sure. So as we talked about, you look at the other eye. If there is no diabetic retinopathy, it's very unlikely that this eye will have proliferative diabetic retinopathy. B scan will give you clue as well. So not every vitreous hemorrhage patient you just rush towards injections. You need to make sure what's the diagnosis, because sometimes blood vessel has ruptured there due to the tear formation when the PVD is happening, and bleeding is from there. Because I had quite a few patients in last 1 year who had actually retinal detachment, and they were every month they were having injections for vitreous hemorrhage because other person was suspecting maybe, and they were not even diabetic. So it's always important to look for, and Dr. Mazhar pointed out, you need to see the patient. Even if you're injecting, you need to follow the patient after a couple of weeks to see how the things are.
So what is the status of vascular growth factors
What is
without vitrectomy and after vitrectomy? Vascular growth factors.
What is
status means the quantity of vascular growth factors.
You mean regarding macular edema or?
No, after vitrectomy and if you don't do a vitrectomy.
If you don't do the vitrectomy and there's still blood, the VEGF is being produced because you're not doing anything. Decreasing the VEGF is either by injections or by PRP. अगर आप दोनों PRP नहीं कर सके and you cannot inject because of the proliferation or because of TRDs, तो VEGF तो कम नहीं होगा. But if you do vitrectomy, there are two things. Number one, the oxygen supply to the blood surface will be increased. और during vitrectomy आपने इसको PRP भी करना है, laser भी करना है, and that laser will decrease the amount of VEGF which is being produced by converting the ischemic into infarcted area. So after vitrectomy and laser, the VEGF level will decrease.
It will be decreased.
Yes.
Yeah.
What about early vitrectomy and how early? Dr. Tariq Khan, how
Early
early would you
vitrectomy.
do vitrectomy? How early would you do if it's not resolving? You give one injection in 4 weeks' time.
Having
still-
good machines, and you shouldn't be reluctant. दूसरी आंख का हाल देखें. You can always decide looking at the other eye कि वो कैसा behave करी, उसमें क्या हुआ है, उसमें क्या नहीं हुआ. And you can do early vitrectomy within 1 month or 6 weeks.
So you would prefer early if it's not clearing?
Yeah, early vitrectomy, that
Dr.
will.
Mazhar, what about you?
I'm saying वही वाली बात है कि if it's a one eye person and I can give him an injection if it's such a dense catheter and knowing everything about him, and if I have to do it, I can do it after 3 days. But normally my practice is that I give it 2 weeks kind of time because
So 2
most
weeks you will wait. And
you always
then
wait. Yeah, giving an injection and
Yes, and 2
then
weeks
wait
you
for 2
wait.
weeks.
If it's not clearing, then
And
you can go
that is my normal. But sometimes if the patient is very apprehensive, only one-eyed person or something like that, you can do it anytime, whatever you find.
What about you?
ये इस पे भी डिपेंड करता है कि विट्रियस हेमरेज है किस टाइप का, ऑर्गेनाइज्ड ब्लीड है, इंट्राजेल ब्लीड है, सब हाईलाइट ब्लीड है, इस पे भी डिपेंड करता है. डेफिनेटली इस पे भी बहुत डिपेंड करता है कि जो को फैक्टर्स हैं, जो रिस्क फैक्टर्स हैं पेशेंट के, वो किस पोजीशन में है, उसका HbA1c किस तरह है, उसके ग्लाइसेमिक कंट्रोल का क्या हाल है, तो ये सारी चीज़ें आपको एक क्लू दे देती हैं कि वेदर दिस हेमरेज इज गोइंग टू रिजॉल्व बाय नेचुरल हिस्ट्री और नॉट.
Yeah, I think it's important. How is the other eye? If patient is having only one eye, non-seeing eye, definitely it's quite stressful. You can go earlier as well. Other clues, as Dr. Tariq mentioned about, you can see, sometimes even you can see whitish membranes there, which means that there is a tractional element which is causing the bleed repeatedly. So you can go early. In those cases, most likely they will develop recurrent. Even you ask them, they will say, हाँ, कुछ अर्सा पहले भी आया था, मुझे 10-12 दफ़ा आ चुका था. You know that it's not going to go away. So it's better to deal with vitrectomy. Role of anti-VEGF in diabetic vitrectomy, just vitreous hemorrhage if it's. Dr. Mazhar, would you do in every case anti-VEGF you would inject or selected cases?
If it's a vitreous hemorrhage, even of diabetic, and if I plan to do a surgery, I will always give an injection.
You will give?
I will always give an injection if I plan to do a vitrectomy. Even if I don't want to, if after 2 weeks
So every vitrectomy in diabetic, you do injection?
I do injections.
Okay. What about you?
No, I don't. It's only in selected cases.
Selected cases.
What cases? TRDs हो, उसका vascular component कम करने के bleeding ना हो. Otherwise, like a
But vitreous hemorrhage wise, you don't
non-absorbing
give,
है, so you can do just vitrectomy without anti-VEGF.
What about you, doctor?
Only in those TRD cases in which I can see the new vascular component. Not
because I think one argument people try to give it, I don't do either in cases in diabetic tractional detachments which are juicy vessels, I do it 3 days before surgery. But some people talk about if you give injection either before or after the surgery immediately, they give at the same time to prevent post-operative जो bleeds है उसका risk कम करने की.
Just want to add on, if you're doing a vitrectomy and you have injected canacort to visualize the vitreous, the canacort itself is a very strong anti-VEGF. So at the end you don't need an anti-VEGF. Let the steroid be there and...
I think so. These are all different, we all have got our own opinion about things, and I think so. And this also, timing has also gone in a different way. If you have known a patient, if you have seen a patient, if it's a very simple, straightforward vitreous hemorrhage and you know what is the retina like, I think so you can, you may avoid it. But all of these things are, as far as the importance of the thing is, it all depends upon the patient and upon the doctor and how he feels about it, what is to be done to the patient. Just to add on that, anti-VEGF has been now, I was just reading through one paper that now most of the world anti-VEGFs are being used for in the surgeries. But naturally, we have already talked about this thing. Whenever the patient with the vitreous hemorrhage comes, you will always do a ultrasound, and you will see what kind of a traction detachment it is, or what kind of a vitreous hemorrhage he has got. And also, as Tariq has said, what is the amount of hemorrhage it is. And if you can make out, and you can decide what. And the important thing is that you can, even if you don't give what Dr. Ahmed has very nicely talked about, that you can give it intraoperatively also. When you finish doing a vitrectomy, you can add on with this thing, or as it if it is using a tramsilon, that can also add. So there are different ways of doing these kind of surgeries.
Yeah, vitrectomy / phaco-vitrectomy, what's your threshold for the cataract, Dr. Mazhar?
Normally,
do you put the lens or not? That's another question.
I always touch the lens. If it is above 40 years or something like that, usually they have got a bit of a cataract there. But most of the time, then you have to go for an surgery. I normally combine my phaco with cataract surgery. If it's because cataracts are usually in the young way. And even in a diabetic younger people, it is also beneficial in my hands, I think, so if I do the cataract at the same time. Because nowadays, the vitrectomy and phaco is such a safe procedure that it really doesn't make any inflammatory response in the eye. And I feel very comfortable doing both of the procedures together.
And you put the lens at the same time? Or
I combine, I put the lens at the same time.
Dr. Mazhar, combined? You do?
Combine.
What, Dr. Tariq, you prefer more phaco-vitrectomy or vitrectomy? Or?
Because if you, after 2 weeks, you tell the patient that cataract develops, after what, confidence आपका lose करता है.
So you go with combined, yeah?
डेफिनेटली
Yeah, and
एक तो ये फ़ायदा है कि आप पेरिफेरल लेज़र
Yes,
आसानी से
you
कर
can do-
सकते हैं.
yes.
दूसरी बात ये है कि इफ़ यू नीड टू पुट ऑयल इन सच केसेस तो उसके लिए आप पेरिफेरल शेविंग आसानी से कर सकते हैं. 6 o'clock को आसानी से शेव कर सकते हैं विदाउट टचिंग.
and you put IUL as well, Dr.
Yes,
Tariq, at the same
yes.
time.
Yeah, visibility is important. My question here is, how much, I mean, in diabetic vitrectomy, I'm not about detachment, how much peripheral shaving is required?
Yeah, I think let's ask Dr. Mazhar and Dr. Tariq first, and then I'll ask.
मैं इसका एक बड़ा मज़ेदार आंसर देता हूँ. जब हमने विटेटमी शुरू की ना तो वो हमने कहा कि एक पहले तो एक विटेटमी कोर विटेटमी हो जाए तो बड़ी बात होती थी. उसके बाद उन्होंने कहा नहीं जी जितना पेरिफेरी को भी करना शुरू करो. एट दैट टाइम वी डिड नॉट हैव आई बहुत सारी सिस्टम नहीं थे तो उसमें होता था कि जितना असिस्टेंट दबा देना उतनी वो कर दो. दैट वाज अ शेविंग एंड देन proper shaving came up and then the shaving mode came in the vitrectomy machines ke jisme shaving mode. So I usually, from my point of view, if the maximum which I can see through and with a mild indentation, that is enough for me. But I will make sure that all of it
You
is
don't want to leave any vitreous,
which is
whatever you
going
see,
attached with the periphery. It is attached with the central retina. That should not be.
That should not.
Tariq?
I think if you are not putting tamponade, then probably it's not needed extensively. But if it is a case of combined tractional rhegmatogenous detachment, then I think you need to shave extensively. Otherwise, if you leave some space, तो early emulsification भी होगी और इसके अलावा
Normally,
fill भी पूरा नहीं.
I think so. Normally, all our practices that we go for the maximum possible of shaving. It's a setup of our mind that we'll do the maximum possible shaving. And normally, when we do finish off with the shaving, then we decide इसमें oil डालना है नहीं डालना है. अब देखते हैं. Usually, I complete my shaving maximum, which I normally do. किसी
Yeah,
case में.
I think easily as much you can remove.
And you can always scan, उसके साथ scan होता रहता है peripheral retina, when he breaks or not.
Yes, always important is intrinsic. So that's just a subhighlight. So that's again subhighlight membrane. We can see shiny membrane. So you need to remove them completely. If you don't remove, then it's a problem. So let's come to tractional and combined tractional rhegmatogenous. What's your take, Dr. Mazhar? When would you intervene? If it's a patient comes to you with a tractional retinal detachment, which area, if it's involved, then you will go for surgery? Which area you will just observe?
My would be if it's a traction involving the macula, or if I feel that this traction is going to lead to macular detachment or macula is threatened. What I mean by macula threatening is कि जी आपकी इस किस्म की traction आ रही है जो उससे वहाँ पड़ी रही तो उसके बाद fovea detach हो जाएगा. अगर आपको वो नज़र आ रहा है, that needs to be sorted out wherever it is. This is the my cut-off point. And if it's somewhere in the periphery or which is not going towards the macula, आपकी ऐसी traction है, तो that can be done, or nasal traction है, which is not extending towards the fovea, you can wait and see. That is
What
my
about you, Dr. Tariq?
Yeah.
Tariq Khan.
Okay, दोनों Dr. Tariq Khan हैं.
Tariq Marwat, Tariq Khan.
Tariq Marwat.
अगर blood vessel, I'll add on the same thing. If there's no traction on blood vessels, so blood vessel bought traction, so it can bleed.
Like
and
if somebody recurrent vitreous hemorrhage happening.
yeah, and macula is fine, and you can do a good PRP, so I'll leave those tractions.
What about you, Dr. Tariq Marwat?
I think I will always individualize the patient before going for surgery. कोई भी absolute indication नहीं है, कोई भी absolute contraindication नहीं है. Real time में जाके आप decide करें whether you want to go for surgery or not. Every membrane is not to be removed. I think हर एक tractional membrane जो है, that is not an indication for surgery. If you think the macula is threatened, if you think the macula is detached, and you can treat the patient with surgery, otherwise you can leave.
Yeah.
Conservative approach is always should be the first
I
priority.
think vision is giving clue. Other thing, it's important to do OCT in such cases because sometimes there can be very fine membranes and they are actually lifting up the macula. So you do OCT, and as we all agree, if it's a macula is involved or macula is threatened, mostly then you want to intervene. Otherwise, if it's a peripheral traction, you can watch it. It's not causing any vitreous hemorrhage or it's not a problem.
Vision is also very important because if the patient have 360-degree traction and he has very good vision, 612, 618 vision, and he is doing well with that vision, so I think we shouldn't touch that traction because it can lead to a lot of complication.
Yeah, I think we need to be quick. I think regarding the gauge, in diabetics, any preference or you just do the same as you do for other retinal detachment or other surgeries? Dr. Mazhar?
23.
Dr. Mazhar, for diabetics, you do any smaller gauge or you use the same gauge? which you use for
Normally, I'm going for 23 and 25, depending upon the market and the price. 27, I've been doing it, but first it's not available, now the price is getting higher and higher. So that could be my main reason, but I do not find any difference. But the only good point is that if you have got a 27 gauge, it acts as a cutter, it acts as also as a scissor, it acts as a delaminating membrane. That's a very good point about thing. So really, if you have got a choice of 27, I don't mind using any of them, whatever is available.
Dr. Tariq Khan?
23,
yeah,
because of financial problem. No
Dr.
25,
Tariq
no
Khan?
27.
Yeah, if it is a simple hemorrhage, then I think if I don't need to put oil, then I think 25 gauge. I mostly do 25 gauge.
If oil, then you
But
use 23 gauge?
Yes, with 23 gauge.
Dr. Tariq Khan?
Again, 23, mostly 23.
23 mostly, yeah. So I think it's a personal preference as well, as Dr. Mazhar mentioned. I use like 70-80% of cases I use 27 gauge. All diabetics I do 27 gauge. It's my personal preference, and as pointed out Dr. Mazhar, that it's finer, you can easily cut the membranes easily with that. But you can do with all, important thing is that you need to remove the membrane. So there are different techniques, strategies, dissection, but with a cutter, if you can cut, you can cut. With a scissor, you can do segmentation, delamination. Adjuncts, I think we all use triamcinolone, PFCL or dyes. If we require it, we use it. Anti-VEGF, we talked about combined, mostly we prefer combined, even if slight. So diabetics, they get earlier cataract, so that we have to keep in mind. Tamponade, what mostly you prefer, Dr. Mazhar, gas or oil, if there is a tractional detachment or combined retinogenous tractional detachment?
It all depends upon how good I have done and how good the retina looks like. If I find that I have done an atogenic break or something like that, in these kind of cases are very extensive, then I always try to put an oil there because I feel that my prognosis is going to go bad. And then I get some, if it's bleeding a lot, even those are the cases. But if I find something in which I do a vitrectomy, I have cleaned up all the membranes, I have done delamination or desegmentation, and there's no bleeding, and the retina is flat, and I've been able to do
Even
that.
some break is there, you would gas.
Yeah, if it's a very mild, small break, with which I think so with the gas I can very easily do it. So it's kind of a case-to-case scenario. But my first choice would be putting a gas tamponade, second would be oil. But it all depends what kind of a case I would.
Dr. Tariq Khan from Lahore.
It depends. Membranes, then because in diabetics, sometimes you're not able to remove all the membranes. And if you have done a good laser and there's still some breaks, sometimes you have induced the breaks. So that I'll go for the oil. लेकिन अगर simple as एक हाथ है और उस पे I'm sure कि उस पे membrane नहीं है, vitreous नहीं है, you can go for the gas, especially the superior one.
Dr. Tariq Maru.
I always keep this thing as a priority कि मैं अगर उसको oiling से बचा सकूं. If I do not commit any break, I'll just go for putting BSS or air. But if if I cause some small break, I will go for gas, SF6 mostly. I do not use C3F8 for quite some time. And if I cause a larger break or I cause a detachment, then I always go for oil.
So I think consensus is on that if you have released the traction, you can just leave it air or gas. Even a small break, you can use the gas. So even sometimes the larger breaks, if my traction is raised, I still go for gas. But if you're worried about your traction, something there, oil is a better option.
So oil has more density, so it will keep the retina flat more.
Yeah, but it will not release the traction. Actually, problem is that oil will push it, but as that will shrink, that break will open up again. So important thing is that you need to release the traction. You have to remove the membranes. because even with the oil, it's going to detach again.
It is better to remove the traction and have a brake
Yes.
rather than keeping that traction there.
Important thing that is traction.
Traction. अगर आपकी वो रहेगी, आप जब आपने जब oil निकालेंगे, तो उसने फिर टांग करना है.
One thing I would like to add, many people think that oiling actually stops the bleed. Oil never stops the bleed.
It doesn't stop.
Yes.
That's
Post-operative bleeding, if you want to get post-operative bleeding now, what I do at the end of surgery, I just make the eye hypotenuse. उससे जितने oozing points है ना, उनको laser या cortisone को बंद कर देता हूँ. So that's very good thing.
So you want to cauterize it, you want to stop the bleeding before.
The
So there are
post-op
some
bleeding.
examples of there are membranes, so you basically want to remove it completely. So here is, this is a recently case I did, quite extensive traction. So after releasing it. So thank you very much, but my panelists have answered the most of the question. Any questions you want to ask about, please feel free to ask during this time. This video will keep on playing. That's a combined retinatic and fractional. And I'm doing 27 gauge and using the chandelier light I'm using. So any questions anyone you want to ask?
मैं दूसरी पार्टी आने वाली है, अगले आ रहे हैं.
So yeah, yes, yeah.
Sir, thank you so much for this valuable session. I'd like to ask two questions. Firstly, sir,
ये आप इसमें पूछ लें.
everybody. So thank you for the wonderful session. I have two questions. Firstly, we talked about the anti-VEGF cover before the cataract surgery. So ideally, what should be the duration between the anti-VEGF injection and the date of the surgery? And secondly, because most of the diabetic patients we have a lot of systemic issues such as ischemic heart disease, and mostly they are on anticoagulants. So do you or any of the seniors stop anticoagulants before cataract surgery, and for how long? Thank you.
So I think the first question is about the anti-VEGF, how many days before the surgery? The other question is about that patients are on anticoagulants or blood thinners. For cataract surgery, do you stop them? And if you stop, how
For the
many days?
cataract surgery, I don't stop them. For
Same
this,
here, I don't stop in cataract surgery.
For this retinal surgery,
I do 3 days.
fibrovascular
3 days.
cloth fronto, so then I do stop them at least 5 days. और anti-VEGF के बाद from 3 to 7 days, मुख्तलिफ लोग मुख्तलिफ करते हैं, but within 7 days, I think अब कर लेना चाहिए.
Dr. Tariq, you want to add something? Or?
For me, 2 to 3 days before surgery, I go for anti-VEGF injection, and I always ask the patient to stop the blood thinning agents.
So when you are injecting and basically retina surgery, you need to, blood thinners can make things quite worse. So 3 to 5 days usually recommended time. But warfarin, INR should be in the limit. You can't stop that, so that's important in those cases. But otherwise, Western-wise, yeah, you can do any time. It's not so. Usually after 3 days, I inject in tractional detachment with fibrovascular area, and I do after 3 days, so no problem at all. Any other questions?
Amir, my question is that if you are doing peeling, you do from the nasal side or temporal side?
For ILM peeling?
Yeah.
It doesn't matter where easily you can pick it up. In macular holes, usually I start temporally in the macular hole. In the diabetics, it doesn't matter wherever it's lifted more. You just pick from there and you start it over.
Because the density of the fiber, that is more on the nasal side. So I think you should avoid nasal
Because
side.
macular bundle is there, usually we try to avoid going there. So we either do superiorly, inferiorly, or temporally. So yeah, that's. Any other questions? Anything?
छुट्टी करें.
Okay, thank you very much.
सुबह से लगे.
And thank you for talking a lot. Thank you.
मेरी एक और presentation.
Thank you. Thank you.
Hello, hello, hello. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم هل أتى على الإنسان حين من الدهر لم يكن شيئا مذكورا إنا خلقنا الإنسان من نطفة أمشاج نبتليه فجعلناه سميعا بصيرا إنا هديناه السبيل إما شاكرا وإما كفورا إنا أعتدنا للكافرين سلاسل وأغلالا وسعيرا إن الأبرار يشربون من كأس كان مزاجها كافورا عينا يشرب بها عباد الله يفجرونها تفجيرا يوفون بالنذر ويخافون يوما كان شره مستطيرا ويطعمون الطعام على حبه مسكينا ويتيما وأسيرا إنما نطعمكم لوجه الله لا نريد منكم جزاء ولا شكورا إنا نخاف من ربنا يوما عبوسا قمطريرا فوقاهم الله شر ذلك اليوم ولقاهم نظرة وسرورا صدق الله العظيم. ये सूरह दाहिर की आयत हैं. इसका दूसरा नाम सूरह इंसान है. हल अता अलल इंसानी हीनुम मिन अद-दहरि लम यकुन शय्यन मज़कूरा. Has there come upon man a period of time when he was not a thing mentionable? Inna khalaqna al-insana min nutfatin amshajin nabtalihi faja'alnahu sami'an basira. Indeed, we created man from a sperm drop mixture that we may try him. And we made him hearing and seeing. Inna hadaynahu sabila imma shakiran wa imma kafura. Indeed, we guided him to the way, be he grateful or be he ungrateful. Inna atadna lil kafirina salasila wa aghlalan wa sa'ira. Indeed, we have prepared for the disbelievers chains and shackles and a blaze. Inna al-abrara yashrabuna min ka'sin kana mizajuha kafura. Indeed, the righteous will drink from a cup of wine whose mixture is of kafur. Aynan yashrabu biha ibadullahi yufajjirunaha tafjira. A spring of which the righteous servants of Allah will drink. They will make it gush forth in force and abundance. Yufuna bin nadri wa yakhafuna yawman kana sharruhu mustatira. They are those who fulfill their vows and fear a day whose evil will be widespread. وَيُطْعِمُونَ الطَّعَامَ عَلَى حُبِّهِ مِسْكِينًا وَيَتِيمًا وَأَسِيرًا. And they give food in spite of love for it to the needy, the orphan, and the captive. إِنَّمَا نُطْعِمُكُمْ لِوَجْهِ اللَّهِ لَا نُرِيدُ مِنْكُمْ جَزَاءً وَلَا شُكُورًا. We feed you only for the continence of Allah. We wish not from you reward and gratitude. Inna nakhafu min rabbina yawman abusan qamtarira. Indeed, we fear from our Lord a day austere and distressful. فَوَقَاهُمُ اللَّهُ شَرَّ ذَلِكَ الْيَوْمَ وَلَقَّاهُمْ نَظْرَةً وَسُرُورًا. So Allah will protect them from the evil of that day and give them radiance and happiness. May Allah make them those obedient servants which will be blessed on the day of judgment by the Almighty's blessings. Jazakallah sanal jaza.
Bismillahirrahmanirrahim. I am Professor Sadio Humayun, and today we are going to have a panel discussion on premium IOLs, confusions and controversies. May I request the panelists, Major General Mazhar Ishaq and Professor Ziaul Mazri, to please come on stage. सर कराची वाले नहीं आए दोनों, डॉक्टर आमिर स्टार जो हैं वो भी नहीं अभी तक आए, और ब्रिगेडियर मजीद मलिक जो हैं वो भी नहीं आए, उन्होंने मैसेज कर दिया था कि नहीं आएंगे सर।
ऐसे करें जी, इट्स ओपन फॉर एवरीबॉडी, जिसने कुछ सवाल का खुद जवाब देना बेशक दे दे, कोई हमसे
ऑडियंस आगे आ जाएं सारे, ऑल ऑफ यू आर पैनलिस्ट, तो एक दूसरे से बातें करते हैं आधा पौना घंटा जितना भी।
5:45 खत्म करना है, उसके बाद वो
प्रोफेसर सादिया हुमायूं इजाजत देती है
सर जब आप कहेंगे।
5:45 इसलिए कि वो सेंट्रल काउंसिल मीटिंग भी आ गई, वरना सर संभाल लेंगे आगे।
नहीं सर, हम जल्दी ख़त्म करेंगे, अब जाने का टाइम।
सवाल शुरू,
वो तो शुरू करने भी नहीं चाह रही थी, शुरू से पहले ख़त्म करने को फिर रही।
मैंने कहा शायद सर।
सर अभी आते हैं ना सर, पहले
मैडम सवाल मैडम ने
उधर करने से उधर सवाल
मैं
आने
सर अभी स्टार्ट करती हूँ, फिर बीच में
वो सारे सवाल हैं ना सर, एक लेट्स एक पूरा तरीके से चल रहे हैं।
Sir, my first question is that if a patient comes to you, he walks into your clinic, and after entering, he says that I want to get cataract surgery done, and I want the best lens, and I want the trifocal or multifocal lenses, and I want the best vision. So,
मतलब आप चाहती हैं मैं कहूँ करूँ या ना करूँ?
So how do you consider who is the good candidate for premium IOLs? And
इसका मतलब इससे पहली बात ये होगी ना कि वो पैसा खर्च करना चाहता है, तो ये तो खुशी की बात हुई कि जी चलो यहाँ तक तो बात ठीक हुई। अब उसका अगर दूसरा सवाल है कि मुझे चाहिए भी ये कि मैंने लेंस और मेरे साथ मतलब व्हाट काइंड ऑफ पर्सनैलिटी इज गॉड, दैट इज़ वेरी इंपॉर्टेंट नो। अगर वो एक्सपेक्ट कर रहे हैं कि 100% मुझे रिजल्ट मिलेगा, और इसका मतलब है एक ये दूसरा साथ सवाल आता है कि मुझे पैसे की, उसके बाद दूसरा क्वेश्चन ये भी होता है कि पैसे की फिक्र ना करें डॉक्टर साहब, जितना मर्जी लगे, लेकिन मैं ऐनक उतारना चाहता हूँ, तो उसको तो आप साफ कह देंगे भाई साहब ये नहीं हो सकता अगर आपने अपनी जान बचानी है, ठीक है ना। मतलब जितनी मर्जी हम बातें करते हैं ना, एंड ऑफ द डे कोई बंदा दुनिया का ऐसा नहीं है जो मैं जिन्होंने लेंस बनाए हैं, जिन्होंने लेंस कैलकुलेशन की नहीं, जिन्होंने बायोमेट्रिक्स बनाए क्या मिस्टर हॉलीडे हो या मिस्टर फलाना है, मिस्टर ढमकाना है, नो बडी ऑन गॉड दैट्स कैन बी 100% श्योर कि जी आपका रेजिडुअल कुछ चीज़ रह ना जाए, वट एवर वी हैव गॉट। सो आपका ऐसी पर्सनैलिटी जो आपको 100% कहे, यानी कि हाइपर टाइप होए और जो चाहता है कि ही वांट्स 100% दैट पर्सन, मेरे हिसाब से तो बिल्कुल उसको मतलब आपको यू हैव टू बी वेरी श्योर एंड एक्सप्लेन टू हिम इन द लैंग्वेज ही अंडरस्टैंड्स, यानी कि उर्दू समझता है तो उर्दू में बताएं, पंजाबी समझता है पंजाबी समझाएं, पश्तो है, सिंधी है, जो भी है उसको बता दो भाईजान मैं आपको 100% रिजल्ट नहीं दे सकता हूँ, बेशक जितने मर्जी पैसे ले लें। मेरा तो ये मजरी आगे, इसके आगे कुछ ये तो आगे से शेर भी बोल देंगे।
Full stop. So I agree with General Saab that the patient's expectations had to be realistic. That's very important. In any surgery, even in refractive surgery, if the patient says 100% safe and Dr. Saab, it's not. So same is true with premium IOL surgery. If the patient is understanding, and we explain all the lenses, we give them the range from right from few thousands to few lakhs, we tell them. But I always say them that if you spend $500,000 rupees, even then there is no guarantee that you will not need spectacles. Corrective spectacles is always a possibility. So the patient needs to understand this fact before moving on.
Sir, so as rightly described by the worthy panelist, that those who are having a positive characteristics, willing to understand, easygoing personalities with realistic expectations, and then the good candidates or the best candidates are moderate to high hyperopes and with healthy eyes, healthy optic nerve and macula.
इसमें अगर साथी मैं एक ऐड कर दूं, अगर मेरे से पूछे हु इज़ द बेस्ट कैंडिडेट, मैं कहता हूँ सबसे बेस्ट कैंडिडेट इस जिस मरीज़ की अम्मी या नानी या दादी, ठीक है ना, विद अ गुड मैकुला ये बेस्ट कैंडिडेट्स हैं, ठीक है ना। उनको मल्टीफोकल आप डालें ना, उन्हें फिक्र होएगी ना, उन्हें गाड़ी चलानी, ठीक है ना उन्होंने कोई ऐसा कुछ काम करना है, एंड दे विल बी हैप्पी टू हैव अ लुक अराउंड, उन्हें आने की ज़रूरत नहीं पड़ेगी। मेरा ख्याल है मेरे अगर मुझे चॉइस मिले तो मैं कुछ ऐसी आंटी, नॉट अ हाई स्टैंड फसी ओल्ड लेडी नहीं, जो एक अच्छी लेडी होए, बुजुर्ग होए, जिसका मैकला ठीक होए, और उसे आपको कुछ उसको थोड़ा सा जो प्लस माइनस भी हो जाए, हेलो शेलो, उसको फिक्र नहीं होगी। दीज आर द बेस्ट कैंडिडेट्स।
सो जनरल साहब असल में साबिर और शाकिर ओल्ड लेडी ढूंढ रहे हैं आइडियल लेंथ इम्प्लांटेशन के लिए,
जो होती नहीं है।
नहीं सर, हमने तो खुद प्रैक्टिस में यही देखा है ना कि जो फीमेल्स हैं वो दे आर गुड कैंडिडेट्स, जो लेडीज़ हैं, हाउस वाइफ्स, इवन वर्किंग लेकिन बहुत ड्राइव नहीं कर रही, जो मेल्स हैं जिनकी फ्रीक्वेंट ड्राइविंग है, ज़ाहिर है दे आर नॉट गुड कैंडिडेट्स। तो the next question is again the poor candidates for premium IOL, and as rightly described, those having negative characteristics, type A personalities with unrealistic expectations or perfectionist mindset, hypercritical patients. We should avoid all these patients. बाद में बहुत तंग करते हैं, especially who have heavy dependence on intermediate vision or night vision. Then those who have special job requirements like commercial pilots, taxi or truck drivers. And in addition to that, the low myopes, क्योंकि उनकी नियर विजन वैसे ही बहुत अच्छी होती है और वो बाद में जान नहीं छोड़ते. Now sir, a patient comes to you with meibomian gland disease. I have shown this picture with frothing and with tear film instability, and patient wants to have a perfect vision after cataract surgery. He has a moderate to dense cataract, and he wants to have no glasses, spectacle free vision for distance intermediate and near.
मैं इसकी एग्जांपल इस तरह देता हूँ, ये या कोई मैकला ख़राब है तो मेरे को मरीज़ पूछे तो मैं ऐसे कहता हूँ, या कोई समझदार मरीज़ हो, ज़्यादा अक्लमंद पढ़ा लिखा है, तो मैं कहता हूँ यार देखो बात ये है कि तुम ये जिस लेंस की बात कर रहे हो ये बेसिकली फरारी है, ठीक है, या पोर्शे है, या वट एवर ये अंडरस्टैंड द लैम्बोर्गिनी है, वट एवर इट इज़। लेकिन मैं बताऊँ उसकी प्रॉब्लम ये है कि अगर वो चले किसी GT रोड पे तो वो 4 घंटे के 4 मिनट भी नहीं चल सकती। रीज़न इज़ कि इट नीड्स जितनी स्पोर्ट्स कार हैं या जितनी आपकी ये गाड़ियाँ, दे नीड्स अ स्पेशल इनका, अगर आपकी वो सारी चीज़ें ठीक होएंगी ओनली देन दिस गाड़ी चलेगी। मैं एग्जांपल देता हूँ कि मेरे घर के मैं जा रहा था, एक पोर्शे बड़ी तेज़ी से मेरे कार से आगे निकली और उसके बाद आगे जाके गई तो उसने टेढ़ी हो गई यूँ, मैंने कहा पता नहीं क्या हो गया, आगे जाकर आगे हम्प आ गया था, हम से वो उसको क्रॉस नहीं कर सकती थी। रीज़न बीइंग कि अनटिल अनलेस, मतलब एक चीज़ ये याद रखेंगे, ट्राइफोकल IOL or premium IOLs are only for those in which you have got the best, everything is very smooth and everything is well. Anything having these kind of MGD or dry eye syndromes or other things which we're going to discuss later will always cause problems. So I will always tell them you are not a good candidate for this kind of thing.
इसको पहले कर्नल शहजाद के क्लिनिक भेजें, वहाँ से ड्राई आइज का ट्रीटमेंट करवा के आए, फिर प्रीमियम IOL डालेंगे।
सर हमारे पास भी भेज सकते हैं, हम भी करेंगे।
आपके पास भी है ड्राई आई ट्रीटमेंट?
बिल्कुल है सर, बिल्कुल है।
So you can send to each other. So we need to take care of these things. This is a risk for endophthalmitis as well. Posterior margin blepharitis was one of the no's which Dr. Tariq Saeed taught us during our residency years. We used to write for every cataract patient in that trust setup, no blepharitis, no guttata, no regurgitation, no Marcus gun sign, like this. So this is one of the greatest no's. It has to be controlled before going further.
Sir, I am asking very basic questions, and the reason is that बहुत सारे पेशेंट्स आते हैं जिनके हाथ में एक बायोमेट्री होती है, IOL मास्टर रिपोर्ट और वन थिंग, दे हैव बीन एडवाइज्ड ट्राइफोकल IOLs कि बस करा लें, इसमें कौन सी बड़ी बात है। सो मैं ये चीज़ें सर ने कह दिया फर्स्ट गो में, और सेंटेंस सर ने बोल दिया कि एवरीथिंग हैज़ टू बी परफेक्टली नॉर्मल। सो बट आई स्टिल कीप ऑन आस्किंग कि ये होना चाहिए कि नहीं होना चाहिए। तो meibomian gland disease, definitely this is what the dry eyes or the meibomian gland disease with ocular surface disease will cause. It will affect topography, induces higher order abrasion, affects visual acuity and refraction. There will be change in K readings, change in corneal thickness. There will be inaccurate biometry. आप उसको ड्राई आइस के साथ करें और बाद में ड्राई आइस ट्रीट करके करें तो आपको ये सारी चीज़ें चेंज हो जाएंगी. There will be difference in your IOL calculation. Dissatisfaction after surgery. So any active ocular surface disease is a contraindication. Now, if the patient has abnormal pupil size or location or atrophic patches or large pupil or pseudoexfoliation, so will you still go for the premium IOLs?
Again, we understand that any kind of pupil, enlarged pupil will always cause halos around the light, especially at night. Night में आपको हमेशा तंग करेंगे. So if you have a abnormal pupil, I think so they are, again you will never should go for these kind of lenses. तो इसमें तो कोई, there's no second thought about that. And this is even, I think so, written in the basics में भी लिखा होता है कि जी if there's abnormal pupil or anything like that, we should not go for it.
So that means there is a role of pupillometry.
Yes, pupillometry has a role and you can examine it on the slit lamp as well. And the problem with this pupil matter is to such a great extent that you know the difference between spherical lenses and aspherical lenses was that we were able to finish the spherical abrasion and we made a point focus instead of a conoid of strum by introduction of IQ lens. So this pupil problem, even an aspheric lens can be troublesome because it has a very sharp focal point. I would prefer to go for a spheric IOL like Acrisaf multipiece in that patient, in which the decentration will not matter much. So the premium IOLs are out of question. And as Dr. Sadia pointed out, that we need to document the pupil by pupillometry if possible.
So we have to do pupillometry to see the scotopic or mesopic pupil size, because a pupil of less than 2.5 and more than 6 millimeter, in such patients we should not be doing premium IOLs, or if there is a shift of more than 0.2 millimeter. Such patients, they suffer from dysphotopsias. Large pupil will cause halos and other type of dysphotopsias, and small pupil, in such patients, mostly patients use the central part of the lens and they have a problem in their distance and near vision.
I have recently seen an EDOF IOL implanted patient moving in the whole city with just decentration of the pupil was the problem.
So even if there is a decentration, pupil centered नहीं है, जैसे इस पिछली picture में मैंने दिखाया भी, the first one. So the lens will not be centered on the pupil, और वो आपको फिर बाद में halos, glare, dysphotopsias, ये सारी चीज़ें होती रहेंगी. Now, so the next question is early diabetic retinopathy a contraindication for premium IOLs?
इसको जवाब मैं इस तरह से दूंगा कि अगर आपको डायबिटिक रेटिनोपैथी है तो आपके लिए फर्स्ट एक जैसे कहते हैं ना फर्स्ट रेड साइन आ जाता है. आपको इन केसेस में फर्स्ट ऑफ ऑल इट इज़ वेरी इंपॉर्टेंट. चलें आपके दो ऑप्शन में, अर्ली डायबिटिक वेल कंट्रोल्ड यंग मैन है. यंग मैन का मतलब है कि मतलब अभी तो उसे और डेवलप नहीं हुआ, ड्यूरेशन कम है. यू हैव टू वेरी मच एक्सप्लेन टू हिम फर्स्ट ऑफ ऑल के, और से लेट्स से कि एवरीथिंग इज़ फाइन. एवरीथिंग इज़ फाइन आप किस तरह से पहले देखेंगे कि यू विल मेक श्योर कि आपने उसको देखा है, रेटिना सारा देखा है. आप समझते उसे नो बैकग्राउंड डायबिटिक रेटिनोपैथी, लेकिन आई विल स्टिल इंसिस्ट दैट यू डू एन OCT. अभी हम पिछली मीटिंग में बताया कि OCT इज़ वेरी इंपॉर्टेंट बिकॉज इन वेरी सटल केसेस ऑफ जिनमें डायबिटिक होती है उसमें इट्स वेरी डिफिकल्ट टू सी द ERMs and these ERMs can cause lot of problems. So in essence आपने वो की, लेकिन even if let's say कि is a very early diabetic or everything, you have to be very careful telling the patient कि what can go wrong and what is going to happen after 10 years when जब आपका कोई diabetic maculopathy develop हो जाएगी या DME होएगी तो कितना आपको problem पड़ेगा. So it's a relative contraindication, लेकिन I will never जो डायबिटिक पेशेंट पे जैसे कहते हैं ना, आई विल नेवर ट्राई टू एम्फसाइज कि जी गो फॉर दिस थिंग, आई विल ऑलवेज ट्राई टू उसे रिस्ट्रिक्ट करूँगा कि ना इस्तेमाल करें. मेरा तो ये है.
So there is another question which this question gives rise to, that is being diabetic a contraindication for premium IOL? It's not. If a patient is diabetic but there is no diabetic retinopathy and OCT is normal, we can go for any IOL in my practice. This particular question, if there are signs of diabetic retinopathy, better not to go for premium IOL. We can go till toric IOL तक जा सकते हैं, लेकिन आगे मल्टीफोकल या ट्राईफोकल की तरफ जाना मुनासिब नहीं होगा, क्योंकि उसको एक दफ़ा डायबिटिक रेटिनोपैथी शुरू हो गई है तो जितना भी कंट्रोल कर लें, उसने हमें पता है कि ओवर टाइम इट इज़ गोइंग टू प्रोग्रेस एंड द मैकुलर फंक्शन इज़ गोइंग टू कंप्रोमाइज ओवर टाइम. Being diabetic is not a contraindication if the retina is normal, but having diabetic retinopathy is a contraindication for me.
100% agreed. हाँ क्या जी? हाँ, मैं यही बता रहा हूँ कि डायबिटिक रेटिनोपैथी का अगर एक साइन आपको नज़र आ जाता है ना, तो दैट इज़ फिनिश्ड. मतलब कोई किसी किस्म का प्रीमियम आइल वो कहता भी रहे तो अपना मैं नहीं डालूंगा, जैसे हम मतलब वी फुली एग्री. हम जो बात कर रहे हैं कि ऐसा डायबिटीज़ जिसमें रेटिना में कुछ भी इन्वॉल्व नहीं है, तो आप उसको समझाएंगे या तुम्हारा फ्यूचर क्या हो सकता है. यू मस्ट अंडरस्टैंड, उसे बताना बहुत ज़रूरी है कि क्या करें. वही वाली बात है. हाँ,
एंटी-वेजेफ से कंट्रोल कर रहे हैं, तो मेरा ख्याल है ये अभी तक स्टिल उसी रिलेटिव कंट्राइंडिकेशन में ही है. लेकिन अगर पेशेंट कह इज विलिंग और वो काउंसल्ड है तो हम इसमें ऐसा लेंथ में तो प्रॉब्लम नहीं है.
आप मतलब ये इट्स इन दैट सेंस, अगर देखें इसका जवाब कोई बनता नहीं है इन दैट सेंस कि जी हाँ या ना 100% हो. लेकिन हम जो अपने आप पेशेंट्स देखते हैं डायबिटिक रेटिनोपैथी जिसको अर्ली डायबिटीज़ है, अगर मैं अपने 20 साल 3 साल से देखूं तो वो किधर जा रहे होते हैं. तो अगर हम ये कहते हैं कि एक अर्ली डायबिटिक जिसमें कोई प्रॉब्लम नहीं है इस वक्त, बट वी नो कि 20 साल बाद उसको क्या होना है और उसके बाद उसके साथ क्या होएगा, तो आई एम श्योर कि इसको हमें इतना प्रेस करना चाहिए कि यार मुझे तुम नज़र आ रहे हो कि अर्ली डायबिटिक चेंजेस आ रही हैं, ये होएगा, ये उसे एक्सप्लेन करना बहुत ज़रूरी है. और कभी तो मैं यूजली मतलब ये बताना बहुत ज़रूरी है. बाकी मतलब इसमें वो वाली बात आप वाली है कि इसमें हम किस तरह करें, लेकिन एक अर्ली डायबिटिक चेंजेस रेटिनोपैथीज आ जाते हैं तो आप मेरा ख्याल है मेरा ख्याल इट विल कम टू योर नेग्लिजेंस लेटर ऑन, कि अगर आप कर रहे हैं तो वो आपको कहीं अगर कोर्ट में ले जाए तो आप नहीं कवर कर सकते अपने आप को कि आपको डायबिटिक रेटिनोपैथी थी और आपने ट्राइफोकल डाल दिया.
इसमें सर इसके अलावा देयर इज लिटिल क्लैरिटी इज नीडेड. एक तो ये है कि जो ट्राइफोकल के रिंग्स हैं, they don't hamper laser treatment. We have done multiple times. There is no problem. That is not the issue. Second, हम trifocal या premium IOL क्यों कह रहे हैं, OCT क्यों करवा रहे हैं, जैसे जनरल साहब ने स्ट्रेस किया कि ERM होगी या कोई डिजेनरेटिव चेंजेस होंगी या मैकुला की थिकनेस एक्सेसिवली कम हो चुकी है, क्यों हम कह रहे हैं कि जी उसको ट्राइफोकल ना डालें, हालांकि उसका बाकी चीज़ें तो नॉर्मल हैं. उसकी रीज़न ये है कि मैकुलर फंक्शन आइडियल होना ट्राइफोकल की एक्सेप्टेबिलिटी के लिए ज़रूरी है. जितने भी ये मल्टीफोकल्स हैं ये लाइट डिस्ट्रीब्यूशन करते हैं, कोई 50% देता है, कोई 25 देता है, कोई 30 देता है, कोई फार विजन को 40 देता है, नियर और इंटरमीडिएट को 30 देता है. तकरीबन सभी जो हैं दे डिस्ट्रीब्यूट लाइट. तो जब लाइट डिस्ट्रीब्यूशन होती है और जब मैकुला का फंक्शन कॉम्प्रोमाइज्ड होता है तो नियर विजन में पेशेंट को प्रॉब्लम होता है, क्योंकि वहाँ उसको ज़्यादा स्ट्रेसफुल फुल कैपेसिटी मैकुला चाहिए होता है. तो दिस इज़ वेयर द रिकमेंडेशन कम्स. इफ़ द मैकुलर फंक्शन इज़ कॉम्प्रोमाइज्ड, वी डोंट रिकमेंड multifocal IOLs or premium IOLs. The reason behind is this. So, it's not the laser treatment or anti-VEGF treatment. We expect that over time the macular function is going to compromise. So when the macular function will compromise, the patient will have much trouble, because having a trifocal lens in your eye, it always gives you 3 images. It always gives the patient an option to choose one of the 3 images and suppress 2 others. This is what the light distribution means. So this is the reason, not the treatment only. Otherwise, your point is valid, that if your patient is keen and you are ready to go ahead with that, you may, but the recommendation is like that, which we agree.
Right, sir. So, early diabetic retinopathy may reduce contrast sensitivity. Patient can have subtle macular changes even before clinically visible DME. Progresses unpredictably with poor glycemic control, and patient dissatisfaction due to glare, halos, reduced quality of vision. So any active retinal pathology should be considered as a contraindication for, especially for trifocal implantation. And as rightly said by Professor Ziaul Mazri, जो जितने भी trifocals हैं, especially जो diffractive हैं, they split light. But when they split light, they also causes, along with that, reduction in contrast sensitivity. So already अगर compromised retina है, further आप reduce करें contrast sensitivity, so that is further aggravating the situation. Sir, आप कुछ
हमें तो ये भी ख्याल रखना होता है ना, अगर हमने कोई गलत जवाब दिया तो हेड मिस्ट्रेस ने आगे जवाब भी तैयार किया हुआ है हमें डांट पड़ जानी है.
सर वो मैंने सोचा कि ज़रा इंटरेक्शन अच्छी हो जाती है आंसर देख के सारों में. So do you think corneal tomography should be performed in all patients? Is there any role of, मैं rephrase भी कर लेती हूँ, is there any role of your total corneal refractive power for the corneal astigmatism and patients, comparing it with AR or with biometry readings, or corneal tomography for any ocular surface diseases? Is it necessary to perform it in all patients of premium IOLs?
मैं तो सारे कराता हूँ, मतलब and I think so we have been able to see that corneal tomography में हमें काफ़ी चीज़ें पता चल जाती हैं उसमें, इवन टोटल कॉर्नियल एस्टिग्मेटिज्म का साथ posterior elevations के all of these things, any subtle changes of keratoconus, ये सारी चीज़ें जो है ना ये सारे बताई जाती हैं, और टोमोग्राफी में बाकी चीज़ें जो अभी ये सारी बता चुकी हैं. तो आई थिंक सो इट इज़ वेरी इंपॉर्टेंट टू HOS, मतलब क्या कुछ नहीं हो सकता. तो ये सारी चीज़ें मतलब जैसे है ना कि आपने स्मूथ आँख में ये लेंस डालना है, उस स्मूथनेस के लिए आपको जो जो चीज़ रिक्वायर्ड है वो करें, तो मैं तो ज़रूर करूँगा.
मेरे पास तो 3 इंस्ट्रूमेंट हैं, एक OCT है और एक टोपोग्राफर है और एक बायोमीटर है, तो मैं तीनों यूज़ करता हूँ. और बाकी टोमोग्राफी मेरा ख्याल है कि आपके पास है. जब OCT नहीं था तो जो एरर्स का रिस्क था वो ज़्यादा था. बड़े हैरानकुन चीज़ें कई दफ़ा मिलती हैं, चूँकि हमने रूटीन बनाई हुई है कि हम OCT बायोमेट्री हर केस में करते हैं, और जिसमें कोई बहुत हाई एंड प्रीमियम एक्सपेक्टेशंस हों उसमें टोपोग्राफी भी करते हैं. और दूसरा ये कि जो आपके बायोमेट्री के फार्मूलाज हैं मॉडर्न, द मोर इंफॉर्मेशन यू फीड देम द बेटर एंड एक्यूरेट रिजल्ट दे विल गिव यू. सो इंफॉर्मेशन कैसे लेंगे आप? You need white to white, you need corneal thickness, you need the whole corneal landscape, you need the anterior chamber measurements, effective lens position calculate करनी है इन सारी चीज़ों से आपके बायोमीटर ने. So the more fields you fill, the more accurate you become with the lesser chances of the biometric surprise will be there.
सर मेरा एक क्वेश्चन है, हम जब ऑप्टिकल बायोमेट्री करते हैं उसमें इंफॉर्मेशन पूरी आ जाती है, देखा एस्टिग्मेटिज्म और सारी सच, तो टोपोग्राफी फिर आप जो है ना इतना फेवर करें टोपोग्राफी, तो टोपोग्राफी यू नो
अभी आपको इसका जवाब मिल जाता है. बोलो सर.
मैं इसका जवाब देती हूँ सर. सर जितने ऑप्टिकल बायोमीटर्स हैं दे आर नॉट, अब न्यू आ गए हैं जिसमें वो कह रहे हैं, लेकिन दे कांट रूल आउट फॉर्म फर्स्ट केटोकोनस for which you have to see the corneal tomography. So keratoconus ke patients may be, you have to be very careful while implanting a trifocal IOL. So agar posterior corneal elevations hain, to you can't rule out with just clinically or just with the IOL master or the new generation optical biometers. Then another important thing which we want to see on with tomographers is the true corneal astigmatism, which is either seen with total corneal refractive powers, or you have to calculate it with anterior and posterior corneal astigmatism. Either add if the same axis or subtract, either subtract if the same axis and add if they are opposite axes. So to be more accurate while calculating your, to counteract your corneal astigmatism, you need to know the exact corneal astigmatism of the cornea of the patient. So for that, we need to know our topography. We do it in our practice. So ये discuss करने का मकसद ही यही है कि हम जैसे LASIK में refractive surgery में I always emphasize कि क्यों requirement है pre-operative assessment की, तो ये present करने का मकसद यही है कि हम emphasize करें. I know not all doctors are following this practice, but just to improve the knowledge and why every step is important for different patients.
बल्क में जब हम काम करते हैं तो जनरली तो जो एक बायोमीटर अल्ट्रासोने का है तो कर ही रहे हैं, लेकिन ये आइडियल सर्कमस्टांसेस होती हैं. बहुत अरसा तक द पीपल यूज टू डू रिफ्रैक्टिव सर्जरी विदाउट टोपोग्राफी एंड अ लॉट ऑफ ectasia problems were there, and now we ditched our scan, which was doing wonders, but it was not taking into account the posterior corneal surface. And once the topographers like Pentacam and Galilei came into the picture, which take into account the anterior and posterior corneal curvatures and the surface evaluation, the risk of ectasia decreased. And we need to remember that the cataract surgery has become a refractive surgery. So we need almost all the parameters which we apply in refractive surgery, we need to apply in cataract surgery to meet the patient's expectations. The second is a question from Dr. Sadia, that if there is a difference between the true corneal astigmatism, how do you incorporate in the biometer this finding? Do you find something on tomogram, and then how do you incorporate with the biometry?
Sir, you have to, so there are different formulas which I'll come in the after another few slides. I'll discuss about that. लेकिन हमने करने का मकसद यही है कि हमने true corneal astigmatism देखना है. We have to treat the corneal astigmatism. We are not treating the manifest astigmatism जो patient दिखा रहा है. So we have to treat the corneal astigmatism. अगर patient का इसके ऊपर for example 2.5 आ रहा है, लेकिन posterior corneal astigmatism मिला के वो 3.3 हो गया है और हम उसको treat कम कर रहे हैं, तो there will be residual astigmatism. और अगर हमने उसको गलत कैलकुलेट किया और हम उसको अंडर करेक्ट कर रहे हैं या ओवर करेक्ट कर रहे हैं, तो देयर विल बी रेजिडुअल एस्टिग्मेटिज्म एंड यू आर पुटिंग ऑन ट्राइफोकल IOL एंड योर ट्राइफोकल टोरिक IOL एंड योर एस्टिग्मेटिज्म इज नॉट करेक्टेड. इवन 0.5 का रेजिडुअल भी जो है वो पेशेंट कांट टॉलरेट. जो इतना पैसा लगा रहे हैं तो वो चाहते हैं कि वी हैव टू हैव
एज अ मैटर ऑफ प्रिंसिपल वी एग्री टू इट, बट आई एम जस्ट आस्किंग दैट the IOL master or the whatever biometer
coming to that, so
will take a K reading. We will modify it.
No sir, we have to compare both. अगर difference आ रहा है इसका मतलब है there is something wrong. It has to be accurate. अगर उसमें आ रहा है difference, then we have to use the other formulas which I'll discuss. अभी मैं आ रही हूँ उसके ऊपर कि हमने उसको कैसे incorporate करना है, वो मैं आगे slide दिखाऊंगी तो आपको समझ आएगी. जी
मैम, आपकी प्रैक्टिस में आपने जो देखा है कि फ़र्क ज़्यादा आता है टोमोग्राफी की एस्टिग्मेटिज्म में और बायोमेट्री की में?
We can't use the normal biometers, normal formulas for IOL calculation. अभी मैं आती हूँ उस पर, मैं अभी दिखाती हूँ आपको. आगे जाके मैं अभी बताती हूँ which formulas you have to use for what kind of eyes, वो भी मैं आपको दिखाती हूँ. OCT scan पे बात हो गई थी. Do you recommend OCT scan should be performed in all patients? Yes, it is very important step because it is mandatory. We can clinically miss the subtle epiretinal membranes on the slit lamp. BMT can be missed, and all of these causes decreased contrast sensitivity as already discussed. Before we move on, sir, specular microscopy. Is it mandatory? Can we skip it? हर एक के पास नहीं है. करना चाहिए, नहीं करना चाहिए, किस में करना चाहिए?
नॉर्मली मैं तो ये मुझे कहती होना चाहिए, लेकिन मैं कहता हूँ नहीं होना चाहिए. लेकिन ओवरऑल अभी जो मतलब एक शुरू हुआ है कि स्पेकुलर माइक्रोस्कोपी करें, लेकिन आई थिंक सो इट्स मोर इम्पोर्टेंट टू सी द एंडोथीलियम. अगर आप स्लिट लैम्प में देखें, कोई कॉर्नियल गटेटा वगैरह है, कोई आपको ऐसा फुक्स के साइन नज़र आते हैं, कोई कॉर्नियल थिकनेस ज़रा आपको लगती है कि ज़्यादा है या कुछ, तो इसी किस्म के फाइंडिंग्स हो तो यू शुड अवॉइड यूजिंग एनी काइंड ऑफ लेंस. लेकिन अगर आप कहें कि आपके आर्मामेंट में स्पेकुलर माइक्रोस्कोप होना चाहिए, मतलब until if there's a history of this thing, it was not been part of it. मतलब ज़्यादातर जो कंसेंसस है उस पर नहीं है, लेकिन ये एक ग्रुप है जो यहाँ राइट साइड पे बैठा है, वो कहता है ये भी होना
मैं आपसे एग्री करती हूँ, मैं दिखा रही हूँ.
अच्छा, एग्री टू डिसएग्री.
एग्री टू डिसएग्री.
लेकिन आपको मकसद कहना है कि स्पेकुलर माइक्रोस्कोप यस अगर आए, मैं उसमें कॉर्नियल गटेटा देखूं, उसमें मैं देखूं कि कॉर्नियल एंडोथेलियम इज नॉट हेल्दी. अच्छा,
एग्जैक्टली यही कहा है सर.
तो फिर आपको स्पेकुलर करना चाहिए. मेरा ये आंसर था. मैंने कहा पता नहीं क्या है कि ये लाजमी लो.
असल में मैं डर लगता है कि पता नहीं मैडम ने जवाब क्या दिखाना है.
नहीं सर, बिल्कुल.
So we are very careful. हेडमिस्ट्रेस बहुत सख्त है. चेस में जो एक टेस्ट में अपने रेजिडेंट्स को कहता हूँ और अक्सर वो जवाब नहीं देते, दैट्स स्पेकुलर रिफ्लेक्शन टेस्ट. वो वाइवा का क्वेश्चन भी है, और स्पेकुलर रिफ्लेक्शन टेस्ट ही असल में स्पेकुलर माइक्रोस्कोपी की बुनियाद है. मैंने आपको वो तारक सईद साहब का भी बताया था, नो गटाटा. So that was the time when he explained to us this specular reflection test. The principle of the specular reflection test is that visual axis of the patient should bisect the viewing angle of the microscope and the illumination beam. When the illumination beam and the viewing angle of the microscope are bisected by the visual axis of the patient, what will happen? The angle of incidence will become equal to the angle of reflection. So the brightest and high magnification image the microscope will receive. And you use about 1 millimeter thick slit lamp beam and examine, focus on the endothelium and descemes membrane. If it is smooth and the corneal thickness appears normal, the endothelial cell count should be more than maybe 1500 or 1000 at least. So then we don't go for this specular microscopy test. But the specular reflection test, every resident and every person should be well versed with, and it should be done routinely in all cataract patients, not only in premium IOLs. And if it is available like AFIO and like premium setups, Dr. Sadia Humayun enjoys, तो करने में क्या हर्ज है? पेशेंट की जेब में पैसे भी हैं और हमने भी इंस्ट्रूमेंट पे पैसे लगाए हुए हैं, तो किस पे यूज़ करना है? फिर करें. नहीं, मैंने कह रहा हूँ अगर अपने सेटअप में है तो फिर तो आप इंडिकेशन बढ़ाते जाएंगे ना.
सर, आई एम टॉकिंग अबाउट ऑल द गाइडलाइंस. मैं अपनी तरफ से खुद कुछ भी नहीं कह रही. सो कैटरेक्ट एंड रिफ्रैक्टिव सब स्पेशलिटी किसी वजह से आई और उसमें ये सारी गाइडलाइंस हैं जो विच all the ophthalmologists all over the world are following these guidelines. तो मेरा कोई बिल्कुल लड़ाई मैंने नहीं करनी. मैं सिर्फ आई एम जस्ट ट्राइंग टू एम्फेसाइज ऑन फ्यू थिंग्स. नहीं सर, मैं आई एम जस्ट प्लेइंग सेफ. सर नहीं, बिल्कुल सर. वो टोमोग्राफी की बात आ गई दोबारा. एक तो गटेटा डेफिनेटली इफ़ यू सी ऑन स्लिट लैम्प, देन स्पेकुलर माइक्रोस्कोपीज ठीक है. फिर कॉर्नियल टोमोग्राफी इज़ अनदर वे ऑफ रूलिंग आउट. इफ़ यू सी बेलिन एम्ब्रोसिया एनहांस्ड एक्टेसिया डिस्प्ले, उसमें अगर आपको फ्लैट नज़र आती है कॉर्नियल थिकनेस स्पेशल प्रोफाइल, सो दैट इज़ अनदर साइन ऑफ फुक्स डिस्ट्रॉफी. सो यू कैन रूल आउट. कॉर्निया थिक होते हैं, के रीडिंग्स आर फाइन, एवरीथिंग इज़ परफेक्ट. जी के रीडिंग्स फाइन है, थिकनेस ठीक है, लेकिन जब आप उस पर देखते हैं तो आपको उसमें भी नज़र आ जाता है कि पेशेंट हैज़ फुक्स.
वैसे जो इंटीरियर सेगमेंट ओसीटी है उस पर रिसेंटली एक पेशेंट के कॉर्निया की थिकनेस मुझे ज़्यादा लग रही थी, तो मैंने कहा कि इसका एंटीरियर सेगमेंट ओसीटी करते हैं। तो उसमें जो कॉर्निया का वो लेता है सेक्शन, उसमें वो बड़े क्लासिकल एक्सक्रीसेंसेस नज़र आ रहे थे एंडोथेलियम पे। तो इसलिए हम इनडायरेक्ट एविडेंस एंटीरियर सेगमेंट ओसीटी से भी ले सकते हैं। सो वी आर नॉट एक्चुअली डिसएग्रीइंग, बट वी आर जस्ट सेइंग दैट if the availability and affordability is there, then these tests are really recommended and are to be performed.
These are all mandatory steps just for the knowledge. बाकी सारी दुनिया में इसके बगैर अगर वो करें सू कर देते हैं कि आपने कर कैसे दिया। अच्छा सर, एंगल कैपा की बात करें, इसको तो कोई लिफ्ट ही नहीं कराता सर एंगल कैपा को। इज़ देयर एनी रोल ऑफ एंगल कैपा, हाउ टू कैलकुलेट इट, पेशेंट का देखना चाहिए नहीं देखना चाहिए? मैं खुद
definite role on this thing, and I think so she will explain it to you in a better way.
So the angle between the pupillary axis and the visual axis, ये दो जो हैं, the angle between them is the angle kappa, and angle between the optical axis and the visual axis is the angle alpha. उसका इतना रोल नहीं है, लेकिन इसका रोल है. So when you measure the length between them, it is known as chord mu. So chord mu हम calculate कर सकते हैं, and it's not very difficult. Again topography का रोल आ जाता है इधर, जिसमें हमने calculate करना है. क्यों important है? क्योंकि if the angle kappa is large, so it will result in more dysphotopsias. ये जो जितने हमारे patients हैं, hyperopes हैं या some few myopes, exotropes especially, तो उनमें angle kappa ज़्यादा होता है, and those are the patients who are the most dissatisfied patients after the surgery, क्योंकि angle kappa ज़्यादा है और उनको उतना ही dysphotopsias, halo, glare, spherical aberration, सारी चीज़ें उनकी उसकी वजह से उनको नज़र आती हैं. So it has a role. So on pentacam, on holiday report, you can see this chord mu value. So normal value is 0.2 to plus minus 0.11. So if it is more than that, then such patients are not good candidates. Chord mu अगर आपके पास holiday report नहीं है, you can calculate with tomography with x and y. ये जो x and y है, so square of x plus square of y under root, you can calculate with your calculator, which I normally do, क्योंकि हमारे पास भी chord mu नहीं है, तो मैं इसको manually calculate करती हूँ. तो it's available on Cirrus के ऊपर, it's available. Pentacam के ऊपर you can manually calculate. Galilei पे you can calculate with x and y axis. वो उसके ऊपर दिए होते हैं, तो you can calculate it manually. Sir,
जारी रखो.
एब्रोमेट्री का कोई रोल है प्रीमियम IOLs में?
होगा तो आपने सवाल रखा है. करें आप, बताएं आप.
Sir, higher order abrasions, coma, trefoil, spherical aberration, root mean square तो उसका total है. Coma, trefoil, spherical aberration, they all cause dysphotopsias. So जितने ज़्यादा higher order abrasion ज़्यादा होंगे, वो it will ultimately result in starburst, trefoil starburst करते हैं, spherical aberration halos करते हैं, glare जो है वो trefoil भी करते हैं, coma भी करता है. ये सारी चीज़ें जो है ना, ये आपको दिखाएंगे. जो patients कहते हैं जी हमें light ऐसी फैली हुई नज़र आ रही है, it's all because of these higher order abrasion. So cut off value for higher order abrasion, आपने सिर्फ root mean square देखना है, आपने कोई higher order abrasion नहीं पढ़ने. Root mean square value normal is less than 0.35, abnormal is more than 5. So
बता भी देना कि सारे इसमें आपके पेंटागन में भी आ जाता है, उसमें भी आता है, गलीली में भी आ जाता है और सिरस में भी आ जाता है.
सिरस में भी, तीनों में जो है ये आपके पास रिपोर्ट आ जाती है. You just have to look at the root mean square value, and this step is very important in planning premium IOL. If the value is between 0.3 and 0.5, less than 0.3, you can implant any kind of premium IOL. उसमें आप EDOF डालें, आप उसमें trifocals डालें, उसमें आप enhanced monofocals डालें, कुछ भी डाल सकते हैं. If it is between 0.3 and 0.5, फिर आप trifocals नहीं डाल सकते. फिर आपने सारी सिर्फ EDOF डालना है या enhanced monofocal डालने हैं. और if it is more than 0.5, तो फिर आप खाली monofocals या enhanced monofocal डालेंगे. So this is very important step, like angle kappa and like other test, कि जिसमें आपने प्लान करना है कि आपने ट्राइफोकल डालना है कि नहीं डालना. So एक IOL मास्टर की रिपोर्ट के ऊपर you can't plan कि आप ट्राइफोकल डालेंगे तो patient satisfaction कैसी होगी afterwards. So these are the few steps which I wanted
और
to
इसमें देखें
emphasize.
ये इम्पॉर्टेंट कितना है कि हम इक्विपमेंट ले भी लेते हैं और टेस्ट करवा भी लेते हैं, बट वी नीड टू स्पेंड सम टाइम टू evaluate एंड टू रीड द रिपोर्ट्स एज वेल, कि उसमें इंफॉर्मेशन इतनी ज़्यादा होती है, ख़ासतौर पर कॉर्नियल एवेलुएशन का जो प्रिंट आउट होता है, इट्स फुल ऑफ न्यूमेरिकल वैल्यूज़, तो हमें उसके भी सीखना है और उसके लिए भी थोड़ी सी पेन लेनी चाहिए कि कम से कम जो अवेलेबल टूल्स हैं उनका जो प्रिंट आउट्स हैं उनको तो हम प्रॉपरली इंटरप्रेट कर सकें.
सर अभी एक कॉमन इंटरेस्ट क्वेश्चन, what is the right age for premium IOLs? A young patient comes to you, 25 years old, who is high myope with -15 diopters and he wants to get rid of his glasses. और ये भी हमने बहुत देखा. सर जाना नहीं है, प्लीज़ 2 मिनट रुक जाए. सर ये क्वेश्चन के बाद.
हाँ सर, मुझे सेंट्रल काउंसिल वालों ने फ़ोन करना शुरू कर दिया ब्लाइंड लेंस. इसका मैं मतलब एक चीज़ आती है रिफ्रैक्टिव लेंस एक्सचेंज, मतलब दिस शुड बी वेरी मच क्लियर कि हम ये काम इज़ अ नो कि आप किसी को प्रीमियम IOL एट द एज ऑफ 25, एनी IOL रिफ्रैक्टिव लेंस एट द एज ऑफ लेस देन 45 ईयर्स और 50 ईयर्स विदाउट हैविंग अ PVD डेवलप नाउ यू है, जिसको इसमें 30% चांसेस है कि रेटिनल अटैचमेंट ज़्यादा हो जाएंगे. तो ये एक तो जो स्टेटमेंट दिए मैंने, ये आपको याद रखें, दैट शुड बी पार्ट ऑफ इट. एनीबडी हु इज़ हाई मायोपिक और एक 25 साल का और अपना 15 डायप्टर का उसके साथ ग्लासेस लगा रहे हैं, ये इससे बड़ा जुल्म आप कोई नहीं कर सकते. हम एज अ विट्रोरेटिनल सर्जन्स द मोस्ट डिफिकल्ट सर्जरीज आर इन दिस काइंड ऑफ पर्सन जब इनको करते हैं, और दे ऑलवेज लीड टू ब्लाइंडनेस एंड जायंट रेटिनल ब्रेक्स एंड एवरीथिंग लाइक दैट. हमेशा फंसे. तो काइंडली refractive lens exchange should only be done, practiced at the age of plus 45 or whenever you look at the retina और retina ठीक है और PVD डेवलप होगी, उससे कम पे तो नहीं करना चाहिए. दिस इज देयर आर लॉट ऑफ पेपर्स ऑन दिस थिंग. मेरी इजाज़त दीजिएगा क्योंकि वो कर रहे हैं, बाकी सर आगे.
सर एक बता दें प्लीज़, अगर यही पेशेंट 25 का विद +15 होगा तो फिर करेंगे आप?
फिर भी मैं नहीं करूँगा. मैं कोशिश ये करूँगा कि रिफ्रैक्टिव लेंस एक्सचेंज को छेड़ूँ ना आँख को, कि जब तक इसकी उस डेवलपमेंट जहाँ पैथोलॉजी होती है, इवन दैन इट बिकम्स व्हाट आई विल डू इज बिकॉज वी हैव गॉट अभी वो आ गए हैं, क्या कहते हैं, फेक ICLs आ गए हैं. इतने नहीं हम बहुत कर रहे हैं. हम फेक ICL इतने ज़्यादा कर रहे हैं कि देयर इज नो लिमिट टू दैट. और इसको देखते हुए आई थिंक सो फेक ICL के ऊपर हमें करना चाहिए एंड वी गेट अ वेरी गुड रिजल्ट. सबसे बड़ी बात ये, और पेशेंट्स आर वेरी वेरी हैप्पी. तो इसको भी हम अगली बार मेरे ख्याल इस पर वर्कशॉप करनी चाहिए इसमें सारा करने के. सर ओवर टू यू सर, हमें इजाज़त दें, हम जरा वो जा रहे हैं सारी पार्टी उधर, आप लोग कैरी ऑन करें.
सर बस एक ही क्वेश्चन रह गया है, वो
एक क्वेश्चन करो फिर सर.
कोई नहीं, मैडम के पास जवाब है, हमें क्या टेंशन है. चलें इसका जवाब तो दें. कोई है रोल लेजर वगैरह का?
So refractive lens exchange in a younger age group, in a patient at 25 years of age, it definitely will cause loss of natural accommodation. There will be increased chances of retinal detachment, as sir already mentioned. There are 30% increased chance of retinal detachment in such patients. So RLE is contraindicated now in patients under the age of 45 years. And phakic ICL is considered as a gold standard for patients under 45 years of age.
कोई 40 की भी है गुंजाइश? थोड़ी
Sir,
सी है.
or if the patient has developed PVD, till the patient has developed PVD.
अगर PVD हो गई है तो फिर 40 years पे भी कर सकते हैं.
फिर आप कर सकते हैं, लेकिन अगर PVD नहीं हुई तो it's better to wait after 45 years of age, क्योंकि उससे पहले जो अगर आप करेंगे तो it will result in retinal detachment.
हाँ, और आप जितनी भी लेज़र लगा लें, एनसर्कलमेंट कर लें, the chances of retinal detachment in young patients remain high. और ख़ास तौर पर अगर आपने PRE की हुई है हैवी और फिर आपने उसका किया क्लियर लेंस एक्सचेंज, खुदा न खास्ता उसमें अगर डिटैचमेंट हो गई तो वो लेज़र मुसीबत बन जाती है. वो इतना PVR वहाँ पे होता है कि उस रेटिना को फ्लैट करना और उसको अटैच करना बहुत बड़ी हेडेक बन जाता है. तो इसलिए इसमें जो मैडम ने हमें क्वेश्चन किया है, वी शुड फॉलो दिस रिकमेंडेशन.
So there are a number of papers which have been published, and they started publishing from 2010 onwards, and Recently, as you can see, there is a systemic review and meta-analysis which was published in British Journal of Ophthalmology in 25, in which they have jitne bhi unke koi thousands of patients which they have reviewed, and they have finally come to the, again they have come to the conclusion, they have started giving these conclusions since 2010 and 2014. ये दो तीन मैंने यहाँ पे लिखे हैं references. हर दफ़ा मेरी इस चीज़ के ऊपर बहस होती है कि प्लीज़ डोंट डू इट, और अब तो ये लोग भी कह रहे हैं कि, और इन्हीं लोगों ने बल्कि कहना शुरू किया. अभी मैं एक मीटिंग मैंने कुछ अर्सा पहले अटेंड की, और वहाँ पे I talked about the workup of refractive as well as cataract and refractive, and then one of the eye specialist, another eye specialist, उन्होंने कहा जी आप लोगों की तो लिमिटेशन है कैटरेक्ट इसमें रिफ्रैक्टिव में कि आप लोग जो है इसको यंग एज में करेंगे और ओल्डर में नहीं करेंगे, लेकिन रिफ्रैक्टिव लेंस एक्सचेंज की ब्यूटी ये है कि इट कैन बी डन एट एनी एज. और मेरा सांस रुक गया एज यूजुअल. फिर मैंने कहा सर इट कांट बी डन एट एनी एज, यू कांट डू इट इन यंगर एज ग्रुप. लेकिन वहाँ पे अच्छी खासी बहस हो गई, मेरी बात कुछ आई गई हो गई, लेकिन इसीलिए ये क्वेश्चन मैंने रखा कि ये दिस इज़ वेरी इंपॉर्टेंट. यू कांट डू रिफ्रैक्टिव लेंस एक्सचेंज. दिस इज़ अ वेरी कॉमन प्रैक्टिस इन पाकिस्तान, रिफ्रैक्टिव लेंस एक्सचेंज इन यंगर एज ग्रुप, अगर स्पेशली अगर रिफ्रैक्टिव सर्जरी नहीं हो रही. अभी तो रिफ्रैक्टिव सर्जरी भी -11 का पेशेंट, -11 डायबिटीज़, यंग बच्चा 18 ईयर्स का, जिसको आई रिफ्यूज़ड फेमटोलेसिक PRK, और मैंने कहा जी नहीं हो सकता इस एज में तो बिल्कुल भी नहीं, आपका फेक ICL विल प्लान आफ्टर 21 ईयर्स, थोड़ा सा वेट करें. ही वॉज सो एडमेंट, ही वेंट टू फैसलाबाद. आफ्टर 1 week ही केम बैक टू मी एंड ही वॉज सो हैप्पी. आई एम 6'6", यू सेड इट कांट बी डन, और मेरा PRK हो गया. एंड व्हेन आई डिड हिज tomography, cornea was paper thin, it was just 320 microns. So he will ultimately land in ectasia. यही हाल रिफ्रैक्टिव लेंस एक्सचेंज का है, या ये कर देते हैं PRK एट सच हाई नंबर, और या फिर रिफ्रैक्टिव लेंस एक्सचेंज कर देते हैं. सो दिस इज़ द टेक होम मैसेज, डोंट डू इट, गो फॉर फेक ICL. इट्स सो ईजी, इट्स नॉट डिफ़िकल्ट एट ऑल. कैटरेक्ट सर्जरी से ये ज़्यादा आसान है. एक दफ़ा सिर्फ एक कुछ झिझक होती है, आप लोग करेंगे, पैरामीटर्स फॉलो करेंगे, मेजरमेंट्स ठीक करेंगे, तो इट्स नॉट ए बिग डील. फेक ICL इज़ वेरी ईजी अगर आप उसको फॉलो करें, गाइडलाइंस और सारी चीज़ें. तो इट्स ए मिरेकल. इतने खुश होते हैं पेशेंट्स पोस्ट ऑपरेटिवली, इतनी मोटी मोटी ग्लासेस उतर जाती हैं जो कि आप नहीं उतार सकते विद रिफ्रैक्टिव.
आपके एक्सपीरियंस में कोई कैटरेक्ट और ग्लाकोमा का इंसिडेंस कितना का है फेक IOL में, कि नहीं हुआ?
सर ग्लूकोमा, IOP, ट्रांजिएंट राइस, स्पेशली शुरू के दिनों में जब
दैट डजंट मैटर,
OVD पीछे रह गया, जिसमें मेटिकुलस वॉश
कैटरेक्ट सर्जरी में भी हो जाता है ना.
जी सर. और
बाद में जो होता है,
बाद में सर किसी 1-2-3 पेशेंट्स में IOP परसिस्टेंटली रेज्ड रहा, जिसको हमने एंटी ग्लूकोमा दी, और उसकी साइजिंग में प्रॉब्लम थी. 2 में सेटल हो गया. एक पेशेंट था जिसमें प्यूपिल डायलेट हो गया एंड वी हैड टू टेक इट आउट. आई एम टॉकिंग अबाउट हमने हंड्रेड्स ऑफ फेक ICLs कर लिए हैं.
आप कोई पेपर भी कर रहे होंगे इस पे?
जी सर,
कंपाइल.
जी सर.
और इट्स वेरी इंटरेस्टिंग एंड वेरी प्रोसीजर इज नॉट दैट डिफिकल्ट एंड इज मच सेफर एज कंपेयर टू clear lens exchange.
Definitely,
and you had another question about hyperopia. What do you say about that? तेरे हर सवाल का सवाल ही जवाब हो.
सर हाइपरोपिया में मैंने बहुत सर्च किया, नेट पे मैंने सर्च किया. वी हैव नॉट डन रिफ्रैक्टिव लेंस एक्सचेंज इन यंगर, इतने 2021 वाले यंगर एज ग्रुप में नहीं, 30s वालों में हमने डेफिनेटली किया.
उसमें आप कर सकते हैं, उसमें इस तरह कंट्राइंडिकेटेड नहीं है जिस तरह मायोप में है.
बिल्कुल सर. तो वो जो लिटरेचर कहता है, अब 35 पे तो मैंने भी किया. शी वॉज आई थिंक 34 और 35. आई डिड रिफ्रैक्टिव सर्जरी. उसका लेंस भी इतना बड़ा था, प्लस 35, एंड शी इज़ द हैप्पीएस्ट पर्सन आई मस्ट से, कि वो जो है शी इज़ सो हैप्पी एंड शी वॉज कि बस कर दें आप, और ट्राईफोकल मैंने डाला एंड शी इज़ वेरी हैप्पीएस्ट पर्सन आई शुड से, कि वो इतनी खुश है.
बल्कि
लेकिन
जी प्लीज,
सॉरी सर,
प्लीज
यंगर एज ग्रुप में अगर मैं मुझसे कहें कि 2021 आई विल बी अ बिट आई थिंक स्पेक्टिकल अबाउट इट, केयरफुल, क्योंकि बहुत ही यंग एज है. आई थिंक थोड़ा सा टाइम देना चाहिए. लेकिन जो मैंने लिटरेचर रिव्यू किया, इसके लिए भी मैं कर रही थी, उसके लिए भी कर रही थी, तो जो ओवरऑल गाइडलाइंस हैं, जो ओवरऑल पेपर्स मैंने जितने पढ़े, तो वो कहते हैं यू कैन डू इट. अभी सर नहीं है, अभी सर से भी मैं बात करूं, लेकिन वो कहते हैं हाइपरोप में हाँ कोरॉइडल फ्यूजन के चांसेस हैं, मेलिग्नेंट ग्लूकोमा के चांसेस हैं. आपने पोस्ट ऑपरेटिवली हमें इस चीज़ का ज़रूर एडवांटेज हो जाता है कि जब आपने लेंस निकाल दिया तो उसका एसी डेप्थ बेहतर हो जाती है। एसी डेप्थ बेहतर होने की वजह से एंगल क्लोजर वाला एलिमेंट कम हो जाता है इन सच हाई नंबर। दैट आर द एडवांटेजेस विच डेफिनेटली वी हैव। लेकिन 18 to 25 ईयर्स के एज ग्रुप में आई विल स्टिल बी वेरी रिलक्टेंट। आई थिंक मैं खुद थोड़ा वेट करूंगी टिल द टाइम पेशेंट इज इन लेट 20s और 30s मिड 30s।
20 तो वैसे जैसे रिफ्रैक्टिव सर्जरी के लिए एक आप वेट करते हैं कि स्टेबल हो जाए आई की ग्रोथ, तो 20 ईयर्स कट ऑफ लिमिट आप रखेंगे। लेकिन जो दूसरी डॉक्टर साहब ने पॉइंट आउट की हैं चीज़ें, मेरा कल एक टॉक थी फेको इन आइज विद शॉर्ट एक्सियल लेंथ, तो ये एक प्लस पॉइंट भी है कि अगर आप हाइपरोपिक आई में, रिसेंटली आई एम गोइंग थ्रू द ग्लाकोमा फेलोशिप जिसकी मैंने आपको पोइम भी सुनाई है, तो उसमें एक टॉपिक हमारा ये भी है जिस पे काफ़ी ब्रेनस्टॉर्मिंग होती है, फेको इन शॉर्ट एक्सियल लेंथ आइज इन अडल्ट शॉर्ट आइज। अब वो शॉर्ट एक्सियल लेंथ वाली आई किसको कहते हैं? जो 20 मिलीमीटर से कम हो। अब उसमें इतना हाइपरोपिया होगा, लेंस थिकनेस ज़्यादा होगी, और फिर हम उसमें डिस्कस करते हैं माइक्रोएप्थेल्मास एंड कॉम्प्लेक्स माइक्रोएप्थेल्मास एंड नैनोएप्थेल्मास। तो उसका जो इंटीरियर सेगमेंट है कई दफ़ा वो माइक्रोएप्थेल्मिक होता है कि वो इंटीरियर सेगमेंट माइक्रोएप्थेल्मास कहलाती है। तो उसमें तो ये प्लस पॉइंट है कि उसका लेंस अगर आप केयरफुली रिमूव कर दें तो आप उसको फ्यूचर में नैरो एंगल ग्लाकोमा से और पिपिलरी ब्लॉक से आप सेफ भी कर सकते हैं। लेकिन जैसे वर्ड ऑफ कॉशन डॉक्टर सादिया ने दिया है कि इसमें डिफ़िकल्ट होता है और इट इज़ अ चैलेंजिंग टू ऑपरेट ऑन अ हाइपरोपिक स्मॉल आई because the corneal thickness is more, and while fashioning the tunnel you need to be careful. Too long a tunnel may cause a phaco burn and difficulty while maneuvering your phaco inside the eye. And similarly there is an increased risk of choroidal effusion, and one may use injection mannitol, and you need to explain more things to the patient. One may opt for even GA in such patients so that the things remain in control. So these are the kinds of, वो जैसे कहते हैं खौफ और उम्मीद के दरमियान ही रहती है ज़िंदगी इंसानों की, और सर्जन्स तो बेचारे इन दोनों खौफ और उम्मीद के दरमियान लटके रहते हैं कि हम पेशेंट को ऑफ़र भी कर रहे होते हैं और दिल में डर भी रहे होते हैं कि अगर खुदा न खास्ता चीज़ें अदर वे राउंड चली गई तो क्या होगा।
एक पेशेंट है जो +15 के साथ देख रहा है 6'9", 6'7.5", एंड यू आर प्लानिंग रिफ्रैक्टिव लेंस एक्सचेंज, और कुछ ना कुछ खुदा ना खास्ता गड़बड़ हो जाए तो वो विजन भी ख़राब हो। ये भी एक डर रहता है ना कि आप प्लान भी करें, आँख भी इतनी छोटी, एसी डेप्थ भी इतना कम, और सब कुछ माइक्रोऑप्थेल्मस है, स्पेशली इंटीरियर सेगमेंट इफ इट्स इंटीरियर चेंबर इज़ माइक्रोऑप्थेल्मिक, तो वो बहुत डिफ़िकल्ट है। तो यू हैव टू,
उस पेशेंट को आप ग्लाकोमा के लिए भी ज़रूर एवेलुएट कर लें, उसका ओसिटी भी देख लें, प्रेशर्स केयरफुली देख लें, गोनियोस्कोपी भी कर लें, और मतलब ओवरऑल उसको देख के करें। और फिर कंसेंसस हमारा यही हुआ कि वो सारी इंटरवेंशंस के लिए ना, जो आपने लेंस इंटरवेंशंस करनी है, 40 इज़ अ गुड एज कि उसमें आप बिला तकल्लुफ़ हाइपरोपिया वाले को भी ग्लासेस से निजात दिला सकते हैं, और केयरफुल एवेल्यूएशन के बाद 45 के बाद मायोपिया वाले को भी रिफ्रैक्टिव लेंस एक्सचेंज या अर्ली कैटरेक्ट सर्जरी हम कहते हैं, फिर उसको थोड़ी बहुत लेंस ओपेसिटी तो ढूंढ ही लेते हैं, तो अर्ली कैटरेक्ट सर्जरी कह के आप उसको बेनिफिट दे सकते हैं। तो कंसेंसस यही है और यही सेफ है।
बिल्कुल सर, डेफिनेटली। So sir, what is your take on premium IUL implantation in patients who have had refractive surgery in the past? So should we go for it? कर सकते हैं premium IULs, trifocals डाल सकते हैं?
We can, but you need to be very careful. जितने पॉसिबल टेस्ट आपने मेंशन किए हैं वो सारे इनमें तो लाजमन होंगे, चाहे उसके लिए मुझे पेशेंट इस्लामाबाद रेफ़र करना पड़े, आई विल डू दैट। उसमें मुझे हर चीज़ चाहिए, उसमें मुझे टोमोग्राफी भी चाहिए, टोपोग्राफी भी चाहिए, ओसीटी भी चाहिए, और फिर हम ऑनलाइन कैलकुलेटर्स यूज़ करेंगे और 2-3 बायोमीटर्स की रीडिंग्स लेंगे, एंड वी विल हैव half to 1 hour session our counselor will have with the patient, that in spite of taking all the precautions and doing this plethora of tests Still, we are not sure that we will be able to provide you an free life after premium IOL surgery. Because in spite of all the precautions and all the measurements and using online calculators, and ASCRS calculator is one of the best ones for this purpose. The better patient is who has all the information, pre-laser and post-laser, all the information we need to feed to the calculator, and then the refractive surprise, the biometric surprise chances decrease, but this patient will be a difficult patient. This is my experience.
Sir. So when we do refractive surgery in any patients, we have changed the corneal curvature. So the anterior and posterior corneal surface are not the same as before. So IOL power will be inaccurately calculated. Either there is an overestimation or there is an underestimation of the corneal power. Refractive surgery also reduces contrast sensitivity, and it also induces higher order abrasions. So as I already described, that we have to see the limit of higher order abrasions. So if the limit of higher order abrasions is already more than what we desire, and we are planning premium IOLs, especially the trifocal in such a patient, and we are increasing the halo glares in such patient. So you have to be very meticulous about the preoperative assessment in such patients. And then the patient who already had a good 15-20 years spectacle-free vision, and now he or she has developed cataract and again wants to have a spectacle-free vision for all the distances, definitely he or she has a very high expectations. So the consensus, what I have seen with the refractive surgeons all over the world who have given their consensus is that toric monofocal is the best, is a good choice for such patients. We can use EDOF with caution if higher order abrasions are normal. Try to avoid trifocal. अगर आपके वो सारे parameters ठीक हैं तो then you can implant. लेकिन I have yet to see any patient with refractive surgery who has had normal higher order abrasions जिनके सारी चीज़ें ठीक हैं. Root mean square तो ज़्यादा होता ही है अगर spherical abrasion बाकी चीज़ें within normal limit भी हो तो. So you have to be very careful about such patients.
जो इसमें थोड़ा सा एक्सपीरियंस है जो उन्होंने कहा है डोफ का ना, तो इसी में जो सीफी का प्रोग्रेसिव डोफ है, दैट्स द ओनली लेंस. नाउ रिसेंटली सम अदर लेंस इज आल्सो लॉन्च्ड हु हैज नो रिंग्स. द प्रोग्रेसिव डोफ टेक्नोलॉजी इज a choice for these patients if at all we consider it.
So now coming to the question which everybody wants me to answer, which IOL formula should be used in biometry for premium IOLs? Can we rely on manual biometry if optical biometry is not available? I have seen patients who have had the manual biometry reading with them and they have been advised trifocal IOLs, premium IOLs of any kind. So should we rely on manual biometry in such patients?
I personally don't rely on manual biometry. Even if I need to refer the patient, I will refer and get the this optical biometry for premium IOL patient. And which formula you will tell, but the Barrett's formula is the kind of order of the day, and we need to purchase the biometer with built-in Barrett formula. And if you purchase a biometer who gives you good measurements and then you feed it to some online Barrett calculator, so there are chances of inaccuracies and errors where the manual entries and manipulation, then your assistants come into play. Sometimes they just put the flatter meridian in the steeper meridian and you end up with a surprise. So it's better to purchase a biometer with the latest capabilities, and I request Professor Sadia Humayun to highlight this further.
So sir, personally, I never rely on any one machine. I always compare. I do normally optical biometry. हम Galilei G6 भी करते हैं, उस पे भी मैं IOL calculation करती हूँ. and then I do it manually, especially for premium IOLs. Manual calculation भी मैं करती हूँ. There are multiple formulas which are available online. आप अपने मोबाइल पे कर सकते हैं. ASCRS है, ESCRS है, केन है, ईवो है, बहुत सारे formulas हैं which are available. अगर आप follow करें any of the 5th generation formula for standard version eyes. So if you have an axial length of more than 25, Kane, Evo, K6, these are all available online. आप ये formulas use करें. If axial hyperopia is less than 22, then again Kane, Evo, K6. These are very good formulas which can accurately measure your IOL, biometry, your IOL power. So post laser vision correction or keratoconus patients, if you find form first keratoconus, any changes, or if you are planning a case of cataract surgery in keratoconus eyes, you can use Barrett True K for KC using either measured PCA or predicted PCA or Kane KC. These are all formulas which are available online. हम उस वक्त बात कर रहे थे कि आपने कॉर्नियल स्टिग्मेटिज्म कैसे मेजर करना है. कॉर्नियल स्टिग्मेटिज्म, जिसकी मैं इंटीरियर पोस्टीरियर स्टिग्मेटिज्म की बात कर रही थी, ये जितने भी बैरेट ट्रू के फार्मूलाज हैं इसमें पूरी ऑप्शंस अवेलेबल है. मेजर्ड और प्रिडिक्टेड में डिफरेंस ही यही है. मेजर्ड में आप इंटीरियर एंड पोस्टीरियर के रीडिंग्स एंटर करते हैं, K1, K2 और स्टिग्मेटिज्म, और जो प्रिडिक्टेड है उसमें आप पोस्टीरियर के रीडिंग्स नहीं एंटर करते और सिलेंडर वो आपको प्रिडिक्टेड वैल्यूज़ देता है. सो जितने ये फार्मूलाज अवेलेबल हैं ये आपको बहुत एक्यूरेट मेजरमेंट देते हैं, जिसमें यू कैन मेजर सिलेंड्रिकल पावर, जिसमें यू कैन मेजर पोस्ट keratoconus सर्जरी पेशेंट्स, एंड एवरीथिंग इज़ अवेलेबल इन दीज. आप ये ऑनलाइन अगर जाएँ ESCRS या ASCRS में केन फार्मूलाज लिखें, आपके पास वो पूरी ड्रॉप डाउन मेन्यू आ जाएगा. तो वेन एवर आई हैव दैट IOL मास्टर और ऑप्टिकल बायोमेट्री रिपोर्ट, आई ऑलवेज कैलकुलेट मैनुअली. मैं टोपोग्राफी से इन फार्मूलाज पे एंटर करती हूँ अपने मोबाइल पे, एंड आई ऑलवेज काउंटर चेक. आई ऑलवेज काउंटर चेक विद गैलीली G6, उसने क्या कैलकुलेट किया. सो ये डिफरेंट फार्मूलाज डाल के ओनली देन आई प्रोसीड, क्योंकि एक्यूरेट बायोमेट्री इज़ अ वेरी इंपॉर्टेंट स्टेप इन ऑल दीज पेशेंट्स. एंड फॉर पोस्ट केराटोप्लास्टी SRKT इज़ द बेस्ट फार्मूला. ये फाइनल कंसेंसस है जो कि अभी तक मैंने देखी है. सो दीज आर वेरी गुड फार्मूलाज. आप ऑनलाइन जाएँ और आप इसको देखें. कहीं पे प्रॉब्लम हो तो आप मेरे से पूछ भी सकते हैं, आई विल गाइड यू. लेकिन अगर आप ये फॉलो करेंगे तो ये आपको बेस्ट रिजल्ट्स देंगे. आपकी मेजरमेंट्स बहुत अच्छी होंगी, क्योंकि नॉर्मली SRKT फार्मूलाज incorporated in most of the biometers. So if you have a patient of keratoconus, or you have a post laser surgery, or this difference in axial length, and if you do the SRKT formula, then your IOL power will not be accurate. So you have to follow this rule. आगे चलूं सर?
Amazing hard work you have done. Please move on.
सर, इसका आंसर मेरे पास नहीं है सर, लास्ट क्वेश्चन का.
अब मुझे ये पूछा था प्रोफेसर इम्तियाज़, सैयद इम्तियाज़ अली शाह जो रावलपिंडी वाले हैं, मुझे कहते हैं अगर आपने प्रीमियम IOL अपनी ही आंख में डलवाना हो तो मुझे दयानतदाराना जवाब देना कि कौन सा डलवाओगे. तो आई आंसर्ड हिम दैट आई विल गो फॉर सीफीज प्रोग्रेसिव विडोफ लेंस. इट हैज़ नो रिंग, इट हैज़ विडोफ विच gives it a range, and it has trifocality, which is blended like a progressive spectacle lens. So I think this is the best lens ever manufactured, though it's not very popular because it's an Italian product, and the giants of manufacturers are not Italians at this moment. So this is what I feel is the best lens in my practice. And for concerning patients, like I have implanted it, a professor of surgery is enjoying this. And another thing I say, that where there is ring, there is dysphotopsia. तो ये poet ophthalmologist डॉक्टर मजहरी का मुहावरा है. Where there is a ring, there is dysphotopsia. चाहे वो रिंग 1 हो, चाहे 2 हो, चाहे 10 हो.
सर आप ट्राइफोकल नहीं डालते फिर? डालता
हूँ, but there will be dysphotopsia. I tell the patient that night driving will be difficult. नाइट ड्राइविंग इसमें जो ये प्रोग्रेसिव विडोफ डिज़ाइन है, इसमें डिस्फोटॉप्सिया कम है, ज़ीरो इसमें भी नहीं है. सबसे कम डिस्फोटॉप्सिया जो मैंने देखा है वो ल्यूसिडिस एडोफ है, जो स्विस टेक्नोलॉजी है, और वो भी पेटेंट है। जितने बाकी सारे जो इवन विवेटी है, जो EMV है रेनर का, जितने भी हैं वो सब एडोफ टेक्नोलॉजी दे रहे हैं बिटवीन फार टू इंटरमीडिएट। जबकि जो ल्यूसिडिस स्विस एडवांस्ड VN का लेंस है, it gives you extended depth of focus between near and intermediate. And I asked this question to an engineer from CFI during Lahore conference. I asked him that why nobody else is coming up with an EDOF lens which gives you range between near and intermediate, because practically you need this range. Between far and intermediate is not a very practical range which you need. That's why in the VVT and EMV, all those lenses, the patients often complain that they have to move the object away. They have to increase the distance to read clearly. This is because the EDOF range is, the depth of focus is there between intermediate and far. Whereas in Lucidis EDOF IOL, the range is there between near and intermediate. And that Italian engineer replied to me that the whole Europe is trying to unfold the mystery, the trick these Swiss people have played with Lucidis IOL. We are yet not able to understand what trick they have done that they are able to give it. Literally they say that we have induced a spherical button. This is all optical gimmicks. What we understand is what practically our patients gives us feedback. This is what we understand. So these two lenses are the best in my practice. In monofocal EDOF, I grade Lucidis on top, and in trifocal progressive EDOF, I grade CFI, Minivel, Proxa, and Minivel both on top. And this is my answer, that for an eye surgeon, that lens is there which gives you minimum amount of dysphotopsia. But even then I am not sure, if I am planning for my own self, that okay, I will be good on road, I will be good on night driving. But my question is, how will this lens behave on microscope? As an eye surgeon, I have to yet understand that which lens will be ideal while sitting on microscope. The answer is probably monofocal. Toric तक हम जा सकते हैं अगर आप ये रिस्क नहीं लेना चाहते। तो मेरी तबीयत में चूँकि थोड़ी अडेप्टेबिलिटी ज़्यादा है, तो मैं तो पर्सनली ये ट्राइफोकल डलवा लूँगा, क्योंकि मैं उसके जो हेलोज और डिस्फटॉप्सियाँ हैं, आई कैन एडजस्ट माई सेल्फ। जैसे आप आहिस्ता आहिस्ता अपनी बेगम साहबा से कंप्रोमाइज़ करना सीख जाते हैं और बेगम साहबा आपसे कंप्रोमाइज़ करना सीख जाते हैं। तो न्यूरो अडेप्टेशन को मैंने कहा था कि स्पाउस अडेप्टेशन और न्यूरो अडेप्टेशन ये मिलते जुलते ही हैं दोनों, तो मैं तो कर लूँगा, लेकिन मुझे दूसरों के बारे में श्योर नहीं है।
ये बहुत ज़बरदस्त वैसे आपने बात कर दी। ये क्वेश्चन इसका आंसर मेरे पास खुद नहीं है। सो वाई आई आस्क दिस क्वेश्चन, क्योंकि मैं खुद भी सोच रही थी कि इफ़ आई वांट टू हैव एन अल्टीमेटली जब कभी ज़रूरत पड़ेगी तो मुझे क्या चाहिए, क्योंकि फॉर मोस्ट ऑफ अस वी जो कि हम ग्लासेस लगा रहे हैं, वी आर मायोप्स एंड वी हैव ए वेरी परफेक्ट नियर विजन, 10-0 भी नज़र आता है अभी तो हमें कौन सी चीज़ अच्छी नियर विजन देगी? फॉर मी नियर विजन इज़ वेरी इंपॉर्टेंट। सो इसका एक आंसर अगर कोई आप लोग एडअप करना चाहते हैं तो बताइए, हम वी आर ओपन फॉर डिस्कशन। दिस वाज द लास्ट क्वेश्चन।
ये जैसे हमने व्हेन वी स्टार्टेड रिफ्रैक्टिव सर्जरी, सो ये पेशेंट्स की तरफ से भी, और जब हम किसी भी फोरम पे, मैं 2-2.5 डेकेड्स पहले की बात कर रहा हूँ, किसी भी फोरम पे आप PRK की लेज़र करेक्शन की बात करते थे तो कोई ना कोई ऑडियंस में से खड़ा हो जाता था, आप अपनी आंख पे कराओगे? So then the time came, Dr. Ejaz Sheikh, a very famous British Pakistan Ophthalmologic Society activist, he is based in UK now. He was a courageous man. He got laser done with a primitive laser machine at Laser Vision Center, Lahore. And now we know many ophthalmologists have gone through the laser treatment. So probably the confidence comes over time when we keep on seeing our patients with positive feedback. So that gives you confidence to offer your own eyes. तो असल बात तो ये है ना कि हम तो कैटरैक्ट में भी करवाते हुए डरते हैं, 1% रिस्क तो है ना. तो ये तो पता नहीं होता कि वो 1 कौन सा होगा और किस्मत किस पे हंसेगी. तो अल्लाह पाक हिफाजत फरमाए. लेकिन दिस इज़ हाउ इट गोज़ कि आप probably over time we are developing confidence and the technology is refining. So we may opt, but I'm not sure what will be the decision when the real time to decide comes.
So when I went to US for my training, I went to Rochester with Professor Scott McCree, and he had got LASIK in one eye and PRK in other eye with monovision. वो and I was surprised क्योंकि normally नहीं कराते होते क्योंकि for near is very important for all of us. So उन्होंने एक में LASIK एक में PRK with monovision की हुई थी and he was without glasses. And फिर उन्होंने मुझे खुद कहा कि aren't you surprised that I'm not wearing glasses at this age? He must be in his, I'm talking of back in 2013 की बात कर रही हूँ मैं, 2013 था या 2013 था. तो फिर मैंने उनसे पूछा तो उन्होंने कहा कि हाँ मैंने कराए हुए and I am very happy about it. So अब for me ये this question is very important क्योंकि for me near vision is very important. So sometimes I do plan कि मैं क्योंकि अभी तक जो मैंने जितने ट्राईफोकल्स हम लोगों ने किए और जो रिजल्ट्स देखे तो जो बेस्ट रिजल्ट्स विद ट्राईफोकल तो एल्कॉन का पेनॉप्टिक्स. अब आई एम नॉट प्रमोटिंग दैट, लेकिन जो मैंने पेशेंट्स में देखा जो उनका जो फीडबैक था उसकी मैं बात कर रही हूँ जिसमें वो सबसे ज़्यादा खुश हैं. PCO रेट कम है, एवरीथिंग इज़ फाइन. सो समटाइम्स मेरी मदर को, मेरी फैमिली में मल्टीपल लोगों को आई हैव गॉट इट डन एंड दे आर वेरी हैप्पी. तो समटाइम्स आई डू थिंक अबाउट इट कि मैं करा लूँ. वही बात है सर की कि ये थोड़े टाइम के बाद पता चलेगा कि क्या चाहिए.
उसमें ना एक बात का यकीन रखें आप, नाइट ड्राइविंग विल बी डिफ़िकल्ट. I am very keen about this. I developed a questionnaire. Not a single patient with the IOLs with rings I have seen who doesn't have this problem.
Sir.
And they, over time, they may adjust. But night driving is a nightmare with IOLs with rings. And nevertheless, a wonderful discussion, and I appreciate the kind of hard work you have put into this simple panel discussion. Is always taken as a very light thing that you float a question and then wait for the answers. But you have done the real hard work behind this. The bottom line for this particular question, which I understand with whole discussion, is it's like refractive surgery. It will be an individual decision. It is not, we cannot decide for every eye surgeon. I will need to decide myself. You will need to decide yourself. And everybody will have different fears, different personalities, and some people accept challenge. Like you said, monovision, very odd thing. So this is how the humans are made. This is how they are diverse. And this is how the eye surgeons differ from each other. So the eye surgeons are free to decide for their own selves, but we have shared our own perspective.
So even for the eye surgeon, all of this workup which I have discussed, pre-operative workup, it is as important as for any other patient. So ये सब कुछ हमने करना है और देखना है. If the eye surgeon is fit, then we can decide and give him the choice, or he can decide for himself क्या करना चाहते हैं. अगर नहीं है तो फिर definitely we have to check all those things which I have already discussed. So thank you very much, sir, for such a great discussion, and thank you all the audience for sitting here and for giving us company for such a, I don't know, it's a boring discussion or it was something we could add. I think आपने कुछ अच्छा सीख लिया होगा हमसे भी और हमने भी आपसे कुछ सीख लिया. Thank you very much for your patience listening.
मैम कुछ questions हैं?
जी जी please.
एक तो very well presented case, आपने बहुत ही information दी. Are there any absolute contraindication for premium IOLs? वो एक तो थोड़ा सा elaborate कर लें. Second, आपने phakic इंट्राओकुलर लेंसेज का बताया, aren't they too expensive? कि एक पेशेंट हमारा PRK के लिए राज़ी नहीं होता और उसको हम ICL पे लाते हैं. थर्ड, आपने NTA सेगमेंट OCT का बहुत एम्फेसाइज नहीं किया, ऑल्दो आई थिंक कि जब आप मल्टीफोकल लेवल पुट करते हैं तो बाद में जब बैग में जाके वो सेटल होता है तो उसके बाद उससे बड़ा इंपॉर्टेंट हो जाता है कि जो आपने बायोमेट्री की थी वो पोस्ट ऑपरेटिव सरप्राइजेस देगी या नहीं देगी, और अगर वो देगी तो फिर मल्टीफोकल आईओ के साथ प्रॉब्लम ये है कि सारे ही डिस्टेंसेस के ऊपर वो पेशेंट की विजन को ख़राब कर देती है.
थर्ड क्वेश्चन मुझे नहीं समझ आई आपकी.
कि NTA सेगमेंट OCT,
posterior segment OCT.
NTA सेगमेंट मैं क्वेश्चन कर रहा हूँ ना कि आपने नहीं कहा उसका कोई रिकमेंडेशन है, बट उससे हमें NTA चैम्बर डेप्थ और जहाँ हमने IOL प्लांट करना है
टोपोग्राफी पे आ जाती है. वी आर कैलकुलेटिंग anterior chamber depth with topography. You have
so
either internal or
in your
external.
practice what will you do if there is post operative refractive surprise in those cases? तो 3
In
questions
premium
हैं.
IOLs,
जी जी.
post operative refractive surprise, if I say that we haven't seen it yet, alhamdulillah. मैंने बताया कि मैं एक रीडिंग पे रिलाई नहीं करती. I always compare. I do manual calculation, IOL TOMI or any optical device with Galilei G6, with all these formulas which I have said. I do manual calculation and then I go for the final IOL power calculation. And एक रीडिंग पे भी मैं रिलाई नहीं करती. I repeat, not on the first reading, ocular surface treat करके I never go कि एक रीडिंग की and then हमने कर लिया. हमने कभी ऐसे नहीं किया.
तो मैडम दोनों जब आती हैं तो where you go first, मतलब ऑप्टिकल भी आपने की और अल्ट्रासोनिक भी की.
It has to match. ऑप्टिकल और अल्ट्रासोनिक एक चीज़ है ना. जब हम मैनुअली कैलकुलेट करते हैं, आपने एक्सियल लेंथ डिफरेंट चीज़ों से करके कर ली, आपने AC डेप्थ डिफरेंट चीज़ों से कंपेयर की. हमने कंपेयर करना है बेसिकली. जब आपने वो भी कंपेयर किया, आपने वो भी कंपेयर किया, AC डेप्थ भी डाली, लेंस थिकनेस भी डाली, आप जब सारे पैरामीटर्स डाल के एंड परफेक्ट फार्मूला लगा के आप जब कैलकुलेट कर रहे हैं तो फिर रिफ्रैक्टिव सरप्राइज होना नहीं चाहिए. सो मोनोफोकल में एक दफ़ा मोनोफोकल की बात कर रही हूँ. आई डिड मैनुअल, और मैंने भी खुद नहीं की थी, मेरे असिस्टेंट ने की, और वो जैसे रूटीन में एक चल रहा था. एंड आई हैड ए सरप्राइज ऑफ 4.5 diopters. I had to do IOL exchange, and that was the turning point in my life. I never rely on my assistants. मैं खुद करती हूँ, और प्रीमियम IOLs पे तो मैं खुद, और एक रीडिंग पे मैं कभी रिलाई नहीं करती, क्योंकि एक दफ़ा मैंने IOL exchange किया और वो I kept on cursing myself कि मैंने क्यों नहीं किया. तो मैं always I check, मैं I don't rely on other things. तो इसका तो आंसर ये है कि एक दफ़ा मोनोफोकल के साथ हो चुका है. I don't want to risk it with trifocals. प्रीमियम IOLs के साथ. और मैं ऑक्यूलर सरफेस, वो भी आप शायद लेट आए हैं, हमने वो सारी चीज़ें डिस्कस की.
सुना है सारा
सुना है. तो वो हम सारी चीज़ें करके पेशेंट को रिपीट बुला के दोबारा से टोपोग्राफीज रिपीट करके आई ऑलवेज मैच कि प्रीवियस एंड इसमें कोई चेंज तो नहीं आ रही. टोपोग्राफीज एंड एवरीथिंग आई काउंटर चेक ट्वाइस, एटलीस्ट ट्वाइस.
और मैडम अगर एस्टिग्मेटिज्म है प्री ऑप, तो कितने एस्टिग्मेटिज्म को आप इग्नोर कर देती हैं मल्टीफोकल आईओएल के लिए?
इफ़ इट इज़ 0.7 एंड लेस, तो फिर हम उसको इग्नोर कर सकते हैं विद द रूल. अगर 0.7 से ज़्यादा है अप टू 1.5, वी नॉर्मली गो फॉर LRIs अगर कॉर्नियल टोपोग्राफी इज़ फाइन. और अगर उससे ज़्यादा है तो वी गो फॉर टोरिक IOLs और ट्राइफोकल टोरिक IOLs.
And what is the price for ICLs, phakic ICLs?
Phakic ICL is very expensive. Not all can afford it. हम ऑप्शन ज़रूर देते हैं. मैं ऐसे नहीं करती कि अगर कोई पेशेंट -11 है एंड ही वांट्स कि आप मेरा आधा ट्रीट कर दें, कि -5 ट्रीट हो रहा है वो ट्रीट कर दें, ऐनक पतली हो जाएगी. आई नेवर डू दैट, क्योंकि आई डोंट एग्री टू इट कि वो आपने थोड़ी सी ऐनक पतली कर दी तो उसका क्या फ़ायदा हुआ. सो बिकॉज इट्स ए कॉस्मेटिक प्रोसीजर, इट्स नॉट ए थेरेप्यूटिक प्रोसीजर. So I always give option. Patient has always come back. ऐसे नहीं हुआ कि हमारे पेशेंट्स वापस ना आए. वो अगर उस वक्त नहीं आते तो वो साल के बाद आ जाते हैं, 2 साल के बाद आ जाते हैं. लेकिन पेशेंट्स आ जाते हैं जिनकी अगर आप प्रॉपर काउंसलिंग करें जो उनके लिए ठीक नहीं है, तो हाउ कैन यू लीव -7 और -8 एंड ट्रीट -4 एंड -5? ऐसे कैसे हो सकता है? तो फेक ICL इज़, आई बिल्कुल एग्री, इट्स वेरी एक्सपेंसिव.
और मैडम किसी पेशेंट के अंदर जिसमें एक्सियल लेंथ कम थी, शॉर्ट आइज थी, हाइपर मैडम, क्या उसमें PI करके भी मल्टीफोकल डाला जा सकता है, पेरिफेरल आयरेक्टमी करके या सर्जिकल या लेज़र से?
इन हाइपरोपिक पेशेंट PI, if you talk of literature, so उन्होंने इसके ऊपर बात की हुई है कि हम ट्राइफोकल PI कर लें, लेकिन अभी जितना न्यू लिटरेचर मैंने रीड किया उसमें PI की बात नहीं होती है. तो जो केसेस विच आई हैव डन, आई हैवंट डन PI, क्योंकि इट इज़ ऑलरेडी इंक्रीजिंग द AC डेप्थ. जब आप सर्जरी कर देते हैं तो आप लेंस निकाल दिया तो वो AC डेप्थ ऑटोमेटिकली आपका ज़्यादा हो जाता है, तो उसमें IOP वैसे ही थोड़ा कम हो जाता है. तो आई हैवंट डन PI माई सेल्फ, अगर आप मेरे से पूछ रहे हैं तो. आई डोंट नो, आर यू फॉलोइंग PI?
मैडम मैं क्वेश्चन यही कर रहा था कि किसी के अंदर AC डेप्थ कम होती है प्री ऑपरेटिवली, तो हम सर्जिकल PI पहले से कर देते हैं पर ऑपरेटिवली, ताकि प्रेशर
अच्छा,
रेज ना हो.
से पहले की बात कर रहे हैं जी.
पहले कर लें और फिर उसके बाद ऑप्ट करें सर्जरी, यानी ज़ाहिर प्लान करेंगे ताकि पर ऑपरेटिवली इश्यूज कम से कम हो, आयरस प्रोलैप्स ना हो, AC डेप्थ एकदम से शॉर्ट होने से इंट्राओकुलर
You
प्रेशर
can
ना
give
increase हो.
mannitol, you can give AZM, you can give pre-operative. Normally इस तरह के पेशेंट्स में मैं 3 days before एंटी ग्लूकोमा कुछ ना कुछ दे देती हूँ, AZM दे देती हूँ, पर ऑप मैनिटॉल लगा देती हूँ, जिनका मुझे शक होता है कि उनका IOP ज़्यादा होगा, स्पेशली यंग पेशेंट्स, उनमें मैं ये प्रोटोकॉल फॉलो कर लेती हूँ.
So whether you prefer topical anesthesia or local in these patients?
टॉपिकल, अगर ओल्डर पेशेंट है तो टॉपिकल विद ऑल दिस प्रोटोकॉल. अगर यंग पेशेंट है तो देन यू, आई वुड प्रेफर GA समटाइम्स. एक पेशेंट में मैंने GA में भी किया हुआ है क्योंकि वो बहुत एंशियस था और उसका कंट्रोल ही नहीं हो रहा था, सो आई हैड टू डू इट. 30s में पेशेंट, लेकिन नॉर्मली टॉपिकल, नॉट लोकल. लोकल से तो और प्रेशर ज़्यादा हो जाता है, वो विच आई डोंट लाइक एट ऑल. टॉपिकल मोस्टली.
Thank you, madam.
थैंक यू.